Well, good morning. I'd like to welcome you to the 2020 CU Sports Medicine Fall Symposium. And for the first time, we are all joining on Zoom. And I really appreciate you making it. I know people will be filtering in over the next several minutes. There are a couple housekeeping items that I want to go through, and I'll go through those with you as we look at this. Please understand that you'll be muted and your camera will be disabled. It's not like a normal Zoom. If you have any questions for the speakers, enter them into the question and answer feature that is on your screen. Please list the speaker's name and then your question. We'll try to get to those at the end of each session. You're welcome to join in the breaks. We'll have some wellness break guided by our staff at CU Sports Medicine Performance Center. And remember that the session will be recorded. Remember to get your continuing education credits, both from the AMA as well as from the Athletic Trainer Association with evidence-based CEUs. There will be a questionnaire that will be sent out, evaluation of the whole seminar. So please do that. You have until the October 11th to complete the course evaluation, and certificates will be mailed to you after that. I want to save the date. In a month, there is going to be a great foot and ankle session for physical therapists as well as physicians, PAs, and anyone interested, athletic trainers. That information Ellen can get to you. Should be terrific. It will be also it'll be virtual. And then next year, similar time of year, Friday, September 10th, 2021, we will be having our annual Sports Medicine Symposium, and we hope we're all in person in the stadium as we are now. Again, I want to welcome everybody. Again, we should be in the stadium right behind me like we see, but unfortunately we're not. But we still have a great day. It's going to be terrific in everything that we have going on. I want to go through a little bit of what we have going on, and it really should be a lot of fun. And please allow me to show you this as we go through. The next is the want to really thank the sponsors. We have some terrific sponsors, and this include Arthrex, Gemini Mountain Medical, which is the local distributor, Bragg, Donjoy, a DJO, Horizon Prosthetics, Oser, Smith & Nephew, Stryker, Wright Medical, and Zimmer Biomed. So without these sponsors, we couldn't keep the cost so low, as there is an expense to put this on and also get the credits for education. So once again, it's a pleasure to have you. We'll just go through a brief outline. We're going to have some really great shoulder topics from 7 to 7:55. Then we're going to talk about shoulder instability. We're going to have a wellness break, a nice long one, so you can get up and do whatever you need to do. Maybe get something to eat and drink. Then we'll talk about the rotator cuff, and then you don't want to miss the keynote lecture. Dr. John Kelly is going to tell us how to stay energized for a lifetime. He's talks a lot about stress management and has a lot of just pearls of wisdom. So I really encourage you to be on for that. And at 11:30, we'll speak about elbow. And then at 12:20 to 1:10, we'll wrap it up with some really terrific topics on biologics, biceps, and also youth athletics. So I want to thank the faculty. They're chosen for their expertise, their knowledge, teaching, ability to interact, and as you'll see, just all around great people. And that's what's important for this. These are some faculty disclosures that are seen right here that faculty have listed. And now it's my pleasure to introduce Coach Richard Rokos. He's the University of Colorado head ski coach. He recently announced that this will be his last year of being the head ski coach. He's done it for almost 30 years. He's been at the University of Colorado almost 35 years. He has 8 national championships, just short of John Wooden, who had 10 national championships in basketball. He has 42 individual NCAA champions and 225 All-Americans through his tenure. He's a great teacher, instructor, mentor, and he also pretends to be a doctor. And it is with that every year for the past almost decade, we've had the opportunity to have Richard come on and give us the invocation. And for that reason, we will have him go now. Richard, please give us the invocation.
Thank you. Thank you, everybody. Good morning. And as always, this is my great honor to be able to address this convention. It has been 17, 18 years, I don't even remember, but it's year after year, fantastic event. And I have friends coming from Europe attending this for years. And unfortunately, this is the year they cannot come. But again, it's an honor to be here, have an opportunity to talk to you and everybody. As a coach, I have to admit that we are always on receiving end of your profession. While you are doing your professional job, we are sweating over the results of surgery, and we are hoping for best outcome of any therapy and anything what relates to injuries, and mainly how to prevent those. And for me, being part of it and having opportunity to go to surgeries with Dr. McCarty and see really on-hand job, it's fantastic, and I appreciate every opportunity. I wish more coaches are using this in-depth knowledge of human body and physics and everything what involves our profession. On personal note, I would like to welcome everybody, and also my granddaughter. She's aspiring hopefully physician or orthopedic surgeon in her life. She's attending this convention, and I'm glad to see young generation rolling in and obtaining the knowledge and getting opportunity to learn new tricks and gimmicks. We have a little exchange program with Dr. McCarty. While he's coming to my functions and delivering invocation, I would like to do it here, which is tradition. And again, it's an opportunity to share everything what we have in us. And someone might ask why we are praying or doing invocation. I believe that in this time it's more important than ever before, because we need to get people on the same note, same understanding, and God will help us, and that's why we are doing it. So please bow your head and let me start. Heavenly Father, thank you for this opportunity to get together with the brightest minds and souls in surgical orthopedic profession. We thank you for having opportunity to share the knowledge and know everything what pertains in this field of human accomplishments. I would like to ask you for giving us great guidance through the conference, have it as a successful event, and conclude it with best possible result. Thank you, and God bless to all of us. Amen.
Amen. Thank you, Richard. And as we remember this day, September 11th, hard to believe it's 20 years ago, the blessings are appreciated. Richard, thank you. Thank you for joining us, and thank you for your blessing upon this time. And let's get ready for the next 6 hours, everyone. We will start with the shoulder, and I have Dr. Braden Meyer will be the first one to speak, and Dr. Meyer will talk on evaluation of the painful shoulder. He's a great colleague of mine, joined us just a couple years ago as part of the Stephen Hawkins Clinic, which is now part of University of Colorado Department of Orthopedics, and we're very happy to have you. He spent some time in Switzerland, France, and did some extra fellowship time to learn about the shoulder. So it's all yours. Thank you, and you can start sharing your screen.
Thanks, EMAC. So I can get this shared. Good morning, everyone. Hopefully you're seeing my screen. Hopefully this is working. It's an honor to start this off for the next 6 hours with the shoulder. Nice to have the coach with us. A very cool story he had there. So I'm going to give you a quick review of a very common thing that we see in our clinic, obviously the painful shoulder that kind of rolls in, a very large part of my practice that comes. And so look forward to sharing kind of some of the wisdoms if we can. So objectives, it's a very brief overview of the anatomy, the relevant history and physical exam findings, and then we'll go through a few of the common causes of shoulder pain, kind of helps with some of the pearls. So as we know here in Colorado in our active patients, a lot of ways to injure the shoulder, whether it's traumatic, whether it's overuse. I'm seeing a influx of the quarantine patients that decide to dabble in CrossFit, and unfortunately that is not a good thing if your form is the way the guy in the lower left picture is. And then obviously our aging population, unfortunately that does kind of cause problems. Shoulder pain in general, you hear about the shoulder like the golf ball and the golf tee. I'm sure you'll hear about that more today. The unique anatomy with a lack of bony stability. And so it's important to really focus your history and physical exam because the patient will give you most of the diagnosis as they're telling you what's going on. And so they can narrow the diagnosis, and with that proper clinical evaluation, you can really disclose most causes of their pain. So really trust your hands and trust kind of what the patient is telling you. So the mechanism of injury, you really want to think about this. If they fall off a bike, you're thinking more about the clavicle or AC separations. If they got their arm twisted behind them and they felt a pop and a clunk, obviously a shoulder dislocation or something. The ever so common electrocution, I guess you may be thinking more about the posterior shoulder dislocation. And then again, if you have the aging population that's coming in, we're thinking a little bit more about rotator cuff tears. Quick overview of the anatomy. Again, we talked about the stability and the lack of bony stability. So it's really a combination of ligamentous and capsular constraints around the shoulder. There's the surrounding musculature. And the glenoid labrum is kind of that gasket seal around that golf tee. This deepens the golf tee to allow a little more stability for the humeral head. The rotator cuff, I'm going to go into more detail on this in a later talk, but the 4 rotator cuff muscles, and really their main job is to compress the humeral head to the glenoid and to keep it there. Very important, almost like a pulley system. If one pulley is out of whack, the whole thing kind of falls apart. The differential can be very long, so again, very important to listen to history and physical exam to kind of narrow this down. And so part of that history is really looking at a lot of different things. One thing I think is key is if they start talking about numbness or tingling past the elbow, if they talk about bilateral shoulder pain, neck pain, you really need to focus some of your exam on the cervical spine. It could be something that's mimicking some shoulder issues. So physical exam, I don't think you can overemphasize the importance of making sure you can see both shoulders, clavicles, and upper back, so you can see both scapula. In Europe, they are not shy about letting you obviously evaluate the shoulders. Here in the United States, we're a little more modest, and so I think you need to make sure they're in the proper clothing so you can see this and kind of go through these asymmetries, these bony deformities. You're looking for the atrophy of the muscle, and the scapular winging can be pretty obvious on some patients. Palpation, it's not a huge part, but you definitely want to rule out the easy things. AC pain or sternoclavicular joint pain is very easy to rule out with general palpation. Bicipital groove pain is an area that I definitely palpate. You can work on the front and sides of the shoulder with the tuberosities. And again, don't forget about the neck. A range of motion is important, active versus passive. There's some normal ranges below, but I think the normal ranges are more looking at symmetry. If someone has a normal forward elevation on their normal shoulder of 160, I'm not worried about them getting to 170 on the other side. And then don't forget about the compensation from the scapula it can definitely throw you off, and patients will try to prove to you that they have good range of motion by doing the lean and the kind of throw the arm over their head as best they can, even though the glenohumeral joint may be very stiff. Strength testing is a very important part of this, testing the supraspinatus and the plane of the scapula, the infraspinatus with the arm at the side, testing external rotation. Teres minor can be tested more with 90 degrees of abduction, the so-called hornblower sign, and then the subscapularis with belly press and liftoffs. We'll go through these in a little more detail later on. Special tests are very important when you're thinking about more specific diagnoses that you can see here. We're going to go through each of these really quickly. When you're thinking about a patient with shoulder pain and rotator cuff pathology, usually the younger patient will have a traumatic event. They may feel a pop from lifting something heavy or a fall or an injury. In our older population, we're usually seeing a more gradual onset of this pain. For shoulder impingement exactly what it is. It's the rotator cuff being impinged underneath the acromion in certain positions. There's these two tests, the NEAR and the Hawkins test, which are tests that we use pretty routinely for impingement. NEAR's test, if you think about, for all the Karate Kid fans, if you're trying to stain the fence and on the way up, the hand is pronated and internally rotated, and passively you bring the shoulder all the way up, and usually they will have shoulder pain at the extremes of this motion. And the Hawkins test, which I think is a little more specific for me, taking the arm at 90 degrees and doing kind of a forceful internal rotation. You can bring the arm to straight abduction, you can bring into AD deduction in different positions. And again, you're trying to pinch that rotator cuff underneath the acromion, causing shoulder pain with this. Biceps tendinopathy is very common with our athletes, overhead athletes, and just kind of wear and tear with weightlifting. Speeds and Jurgensen's are kind of the ones we'll see the most, with Speeds being this resisted forward flexion with forearm supination. So you can see here, be a little careful pushing hard with this. Unfortunately, you hear some horror stories about the rupture of the biceps in clinic. Good thing is their pain goes away. You fix the problem. Unfortunately, it's probably scary not only for the patient, but for the doctor as well. So, but something, if they get pain localized over the bicipital groove, this would be an important positive test for this. Looking at all these tests, there's some research looking at the Speeds and Jurgensen's for biceps pathology, and then comparing it to the time of surgery. And unfortunately, these are not perfect. As you can see, Speeds test is 75% specific, Jurgensen's 79%, pretty low sensitivity, not great predictive value. However, we put these all together with your clinical examination and history, and it can help make the diagnosis. Adhesive capsulitis, I'm not going to go into too much detail. Dr. Wolco is going to give us a talk next about this, but really focus on the loss of active and passive range of motion. I focus really on external rotation at their side. If they've lost external rotation, that kind of keys me in some capsular tightness. And again, look at their scapular asymmetry for the due to the stiffness of the glenohumeral joint. AC joint disease is easily ruled out. It should be tested on every patient. Just localized pain over the acromioclavicular joint. The cross arm adduction test causes compression at the AC joint and will cause pain. So this should be documented. Unfortunately, you see a lot on MRIs and X-rays of patients telling you they have AC arthritis. Unfortunately, it's most commonly not the source of their pain. So just document that to make sure. Shoulder instability, we see it a ton. Unfortunately, you have to kind of rule out what this instability is. Again, we're going to hear a lot about this in the next session of the talk, but I think it's important to make sure you're ruling out patients that are hyperlax. The Bateman criteria for hypermobility, something that you look over and make sure you're kind of looking at. The apprehension relocation test, very important test for anterior instability. And talking to patients about the history. Is this recurrent? Is this the first time dislocation? Was it traumatic, or did the shoulder just fall out in your sleep? All very important things to rule this out. For SLAP lesions, again, probably something that's diagnosed more on radiographs than anything else with MRIs. We see it a lot in overhead athletes. Be a little careful. It's not always the source of the pain. I think O'Brien's test is a great test to test the SLAP lesion. It's where the biceps, long head biceps tendon is attaching to the glenoid and the labrum. This is a patient here with their arm adducted and internally rotated, and then you test their strength in this position. This puts tension on that glenoid and biceps, and they'll have pain. A positive test, however, is when they supinate the forearm or fully externally rotate the arm, their pain goes away. And so that can be something to really put down as a positive finding. Glenohumeral joint DJD, or just arthritis in general, they'll have a painful arc of motion, they'll have crepitance and really gradual loss of motion. As you can see, that top X-ray is a normal shoulder with a round peg and a round hole. As the shoulder becomes more arthritic, the ball becomes flat, there's large bone spurs, you get more of a square peg and a square hole, and unfortunately that causes significant mechanical issues with the shoulder. Just very briefly on imaging before I get to hook, but X-rays are very important. AP and AP oblique, which is kind of a straight glenoid view, which is a Grachet view, a scapular Y, and the axillary lateral, unfortunately, gets missed sometimes in some of the trauma series we see in ERs and urgent cares. This is a patient who came into my clinic. He's 3 weeks out from a shoulder injury. He has seizure disorder, went into an emergency room, was told based on this X-ray his shoulder was fine to go see a orthopedic surgeon. Shows up 3 weeks later, unfortunately, into my clinic. We get an axillary lateral view, and what we see here is he's a posterior shoulder dislocation, easily missed with only one X-ray or not getting the proper X-rays. MRI is really our go-to for shoulder pain injuries, improved accuracy with our better magnets. Really important to correlate your MRI findings with clinical examination. Patients will come in for a second opinion with their MRI reads, highlighted, circled, everything that's positive on there. However, probably and most commonly is not the source of their pain based on their history and physical examination. My go-to to get MRI, traumatic event with weakness and loss of range of motion. They've had previous surgery. I tend to lean a little more towards getting an MRI sooner, and obviously they failed conservative treatment. And then CT scans more for the bony deformities and fractures, really focusing on glenoid morphology, maybe for instability, and then surgical planning. As you can see, 3D recons have become very important in our practice. Looking at the morphology, here's a fractured shoulder. Obviously, the 3D recon really tells us what we're getting ourselves into. So this conclusion, really make sure you narrow your diagnosis with a thorough history and physical exam. You're going to diagnose most injuries and a lot of their pain if you really listen to the patient, and then try to correlate your exam findings with any imaging that you get from this. I appreciate everybody and look forward to the rest of the talks.
Hey, thank you, Braden. Excellent job. And as always, really appreciate you. And next we have Michelle Wolcott. She's been a great colleague and partner of mine for the past 17 years at the University of Colorado. Is head team physician for CU basketball and has been a team physician for University of Denver, the University of Colorado, and also Mammoth and the Nuggets. So Michelle's going to talk on adhesive capsulitis, the great imitator. And Michelle, we look forward to hearing why it's the great imitator.
You guys can hear me. Thumbs up, can hear me? All right, so I'm going to talk about adhesive capsulitis. It is the great imitator, and some of the things that Dr. Meyer just talked about can seem more obvious when you get a little bit better physical exam and a history, but there are times when that's not very easy to distinguish. So we're going to go through adhesive capsulitis and discuss when that is a more obvious diagnosis. So the definition of adhesive capsulitis is a gradual loss of both active and passive range of motion, specifically the glenohumeral joint. Codman originally described this as tendinitis, which involved bursa and spasm, which we understand really probably is not the pathology, but Navazier and Joe Hannafin have really described this more as a continuum of a pathologic lesion that starts with inflammation of the glenohumeral capsule, followed by fibrosis, and then capsular contracture and thawing or loosening up. So most patients who present with this come in with a fairly similar story, but it only occurs in about 2 to 5% of the population. Women far more likely to get this than men, typically in that age range between 40 and 60. Interestingly, a lot of patients who get this and recover from it will develop it in the other side. There may be some obvious reasons for that, there may not be. And very often it happens in the non-dominant arm. So whereas you may see things like a rotator cuff tear injury, tendinitis, or more acute injuries in the dominant arm, this can often be in the non-dominant arm. The risk factors for adhesive capsulitis, I think we're all very familiar with the risk factor associated with diabetes, but it can also be associated with thyroid dysfunction, certain types of cancer such as breast cancer, possibly autoimmune diseases, cardiovascular diseases, and a certain percentage of patients will actually describe there was some inciting event or trauma or incident that started this process. And so you can be confused a little bit by that as well. But primary adhesive capsulitis, which is a little bit different, is idiopathic. We don't really understand what starts it, but it starts with inflammation of the capsule, followed by fibrosis, and there's really not another explanation or reason for why this is occurring. That'll be a more primary type of capsulitis. But secondary adhesive capsulitis, which probably as surgeons we may be a little bit more familiar with, is typically as a result of something else. Sometimes it's calcific tendinitis, sometimes it's rotator cuff disease, sometimes biceps tendinitis, arthritis, which is very common because you do lose glenohumeral motion with both arthritis and adhesive capsulitis, and then sometimes after surgery. So in these incidents where it can look like or mimic these other things, we need to treat the underlying pathology if it's there, and if not, then consider it being a primary form of adhesive capsulitis. So the stages of adhesive capsulitis, as I said, it's really a continuum. Sometimes it's really hard to go through the literature on this because there's so much variability in when it's being reported and what type of treatment is being given at what stage. So it's a little bit controversial what the ultimate course of this is going to be, but it does tend to follow a pretty consistent continuum, and we'll go through that. So stage 1 is really kind of a gradual onset of pain. People will just tell you it started to hurt or ache. It's often referred to the deltoid insertion. It's usually achy at wrist, but can be worse with movement. Oftentimes pain at night. It's hard to sleep on that side. Usually it's limited in duration. Typically when you're in this stage, it's less than 3 months, although that varies quite a bit. Pain is difficult to palpate, and they have pain with passive motion. And everything I just listed there could be associated with almost any shoulder pathology. So this is one of the reasons it can be difficult to identify this as the pathology and why it's considered a great imitator. But in stage 1, what's happening is they're starting to lose a little bit of, as Dr. Meyer pointed out, external rotation specifically. The rotator cuff is usually intact, meaning that their strength is intact. And if you, at this stage, inject just lidocaine or any type of intra-articular anesthetic, you can restore that motion pretty easily. It's pain that's causing the limitation. You can do diagnostic testing at this stage, and often do, because you're not certain if it may be something else or one of those other pathologies. So very often you'll be doing MRIs and things in this stage, and it can be hard to interpret that. But what you'll see if you scope someone in this stage is a lot of inflammation, all that hyperemia, erythema, especially throughout the capsule. You may see a little bit of contracture or loss of some of the capsular space, but typically not. We don't often scope people at this stage, so it's a little bit unusual to see it, but you may incidentally scope someone because there's some other concomitant pathology and see this. And histologically, if you take a biopsy, what you'll see is a lot of inflammatory markers, inflammatory cells, hypervascularity, a lot of synovitis, but the capsule itself will typically appear fairly normal, and that's because it's early in the stage. Stage 2, which is the freezing stage. In that stage, the pain is persistent. It could be getting worse, it may not be. Usually the motion is decreasing, so typical for when something is freezing, it's starting to get tighter. Most often you'll see this, I would say, in internal and external rotation, most typically external, but then forward flexion, abduction, but that can be later, and that mimics a lot of other diseases. And at this stage, sometimes you can get some of the range of motion back, but typically not completely. If you try an injection, they'll still have sort of a hard stop or a tethered feeling when you try to range them. So what stage 2 looks like is arthroscopically, you start to see thickening. Some of that, it's starting to turn a little bit more white. You might see synovitis, such as this on the top right, this Christmas tree appearance, which is these large fronds of synovium. The axillary patch will start to be obliterated. So when you're trying to get down there inferiorly, there's less room just to get your scope down there. And histologically, you'll see more of this hypertrophy at this point. That hypervascular synovitis that you see in the top right, you can see in the very bottom slide histologically, and you'll start to see blood vessels forming around that synovium. And it could start to now look, the capsule can start to look more fibrotic in this stage. Stage 3 is really the frozen stage, and most people will come in complaining not that much of pain, but now it's just very, very stiff. Pain may be more obvious when you're really at the end range. So when you really force them into external rotation, internal rotation, abduction, it hurts just at the end of that. And usually it'll be more of a solid block, so it'll feel like it just stops. Things like loose bodies and mechanical things in the shoulder are not that common. So if I see sort of a solid block with motion and it fits some of the other descriptions, I'm considering it more likely to be adhesive capsulitis. And if you inject them just with lidocaine at this point, you typically don't see much improvement in motion. Usually this is later stage in the 9 to 18 month time frame, and oftentimes we won't see a patient until this point. Arthroscopically, really difficult to see. Sometimes you put a scope in there, and if you haven't done any kind of manipulation at this point, it's hard to really tell where you are. You just see a lot of white, dense tissue. Histologically, it's very, very dense. It's hypercellular. It looks very, very fibrotic, and the synovium is much thinner. So instead of seeing those inflammatory and vascular areas, you're just seeing sort of a sheet of dense fibrotic cells, which you can see on the bottom of the histologic side. On the right in the cartoon, this is just showing how that axillary pouch sort of disappears and how the capsule tightens up. In stage 4, the thawing stage, really typically won't have that much pain. They may gradually start to improve their motion. Depending on how often you see them, this may seem gradual to you. This may seem like it takes forever, but it is oftentimes very, very slow. And this can be difficult to manage just because the expectations from both the providers and the patients are much higher than how long this can take. In the stage 4 or thawing stage, oftentimes arthroscopically, you really don't see that narrowing of the capsule, but you see that dense white, just scarred looking capsule. You might see some obliteration of the joint space depending on when you get in there, you may not. But histologically, because this is a hard stage to identify, there's not really a good accurate description of what this looks like. So I don't have information on that, but I think you can probably assume that you're going to see those mature fibrotic bands with less vascularity and really less active inflammation going on. So the natural history historically has been described as self-limiting, but that's pretty difficult to interpret. Most studies that you look at will describe some type of treatment, so that it's rare that we just leave people alone and do nothing. So it's difficult to know if that's actually effective treatment, but historically has been described to be. There's a lot of studies on this, and a lot of the levels of evidence are fairly anecdotal. In general, most of the studies do point to the fact that if you do little, meaning reassure anti-inflammatories, they will get better without any intervention. Particularly early on, a lot of people will do physical therapy and sometimes and passive motion. Sometimes that can aggravate symptoms, and sometimes it's very helpful. So when you look through this, it's hard to know when the right time to do therapy is. So I do typically include therapy as part of this protocol, but I think the timing of it and this type of therapy is very important, especially for the right outcome or improvement that patients can start to buy into. So most of the time, these studies rely on patient-based outcomes that tend to be more favorable, but physician-based outcomes or objective-based outcomes tend to be less favorable. And I think part of that probably has to do with, as physicians, as surgeons, we want our patients to get better, and it's very, very difficult to just sit and wait in this situation. But the treatment still is somewhat controversial. Generally, if patients have prolonged pain, disability, and limitation of function, we do something. And I will say that that has changed over the course of my career dramatically, where we were more reassuring early on. I think more and more patients demand some type of intervention at some point, typically earlier on. So really optimizing the treatment depends on knowing what stage of disease you're in and providing the intervention that's appropriate to that stage. Non-operative treatment, anti-inflammatories can be helpful when they're in the inflammatory stage, so in stage 1 or 2, but it doesn't really change the natural course. It just makes their symptoms a bit better through that portion. Oral steroids can give more rapid relief, but they don't necessarily alter the course either. None of the studies really distinguish the stage of the disease at the time of treatment. So again, this is difficult to interpret, but we'll apply some principles to this. Intra-articular steroid injections, I found this to be very, very helpful, particularly if they're in the early inflammatory stages, stage 1 or 2. A lot of variability in the evidence for this, but if you think about the pathology and the fact that this is inflammation, decreasing inflammation can really just help your patients feel more comfortable. May also help them tolerate physical therapy better. Steroid injections in earlier stages seem to be more effective because you're treating inflammation rather than the fibrosis and the scarring. So physical therapy almost any intervention supports using physical therapy, and almost all of them get some. Physical therapy alone doesn't necessarily do better than physical therapy with other interventions and may actually do worse. Particularly if you push them to the level of pain, they may get a rebound, more inflammation and more pain, and then they don't move as much because it hurts. May not be actually worsening the process, but maybe limiting the patient in terms of their anticipation of getting better. So gentle stretching, active motion, staying in pain-free zones seem to be more efficient or more sufficient than doing anything painful. Operative intervention is a bit, I would say, controversial. Most of the time, if things have been going on for a long period of time, and I won't define that, most of the time that's defined by both the surgeon and the patient, they may end up getting some type of operative intervention. And about 10% of patients won't respond to anything other than operative intervention, so not a high percentage. And indications for invasive treatments such as surgery are more subjective, individualized, and I would say controversial. Superscapular nerve blocks. This has gotten some attention because what you're doing is interfering with their perception of pain, which can allow them to participate in things like physical therapy a little bit better, or to be patient if you think that the natural course is that it will get better on its own. And it does work for pain, but it doesn't necessarily work for improvements in function or to alter the speed or the process of the disease. Hydrodilation, I think this is something that Dr. Hill is going to speak in a little bit, has done quite often in our patients in our clinic. And I found this to be very, very effective, particularly in that stage 2 or maybe late stage 1. If you do this with a steroid, with lidocaine, and with a high volume of saline, you can actually distend that capsule and increase their range of motion pretty quickly, similar to what you would do in a manipulation or potentially arthroscopically. So it increases the capsular pressure. It may rupture the capsule, which is what you're essentially intending to do. If you have experienced practitioners, which we do with Dr. Hill and Dr. Spittler, who've been doing this for us for a long time, it really is effective, and I've been really happy with this. But not a lot of data on this, and I think because it varies so much in terms of how the practitioner technique is, that you really want to get someone who's familiar with this and does it well. Manipulation. Consistently, there's good results with manipulation, but I think considering the potential complications, particularly if you have an older patient who may have lower bone density, fractures can happen. You can rupture the subscap, the labrum, the biceps. None of those are necessarily common, and I would say fractures what we worry about the most. And so if you're doing a manipulation, you want to be doing more of a gentle manipulation, maybe a bit more than what the therapist can do in an awake patient. But this is something that does work, particularly if you don't have to do anything that requires a significant amount of force. And in that case, you're going to consider intervention. But it is a good modality, excuse me, and they typically do get range of motion better earlier with manipulation. I'll skip through some of those studies and go straight to arthroscopy. I don't do this very often. I don't know how many of my partners that do more shoulder surgery really do this, but it can be done with or without a manipulation. I think most people who do this will scope first, do a capsular release, and then manipulate to sort of get those end ranges. It's a little bit controversial which one you should do first, and I would say in my hands, if I can't get the scope in or they're very, very tight, doing a small gentle manipulation first may help you get the scope in, but then I think it's a bit safer to do your capsular release and then do one more, I don't want to say aggressive, but more significant manipulation after that. You can do a synovectomy, remove some of that inflamed synovium. You don't want to cause a lot of scarring because you may get a bit of a rebound, but arthroscopy can be very beneficial in more refractory cases. Basically, I just summarized what some of these studies say, and you'll have these slides. You can look these up if you'd like. How much capsule to release is a little bit dependent on the treating surgeon. I think you want to release enough capsule to allow a normal range of motion within a functional range. It doesn't have to be exactly symmetric to the other side. You can get a little bit more stretch with manipulating it after you do the release. So this is very individualized and surgeon by surgeon. Open releases are almost, I want to say, never performed unless there's some other pathology going on. So if you have some type of trauma that's ended up in adhesive capsulitis as a secondary cause, you may need to go in and do an open type of release, but this is very uncommon, and I would not do this in a diabetic because the chances of them having even more stiffness are much, much higher after an open release. So algorithmic treatment, I kind of went through this already, but basically in stage 1 to 2 disease, I'll do a steroid injection or a hydrodilation injection if they're really getting tight. Oral anti-inflammatories can be helpful if they're not contraindicated. Physical therapy within pain tolerance and home exercises. In stage 3, we'll do physical therapy to continue to mobilize them a bit using heat, passive stretch, active warm-up. I would say I do a lot of reassurance in stage 3. You can push the motion a little bit because they're not as painful, and hydrodilation may be helpful here. At stage 4, it's the same as stage 3, but then you're going to start considering intervention, whether it's a arthroscopy, manipulation, or combination of the two. It needs to be very individualized. If you have a patient who can be patient, sometimes you can wait a little bit longer. But if you do any of these interventions, you want to follow that up with therapy right away. So in conclusion, the treatment of this is still a bit controversial, but there is a linear algorithmic approach to this. Most of the literature is not very helpful to inform what type of treatment, but you can use principles of treatment to help guide you. Clinical stages are very, very important in this. I like intra-articular steroids and hydrodilation in early stages. Manipulation can be effective, arthroscopy can be effective, but we need a little bit more higher level studies, less opinion and less anecdotal evidence to really understand the appropriate treatment. Thank you.
Thank you, Michelle. Excellent talk, and that's a necessary talk that we all need to hear. It's a great imitator. So, hey, it's a great pleasure next to have John Hill. Dr. John Hill is just one of our great colleagues that is really an interesting guy. He has done a lot of neat things. Just recently wrote a book that it's called All In. And Dr. Hill is a team physician for University of Denver. Is going to talk to us about how do we use ultrasound to treat the painful conditions. So John, thank you for joining us.
Okay, thank you very much. We're going to look at some of the different examples here with it. Can you see my screen? Let me just make sure I've got that right, correct on here. And I'm not sure if I'm picking up on there or not.
So while John is trying to figure this out, I just have to say that John was one of the really early adopters of ultrasound for conditions, and he first learned as an OB and then practiced on a lot of people and started to figure out what he could do with the musculoskeletal system. And so we're really fortunate to have him as one of our guests, but also one of our colleagues and one of the really true innovators. John, do you need a little help from the IT guys? Should we go to the next talk and then come back? What do you think?
Yeah, that might work out because I had everything all set and then I screwed it up. So let me, we'll go to the next talk and then I'll pick up on that one. So I apologize for that.
Hey, no problem. And maybe Ellen can reach out and they can reach out to you. All right. So what we'll do, Ellen, if Ellen Shanley, if you're ready, Ellen, we're going to go straight to you. And Ellen Shanley is a guest of ours today. She comes from the University of South Carolina, but Greenville, South Carolina is a terrific clinician, but also researcher. She has her doctorate and also a physical therapist, is part of ATI and has done a lot of neat studies. Has been the past president of the American Shoulder and Elbow Therapist. And Ellen, if you're ready, Ellen Shanley, we could get you on and start your video, please.
Sure, I think you should be able to see my screen now.
Yeah, we can see it. Thank you.
Great. So I want to thank Dr. McCarty for inviting me here to talk today. It's a great pleasure. I wish I was out there in person, but hopefully maybe next year. So today the topic of my talk is really physical therapy for the painful shoulder. I have some disclosures which Dr. McCarty helped me with. So let's get on to the talk. Luckily, the shoulder is not complex at all. And obviously I'm kidding. When you look at the anatomy of the shoulder, it's oftentimes very difficult to figure out exactly why the shoulder is painful. And then you put in the anatomy of the upper quarter, the angles that we have to deal with, and it makes it much more complex. So really how we start is when we're approached by a patient with shoulder pain is really a careful examination that was given to us by Dr. Meyer, really focusing on what are the things that can bring us to a better outcome for this patient. And so for me, if we focus on the basic science, it always helps me to sort of plan my treatment by focusing on first, what structures really are able to or are most painful in the shoulder based on their sensory, sympathetic, and substance P fibers. Then thinking about the complex movements, the functional independence with ADLs and our daily demands, and some of the biopsychosocial factors that we have to deal with. If you look at the pathology, which we're describing today, really some pathologies are associated with higher levels of pain and some with lower levels of pain as a common symptom. And then there are pathologies that really span the spectrum of how much pain the patient usually presents with, like osteoarthritis, depending on the stage. But whenever we magnify the load or increase the load to that shoulder, regardless of pathology, it normally will increase the symptoms of increased pain and decreased function. So we can take some of the information that the patient gives us, and we know that certain patients typically present with certain pathologies, but we still need to go through our process, which is clarifying that the pain that the patient is feeling in the shoulder is from a musculoskeletal, not medical cause, and then it's somehow associated with movement. So the willingness to move is often a key factor in our examination. We're looking for global and local patterns of pain and local patterns of impairment, as well as overall joint function. And these really help us to clarify the profile of the patient and the expectations we can have with treatments that we deliver. So our focus really needs to be on not only the pain, but the impairments the patient presents with. And I think this is a really good paradigm that's helped me approach people with generalized shoulder pain, the impact of the level of irritability on the patient. So this was presented in a 2013 JOSPT article by Kelly and colleagues, which was the first CPG put out by the American Physical Therapy Association. It really characterizes what level of irritability the patient approaches us with or appears in our clinic with, and talks about their level of pain, what is associated with that level of pain. And we can, of course, see that their impairments are greater with the highest level of irritability. But not only do we want to think about the level of irritability when the patient appears for their first evaluation, but really how they progress through this process. And we want to match the treatment then to the level of irritability. This algorithm is also included in that 2013 article and really talks about the highest level of irritability is best matched with more passive treatments that can be progressed to active treatments within acceptable symptoms. And as we progress, we can do more active treatments and approach more of the specific deficits that people have. And in the areas of low irritability, we can really be aggressive in having the person do some of their own self-care stretching exercises and progress to neuromuscular re-education. But not all people present with a clear-cut level of irritability. There's some people that just don't fit this pattern of high, moderate to low or low level of irritability. There are people that have really good full function for ADLs and basic activities, but then present with significant impairment and high levels of pain associated with higher levels of activity. So for instance, when a worker approaches you with a primary complaint of really significant limitations at work, they may have full function at home and deny any problems in their daily life. So this is the story of a 46-year-old right-hand dominant male who presented 6 months after he had an acute episode at work. He had 6 months of continuous and increasing pain with work, but he was a self-employed landscape designer, which required him to work every day in order to pay his bills. He had pain-limited overhead work, so he wasn't able to work consistently at 120 degrees of elevation or greater. And he showed increasing fatigue over time with his overhead work. So at work, he really had a moderate level of irritability, but the rest of his life was really he functioned at a low level of irritability. His symptoms were pain with overhead work. His signs were decreased glenohumeral joint range of motion, decreased thoracic spine and rib mobility, poor motor control and endurance, especially of his posterior musculature, scapular dyskinesis, which was aided by a scapular assistance test, impaired function, really increased night pain, a VAS score at rest of 3, but at work at 8 to 9. His PEN score was 92 and his SANE score was 35. His pain really was generalized throughout the shoulder, but primarily anterior type shoulder pain. So the question was, where do we start with this gentleman? So the first and most important area was the acknowledgement of his need to work, his work issues, and to try to come up with some choices he could make to intersperse really consultation on landscape design with activities where he needed to work overhead, and really to plan his week out ahead of time so that he could manage his pain both at work and at home. And he could do some of this independently. We wanted to improve his available range of motion with him doing a foam roll and flexibility extensibility program at home, having him come in for treatment specifically to address some of his impairments in his range of motion and capsular mobility, and to improve his available range of motion. Then we progressed with motor control activities in the clinic and gave him some cues to know when he was really functioning at the highest level and still using correct motor patterns, which decreased his overall pain. His prognosis and progress. We were treating him 1 time a week. He had a huge commitment to his home exercise program and was very communicative when he needed help progressing his program. We gave him some visual and tactile cues with the program that we were able to then transfer to his landscape activities. His symptoms quickly became manageable, but they didn't really resolve until he was able to have an extended period of rest in his sort of down season. He periodically still checks in for increased intervention or change in his home exercise program. So for him, it was careful attention to detail and really giving him and equipping him with the tools that he needed to manage his shoulder pain, really regardless of the ultimate pathology. And so I feel like the combination of a really very specific examination combined with levels of irritability can really help us tailor and progress our patients so they can get back to full goal activities. Thank you.
A terrific talk, Ellen. And, you know, we are so fortunate to have you join us. And I do look forward when you come to the University of Colorado and visit us in Boulder. I know we'd love to get you here, as many of your colleagues have been here. So thank you. We look forward to another your talks as come up later. I think they'll be terrific. So thank you. All right, now we got John Hill. Can we get you back up on the screen? And I know that Ellen has your talk if you're not able to pull it up on your screen. John?
And let me see if I can get this loaded on here. Ellen, maybe I'll just have you pull it up because the button I have, I just made it vanish. I so apologize for that. And so, and then if we can make that bigger on there. And okay. Can you see my screen now when I'm advancing on there? Again, I don't have any disclosures. The objectives of this is to look at ultrasound and to accurately diagnose the pathology. Diagnostic ultrasound is quite helpful for that. And then we'll also discuss the interventions with this, as well as looking at the different procedures on that. I think I'm still having trouble with seeing my screen on there. If
you see that, John, Ellen's got your PDF on, and she's going to have to advance the slides, for you. It looks like a PDF and not actually your PowerPoint. Do you want?
I think that's what it is, and I might have just. Not sure how I've managed to mess this up when I practiced it so many times. But let's see if we can.
You got so many good things. I mean, I'll tell you what, we could go to shoulder instability, and then if you want to spend the next 30 minutes trying to figure it out. What do you think, John?
That probably would be best, because this is a total flail, and I really apologize for that. I haven't really messed up that much before, but I turn it over to you now, Eric.
All right, John. Hey, so that's what we'll do. We'll spend the next 30 minutes, and I think what we'll do because you've got such a great talk at the end of shoulder instability, I think you'll have it. And, but John, just like you've experienced in your life with so many things and so many obstacles and so many things that you've overcome, this is nothing. So, although it may be the hardest thing in your life right now. So, John Hill, thank you. I appreciate, and we'll try to get that figured out, speak to the IT, maybe you send it to them, the entire PowerPoint, and we'll go from there, okay? So what we'll do, in trying to maybe catch up with everything, and we're gonna go straight to shoulder instability. I know that Rachel Frank, I hope that you're ready to go, and that we can get you on, and we're gonna talk about evaluation of shoulder instability in the athlete. Rachel is a faculty member that joined us a few years ago from Rush. She is a team physician for University of Colorado and the Colorado Rapids. And Rachel, you ready?
Ready. All right, can you guys hear me?
Yes.
Good, and can you see the screen?
Excellent.
Perfect. Well, thank you, and EMAC, thank you so much for having me first in the program and here, at CU, and also on this program. This symposium has been terrific, at least for me, from a learning standpoint since I got here. One of the first conferences that I was able to attend and be part of as faculty here, and just super honored to be part of it. So thank you so much for that. And I'd like to acknowledge all of the CU and Stephen Hawkins faculty that are part of our sports medicine team and making us really the primary physicians for all of the pro teams here, as you can see at the bottom of the screen, and the college teams. What a great program. And finally, I'd like to thank Ellen for helping organize all of this, as she always does. And she's just terrific in so many ways. So thank you. I do have some disclosures, none of which are financially relevant to this talk, but they're available online. When we talk about shoulder instability and the evaluation of the shoulder in the athlete with shoulder instability, it really boils down into history and physical examination. And the reason is because Imaging, which we always have, is helpful and it helps complete the picture, but it doesn't tell us the story. And the story is the most important part in determining how we're going to treat these patients. So when we take a history to evaluate these patients, we've got to have a very thorough history. So we've got to understand, is their primary complaint instability, which is typically the case for anterior instability, or is it more pain, which is typically the case for posterior labral tears? Is it stiffness, or is it some combination of all the above? We've got to understand how many instability events they've had. Have they had just one or more than one? Are they dislocating or subluxating or feeling loose or slipping every day? Have they ever needed a formal reduction under anesthesia? Have they had prior treatment, including prior surgery? If so, can we get a hold of their prior operative note? Can we get a hold of their prior operative photos if they've had an arthroscopic picture? And then we've got to ask them, do you feel nervous with your shoulder with regular activities of daily living? For guys, I often say, does it bother you if you're putting your wallet away or if you're reaching on top of your head? For women, I ask, does it bother you if you're putting on your bra, or does it bother you if you're doing your hair? You know, certain things in terms of activities of daily living. How does your shoulder bother you? And then we talk about instability in the mid ranges of motion. So for regular activities of daily living, you know, such as putting your seatbelt on, putting on a jacket, waving hi to someone, does that seem to cause your shoulder to click or to catch or to feel unstable? And then in particular for our athletes, it's important to know, particularly for our high school and collegiate athletes, are they an in-season athlete? Are they in a contract year if they're a professional athlete? And what are their future athletic goals? What are our goals? What do we need to do right now versus what do we need to do in the next 6 months to 6 years? Physical examination is critical, and here's why it matters. The reason why it matters is because, as I mentioned before, the imaging is not always perfect. We've got to understand baseline ligamentous laxity, and Braden talked about this a little bit in his early talk in terms of the Baton score, and we'll talk about that just a little bit more. But it's critical to recognize, for example, in a patient such as you see here with baseline ligamentous laxity, and laxity does not always equal pathology. Laxity may be that patient's normal. They may be loosey-goosey in all of their joints and still have an unstable shoulder, but we've got to recognize that their baseline laxity is their baseline, and it's important not to over-tighten them. And then we've got to recognize and understand stiffness, weakness, paresthesias, contributions from the cervical spine or nearby joints. And so when we talk about the instability examination in the next 7 minutes, we're not going to have time to discuss all of it, but these are two great resources that I would recommend if you have a further interest in understanding some of the tests I'm about to describe in terms of evaluating the patient with shoulder instability. These two resources are comprehensive, they're not too technical, and they provide a great overview. So with inspection, we want to look at posture. We want to look at the patient's scapula. If you're in my clinic, you'll know that with guys, I typically just have them take off their shirt, and with women, same thing, but I offer them a gown. I offer everyone a gown, but most of the time the guys don't like or don't care to use that. And the reason is you've really got to see the scapulas. If you can't understand the scapulas, you're not going to be able to treat the patient effectively. And if their clothes are on, you're not going to be able to see the scapulas, and you can't get it just by feeling. So for new patients, particularly with cuffs and with shoulder instability, I like to see their scapulas. I look for prior incisions. Have they had an open repair in the past, an arthroscopic repair? I look for atrophy, including subtle signs of atrophy, scapular winging, be it medial or lateral, which have different causes and different treatments. And then I especially compare the injured side to the uninjured side. With palpation, this is more to rule out other diagnoses. We typically don't have painful shoulders to specific areas of palpation in the setting of shoulder instability. There's really no specific point tenderness. Oftentimes patients with posterior labral tears or posterior instability will make a C sign on their shoulder. So they'll say, doc, it hurts right here. And they'll try to describe something deep and achy within the shoulder, but they can't really feel where it is. Inferior anterior instability patients may point to the axilla in terms of this is where it hurts, but they often will make a C sign as well. And that's because they're trying to describe pain deep in the joint, but it's hard to palpate that area. We want to assess range of motion of both shoulders. If I see a patient like this, I start to get a little bit antsy in terms of if I'm going to need to do a repair, I want to make sure I don't over tighten them. Laxity is actually an advantage for some athletes, in particular swimmers, but also baseball pitchers and certainly volleyball athletes, some of our rock climbers. So we've got to be very cognizant of their baseline hyperlaxity in addition to their instability. With the Baton score, Braden again mentioned this earlier, it's a score of 1 to 9 or 0 to 9, and we're testing for systemic generalized hyperlaxity of their collagen, and a score of greater than 4 is indicative of hyperlaxity. And this is really important. We do this as part of our Moon cohort on every patient, but really any patient that I see that's getting a ligament or soft tissue procedure or has an injury to the ligaments or soft tissue, we're evaluating the Baton score. And we've got to remember that laxity is not symmetric with pathology. We may have a patient complaining of left shoulder instability, but have right shoulder laxity. It does not mean we need to treat the right shoulder. We've got to understand what their normal is. So here's that same patient I showed you before. And here we're going to show, if you look at the thumb, you can see EMAC and I tag team this case. That's his voice there. Super hyperlax, elbow hyperextends to about 15 there. The thumb goes all the way back to the forearm, and she can do this while she's awake as well. So this patient's got a Baton of 9, but incredibly hyperlax. Moving on to the rest of the physical examination to evaluate these patients with shoulder instability, we're of course going to look all the way around the shoulder and not just focus on the labrum, but we need to better evaluate the rotator cuff, doing our standard strength test, as you can see here. In particular, for patients who have had prior surgery and especially prior open shoulder surgery, we really want to look at the subscap function, because if we're going back to do a revision instability repair, we've got to understand their baseline subscap function, which may be weakened because the shoulder may have been violated through or detaching the subscap with their first surgery. We want to check for, again, hyperlaxity and looking for that sulcus sign. And here's an example of checking for that in the office. And you can see this is an example of a very positive sulcus sign on this athlete's right shoulder. Another thing we want to look for specific to instability is load and shift, and this can be both anteriorly and posteriorly assessed. And so we essentially stabilize the shoulder with one hand, and then we load and shuck the shoulder posterior or anterior with the other hand to see if that humerus will slide relative to the glenoid, either to the level of the glenoid rim or even over the glenoid rim, and then we can grade that appropriately. And then we look for apprehension. I really like doing this supine like you see here, and the reason is because this eliminates any rotation of the scapula, and the patient can't really fake it if we're eliminating the scapula. And so we can assess for both anterior and posterior apprehension. And then if they have pain in this position, we can place a hand right on top of the humerus, especially if we're assessing for anterior instability, and then relocate their humerus back to the center of the groove, and they should experience relief of their pain with the relocation maneuver. The Gagey hyperabduction test is a test that one of my former mentors, Greg Nicholson, really likes. This is a great way to assess for hyperabduction in the patient with hyperlaxity, and essentially abduction over 105 degrees or so is very synonymous with a loose inferior capsule, and we can use this test to assess for baseline hyperlaxity as well as laxity of the inferior glenohumeral ligament. The jerk test is a test that we do quite often for posterior instability assessment, as you can see in this video. Basically, the patient's seated. We use an axial directed force with the shoulder forward flexed, adducted, and internally rotated. And then we bring the arm into extension to reduce that subluxated humeral head. Patients will feel a clunk at times, or they may just have pain, and we can use those to assess for posterior labral tears. The active compression test, or O'Brien's test, this is a test that can be confusing, especially for residents, fellows, and even me sometimes, because patients will often have pain with this test, but they can have difficulty localizing their pain. And so I really ask them when I do this test, where is your pain? And I try to have them indicate if it's at the AC joint, which is different than if it's really in the superior labrum and biceps region. And it can be sometimes difficult for the patients to discern. So this is a test that's in our toolbox to evaluate these patients, but not very specific for a labral tear, but more specific for superior labrum, biceps, etiologies, or pathologies. But don't be fooled if this test is positive and the patient has pain at the AC joint. That can also occur. And if that's the case, we're not really focused on the labrum. And then one thing to look out for is this type of patient, the voluntary subluxator. This guy is a guy who we'd have some hesitancy choosing surgery on. Not everyone who can voluntarily dislocate their shoulder is a bad surgical candidate, but in this case, the patient is willing and almost enjoys doing it. It's the patient that doesn't want to do it, but can. Those are the ones where voluntary dislocation or voluntary subluxation we're more okay operating on. But patients with voluntary willful instability, we want to be a little bit more cautious, because once you do your repair, they may just try to stress the repair by doing this again, whereas the non-willful voluntary instability patients don't want to do it. And so this is something we want to, if a patient comes in saying, look what I can do, and they're kind of happy about it, you want to be hesitant in terms of understanding if we should do surgery on those patients. So that's a brief overview in just under 10 minutes on how to evaluate the patient with shoulder instability. I didn't get into imaging. We'll certainly talk. I'm sure and Dr. McCarty and Dr. Brovins talk a little bit more on as we get into the surgical side of things in terms of using imaging. But in my practice, we focus primarily on the history and physical examination, and then we use the imaging to help complete the story and help guide the surgical decision-making, or in some cases, the non-surgical decision-making if a patient is better suited for a non-operative approach. The treatment points, the take-home points for me in terms of evaluating these patients are really understanding that history and physical examination, using all of the physical examination tools that we have in our toolbox, and understanding, and I think I've said this now 5 times, so hopefully it sticks, laxity does not equal pathology. That's particularly important in the female athlete, but also in male athletes who do have baseline ligamentous hyperlaxity. With that, again, thank you, EMAC, so much. Honored to be part of this and happy to take any questions and looking forward to the rest of the day.
Hey, thank you, Rachel. Great talk, and Murph looks great in the mask. So don't get the COVID, or don't give COVID to the dog. Hey, great job. So we're going back to Ellen Shanley. Ellen, Ellen is a great talk on how we can treat shoulder instability without surgery. So this really opened up my eyes a couple years ago when this paper came out, and Ellen just gives some really great data and info on this. So thank you, Ellen.
Thank you again, Dr. McCarty. So I am fortunate to work in a co-located area with the Steadman Hawkins surgeons in South Carolina. And so I fortunately get to work in shoulder instability a lot. And so we do mostly high school and collegiate athletes with our instability practice. And as we looked at our practice, it really became clear to me that we didn't treat everyone operatively as most people think. So I started to think about, not only in our clinical practice, but in our research, how did non-operative treatment become a thing in shoulder instability? And really, what was our definition of success? And so if you look at the literature and look at how non-operative treatment sort of worked its way into the medical treatment of shoulder instability, I think it really came from this mid-season or in-season return to sport after shoulder instability. In 2004 in AJSM, Dr. Buss returned a group of patients in approximately 10 days to in-season sport. They had a 90% return rate and about a 30% recurrence rate in that group. In 2014, Dr. Dickens was in charge of a multi-center project at the military academies and looked similarly at the ability to return to in-season play after traumatic anterior shoulder instability. And so this is a group of cadets and really highly active people. They found that on average, it took 5 days to return these people to care. They had 73% that were able to return to sport. The 27% who were unable to return to sport couldn't return because of their level of function. They weren't functionally able. And he had about 30% at the end of the year that had some recurrence and weren't able to make it all the way through the season. So then what are the considerations in terms of return to sport, whether in season or out of season, if the patient has been treated non-operatively? Well, there's not really a clear pathway to what is the road to success, or even really what the definition of success is after shoulder instability. So traditionally, we have looked medically at recurrence being a definition of success. And so Dr. Franks talked about how many times somebody has had an instability episode. And I think that is critically important when we look at the long-term, short-term, and long-term outcome for patients. But also now we're looking more at patient-reported outcomes, both region-specific and pathology-specific outcomes. And so Dr. Dickens in 2014 and then again in 2017 described use of patient-reported outcomes to predict who really could go back to sport in the same season, and then what percentage of ability to go back was related to their score on their patient-reported outcomes. And so he predicted, or basically said, you were able to predict the ability to return to a subsequent season. But when we think about talking to our patients, the real measure of success for them is, can they go back to sport? And of course, it's a mutual goal. We want people to go back to safe sport as well, but we're also worried about their short and long-term health. So I think the next question is, if we let an athlete go back to play and they play without further instability, they have goals that are occupational, recreational, maybe not going back to a contract year as a pro athlete, or maybe not going on to play in college, then how do we decide what the right treatment is for them? And what's the answer to the question? Well, it depends on a lot of things. It depends on what demographic category they fit into in terms of recurrence rates, and whether they've had a previous dislocation or subluxation. What's their score on the patient-reported outcomes and their pathology-specific outcomes? What's the return to sport rate in the sport they want to go back to? And what's the risk in that sport? If you look at the 25-year follow-up from Dr. Hovelius, he said that patients tend to get stiffer over time, and approximately 50% of his patients went on to basically be stable over time. And if he had operated on all of them, he probably would have operated on 25 to 30% who might not have needed that surgery. There's also an article in JSES in 2012 that described a 30% complication rate for all different types of instability surgery, from arthroscopic all the way through the open Latarjet. So it's not as clear as 30% complication rates for an arthroscopic surgery, certainly not saying that, but there is possibility. So is the answer always go to the treatment that can't be reversed? If we try conservative treatment, we always have the next step. If we try surgery, we can't go back. So there are some things that have been found in the literature to either tend to bring somebody to having recurrence or not, or whether they're successful in terms of return to sport. And you can see sport type is really critical to know, in that contact athletes generally have more recurrence and they don't do as well going back to sport. Bone loss seems to be a significant factor, and we'll talk more about that later. There's some open questions about bracing and immobilization, instability type, and then there's some emerging evidence about dominant side instability being a factor for recurrence. And then also Tampa Kinesiophobia scale has been used to define people that are more likely to redislocate. We've just published 2 articles in 2020. They're both online first, using a non-operative instability severity index to predict whether somebody will need operative versus non-operative treatment in the youth and adolescent athlete, and then a functional bracing article that basically we found that patients with functional braces that return to sport do no better than those who return to sport without functional braces. So we started to study this. We had an original cohort of 129 high school athletes that were hurt in high school sport. 97 of them were originally treated conservatively and 32 treated surgically. We had an 85% return to sport rate without any increased instability or shoulder injury for 1 full year after initial return to sport in our conservative group. Success was equivalent whether you were in the surgical or conservative group. We've followed those patients up now for 2+ years and have been able to follow 62 of them. We have 11 athletes who have required additional surgical intervention with a similar frequency between groups. What you see is, interestingly, is the thing that was most associated with requiring additional care in our non-surgical or conservative group was this posterior extension of their labral tear. So people with a larger labral tear and concomitant capsular pathology really seem to not do as well with conservative care. The other interesting thing here is that those who were treated conservatively and needed additional care needed it within a much shorter time frame, 1/3 the amount of time. But when you look at functional outcomes, our WOSI scores and SAME scores are similar within groups for those with additional treatment or not, and between groups. So there was no difference. But the really interesting thing is the WOSI score was truly helpful in telling us who would be successful going back to sport. In the adapted WOSI score, or when it's put on a 0 to 100 scale, a score of 75 or greater was predictive of people who could tolerate and perform better at return to sport, whether they were treated conservatively or surgically. So in conclusion then, function after shoulder instability really is not equivalent if we look at return to sport or recurrence, and it's not predicted by recurrence, at least in our cohort. It was not predicted by treatment or sport type, meaning it's probably multifactorial. The WOSI seems to capture disability better, and it may help us predict and really help with treatment planning in those wanting to return to sport. Thank you.
Thank you, Ellen. Excellent job as always, and really appreciate your talk. It certainly is eye-opening and something we have to consider. And as we go now to my talk, I will now talk on stabilization in the contact athlete. And if I didn't introduce myself before and you weren't on, I am Eric McCarty. I am the Chief Sports Medicine Shoulder Surgery at the University of Colorado School of Medicine and head team physician for University of Colorado and Colorado Avalanche. So we thank you for joining us, my speaker disclosures. So as I talk about this, some of this comes from experience. 21 years as a college football team doc, 17 years as a college hockey team doc, 17 years as a college lacrosse team doc, and 3 seasons as an NHL team physician. And shoulder instability is a prevalent problem in these athletes. Of note, the professional hockey players are different than any of their other athletes. They get more dislocations in creating games, not so many occurring in practices. They often are with seemingly mild hits, and their tolerance for shoulder instability is in a different category from everybody else. This is the kind of hits they take, and they get a lot of these hits. And this is just a video of a very seemingly mild hit that occurred, and the guy dislocated. This was at Pepsi Arena. Here he is on the bench, one of the Blues' best players, not feeling so good. So we go into the Blues training room, and he had dislocated his shoulder. So what to do when we have this in a contact athlete? Well, Ellen Shanley gave a great talk on the considerations. Well, it certainly is a high energy type of dislocation. There's more significant bone or soft tissue damage around the shoulder than we might see in other dislocations. The injuries and risks that come with the high velocity dislocations and collisions result in a higher recurrence rate in athletes, both non-operatively treated and also operatively treated. The systematic reviews have shown non-operative treatment to result in high failure rate in the male contact collision athlete. And this has been seen in several studies. So what do you do if this is your athlete? What do you do if it's your high profile athlete? Maybe it's your high profile collegiate athlete. Maybe it's your high school athlete. We got to take what Helen has told us, but also take into other factors and have a great discussion with the athlete and maybe their family, maybe the coaches, the athletic trainers, and maybe the agents. So what if it is your athlete? What's if he's feeling good at the end of the season? So you let him continue playing during the year and says, Doc, I feel fine. Well, going back to Habilius's study back in 2008, looking at the long-term follow-up. If you look at the contact and the recreational sports, there was a 70% recurrent instability or need for surgery in those higher demand patients. Sure, there's 30% that don't need surgery, but there's 70% that do. Are you going to take that chance, particularly if it's somebody that is really a athlete that wants to play, even if it's their high school athlete, they really want to play their contact sport. So, doc, I feel fine. Should I fix it at the end of the season? Well, the natural history for contact athletes suggests that you should fix it. Now, the decision for surgery, a contact athlete with Bankart and no bone loss, what to do? What would you do? Would it be an arthroscopic Bankart repair? Would it be an arthroscopic Bankart remplissage? Maybe an open Bankart, maybe an open Latarjet, we'll talk about later. Maybe an open bone graft, and maybe an arthroscopic Latarjet. This was a study of NFL team physicians that we did a few years ago. We did a previous study in 2008, and then in 2016. What would you do in your NFL player? And this is just part of the series of questions, but one question was, how would you treat your NFL player? And in 2008, 79% said arthroscopic Bankart. In 2016, 90% said arthroscopic Bankart. So what to do? Arthroscopic stabilization, open stabilization, or bone graft procedure. My preference in the majority of the cases is an arthroscopic stabilization. So why an arthroscopic stabilization? Well, we have to go back in history a little bit and see why some people don't do it. So in the 1990s and 2000s, there was a relatively high failure rate of 20 to 35%. Now, there was a variety of techniques of fixation and techniques. Now, there's been an evolution of arthroscopic stabilization in the United States over the past couple decades. The trends in management of shoulder instability looked at in this article have shown an increasing in arthroscopic, also mirrors what we saw with the survey of the NFL team physicians. This was a very nice meta-analysis of open versus arthroscopic Bankart using suture anchors. This was published in 2010. And what I want to point out to is looking at all the data and looking at the newer data, looking at studies starting in 2002, not the 90s, but those that were done open versus done with arthroscopic and suture anchor, the recurrences was less arthroscopic and the reoperation was less. And this was a very nice study that Dr. Frank was part of while she was at Rush, a meta-analysis of studies of arthroscopic stabilization in the contact and collision athlete. They looked at 26 studies. The average age was 19.9 years. Rugby, a high collision sport, was the most common sport. The pool failure rate was 17.8%. However, when you look at studies using modern techniques and excluding bone loss of less than 20 to 25%, those that had bone loss of 20 to 25% were excluded, only 7.9% failure rate. So what was learned from this study, and look at all the studies, you need the right patients with few episodes, they need to have good tissue, and you need to avoid the bone loss, particularly above 20%. And you need the right technique. Several studies shown that there's a decreased incidence when done in the lateral decubus position, so on the side, which we'll show in my next talk. You need to treat all the pathoanatomy and a minimum of 3 to 4 anchors. And the recurrence in collision athletes then is 7.9%. So when can arthroscopic anterior shoulder stabilization be performed in the collision athlete? In 2020, most of the time and for most conditions. But the caveat is that they must possess the skills necessary for arthroscopic stabilization techniques. And that takes time, that takes fellowship, that takes extra time learning it over the years so that you can perfect that technique. And this is what it may look like in that lateral position. This is a Bankart lesion, and this is after it is fixed. Just a question of what about the Latarjet? So this comes up. Well, the arthroscopic Bankart we've been talking about versus the Latarjet remains controversial. Some people will favor the Latarjet for contact sports, particularly in France and Europe. However, this lacks random controlled trials. Long-term follow-up is lacked, and systematic reviews are inconclusive. In my practice, the arthroscopic Bankart is in 92%, and the open Latarjet in 8%, and that is reserved mostly for those with bone loss and often for revisions. And so when I perform it for glenoid bone loss greater than 5 to 15 to 20%, you can see this with the arrow. This is a part of the glenoid that has been knocked off, and you can see the golf tee is quite small for the golf ball. So glenoid bone loss is the primary reason for failure after arthroscopic stabilization. We have to remember that. And Burkhardt and De Beer had a very nice study that showed that without significant bone defect, those less than 25%, there was a 4% recurrence. However, when the bone loss was greater than 25%, there's a 67% recurrence. So, and with contact athletes without significant bone defect, 6.5% recurrence, and those with a significant bone defect, 89% recurrence. So there are lessons learned. The Latarjet provides an excellent architecture of increasing the bone, and has some other things that Dr. Brahman will discuss in his talk. However, there are some complications with this, at least 30% risk of nerve injury, infection, non-union fracture. So we have to remember that it's not a benign procedure. So if arthroscopic Bankart are not indicated, possibly going to the coracoid transfer or Latarjet. So what to do in my contact athlete with Bankart, no bone loss? Arthroscopic stabilization is my procedure of choice. We have to look to the key factors for successful arthroscopic anterior stabilization. And in summary, remember our surgery at the end of the season is recommended even if doing well. However, look at all the factors and look at the factors even that Dr. Shanley has talked about. However, I don't want to be coming back to the beginning of the next season knowing that if he comes out at the first game of the season, I could have fixed him at the end of the last season. So be cognizant of that. Have the right counseling with the patient. And often the predictable thing is to do the stabilization. The arthroscopic stabilization works well in a majority of cases in the contact athlete, and use the Latarjet for bone loss greater than 15 to 20%. So thank you for this portion of the talk. And I just got we missed football, we missed Ralphie running around. So unfortunately, none of that this year. We will go now to my next talk, and the next talk takes us up on the stabilization pearls. So I'm going to stop sharing that one and see if I can go to the next one. But it's an excellent discussion that we have as we talk about what to do with the contact athlete, and very important as we look at that. So let me share my screen on the next one. So I know many of those in attendance today are the physical therapists, athletic trainers, and not necessarily surgeons, but it's important to understand what we do in surgery. And for those surgeons, it's important to understand what the tips are for success. Now, I'm filling in for Rob Hunter. Rob could not give this talk today. He is recovering from some intervention that he needed for some part of his body. He's doing well from what I understand, but I'll try to do my best as we look at the tips. So top 10 pearls, we need to define what's being treated and make the correct diagnosis. Positioning is important. Portal placement is important. Visualization, the fluids that we use, the exam under anesthesia and the arthroscopic exam, we need to treat what is necessary. We need to mobilize the labrum and inferior glenohumeral ligament. We need to prepare the glenoid. The anchors, the placement and application of the tissue is important. And we need to have the correct instruments. And then finally, as we're talking about in these talks, rehab is critical. So the goals of instability surgery, arthroscopic surgery, are correction of the laxity, restore the glenoid containment, retention of the glenohumeral ligaments, and decrease the volume of the joint, plicate the capsule, and repair the tear. So we need to define who and what is being treated and make the correct diagnosis. We need to recognize bone loss. We need to look at a Hegel. Over to your left is a picture of a arthroscopic view with a large bone lesion. This actually could be treated arthroscopically, as we could reattach that. And to your right is what we call Hegel lesion, where there's not a Bankart lesion, but the tissue, the ligamentous tissue called the inferior glenohumeral ligament has basically torn off from the portion of the humerus. We need a good preoperative exam and history, and Dr. Frank gave a great reasons why we do that. Imaging is helpful, and these are all essential to optimize a good outcome. And we need to recognize the right patient selection for the right surgery. This is more critical to consistent outcomes in surgical ability and technique. So we talked a little bit about lateral cubus versus beach chair. There's advantages to both. In the past, I was taught in the beach chair position. That's in the sitting position, as you see in the picture to your left. It was easy to convert to an open. Arthroscopic viewing is an upright anatomic position, and you can really manipulate the arm and the shoulder. However, as I learned during part of my fellowship and in practice, I found that my preferred position is the lateral cubus. You get more distraction, better visualization, and easier to maneuver between the anterior and posterior. And as we've seen, there are better results with the lateral cubus than the beach chair, and that's been my experience as well. So positioning pearls in the lateral cubus, we need to align the body in about 20 to 30 degrees posterior tilt to keep the glenoid horizontal, and need about 10 pounds of traction, and then lateral distraction with this pulling up on the arm to help provide visualization. And then we can use a bump in the axilla if having difficulty visualizing inferiorly. So again, for many of you that aren't in the operating room, this may look a little bit foreign, but this is important for you to understand what we're doing to provide access to see inside. And this is the positioning that somebody would have at the time of surgery. Again, about 30 degrees tilt, and so that you're in the plane of the scapula. This is the traction and then the distraction, the traction and then distraction, where it's providing a little bit more room for us to move around inside the shoulder. So some pitfalls of positioning: overzealous traction and distraction. We need to feel the tension of the nerves in the upper arm, and we need to ensure that we have appropriate rolls, particularly in the axilla, to prevent pressure injuries, and also around the genitalia and also around the knee. Now, portal placement is very important. I use standard posterior portals, and I use a second posterior inferior portal that will help, and you'll see in just a moment why that's so helpful. And then two anterior portals. One is high in the rotator interval, and the second is the top border of the subscapularis. So there should be 4 portals around the shoulder. Now this shows the a posterior inferior portal and kind of the area that we will go into, getting to the 6 o'clock position, deep inferior into the joint. So very important portal for us. Now, visualization is very important. We have to have appropriate fluid pressure and avoid turbulence. The turbulence creates poor visualization because, due to Bernoulli's principle, if you remember that from physics, a force is created that sucks the blood from the capillaries. So we want to prevent that. We want to prevent that turbulence and that blood vessels and that blood from creating a trouble and seeing in our view. Now, gravity fluid keeps constant pressure and avoids a turbulence. We put epinephrine in the bags, 1 to 1,000. This helps with the visualization as well. Now, examination under anesthesia and an arthroscopic exam are very important. We must assess the anterior laxity, abduction with neutral and external rotation, and then we want to assess the posterior laxity. The direction of the instability is noted. So a very important part when we first get everybody asleep, and a wonderful time to get exactly how much laxity there is. Now, in the diagnostic examination, we want to look at the overall volume of the joint. We want to evaluate the biceps anchor, the labrum, the rotator cuff, the articular surfaces, any bony defects, and any capsular lesions or avulsions. If you look to your lower right on the screen, this is what a haggle might look like. We are looking into the muscle beyond the capsule. And so when we see this, we want to be able to understand and know and fix it. Now, we want to treat what is necessary. We don't want to overtreat. Beware of the Buford complex. This is an area that is a cord-like middle glenohumeral ligament that looks like maybe there's a tear. There's absence anterior superior labrum. However, this is normal variant of pathology. This is not a tear of the labrum as you look to the left. And then as you look to the right, this is an anterior superior labrum. And we want to make sure that we don't treat, that is not something that is, we don't want to overtreat. We don't want to treat something that doesn't need surgery. We want to mobilize the labrum and inferior glenohumeral ligament. This is done by elevating the tissue. We want to release the tissue at least to the 6 o'clock position. This is the anterior. We're releasing it. We can see the subscapularis below us. And then we want to prepare the glenoid. It's very important to prepare the bone. We want to get bleeding to stimulate healing. We want to visualize the anterior edge of the glenoid. And then we want to place anchors. And very important anchor for me is this 6 o'clock anchor that I can get through that posterior inferior portal. And we want to be able to do that. And we can do that because we have some technological advances. We have a curved guide. This allows for placement of anchors almost anywhere in the shoulder. Even works for the Hagel lesion that we talked about. And this is what the 6 o'clock and that posterior inferior portal looks like. This is looking at a shoulder. This is a right shoulder on the side. The head is up to the left. This is coming down, and this is where the anchor comes down. This is looking from the top part of the glenoid. Scope is looking down, and this is what we call the 6 o'clock position. And this is what it looks like drilling that anchor. The anchor is going down inferiorly. You can see I have a great view all around. And then what we'll do is retrieve the suture from that anchor. Anchor is retrieved through the second anterior portal. I'm looking from the top anterior portal, and then using a suture hook that will help placate the tissue. And this is very helpful to eliminate any redundancy of the capsular tissue and allow things to be tightened up. And then I'll shuttle that the suture that I just pulled through the anterior portal. We'll shuttle that through the tissue that we just placated, and then we'll be able to tie that down. So you can see that having the right position, the right portal, and the right anchors is very important, and you can see as we're about to tie that. So anchors, placement, and placation, very important. Dr. Boileau from France has shown us that we need at least 4 anchors because less than 3 anchors in their study was associated with failure after stabilization. So very important to have enough anchors in the right position. And then I like to do the 6 o'clock and then a posterior inferior plication to complete the stabilization, and then also to complete and completely tension the inferior glenohumeral ligament. So this is anterior to the right, inferior is below, and posterior inferior, very important. So the pearls, we want to liberally use these sutures, anchors at the edge of the glenoid to provide excellent secure fixation, especially if there's poor tissue. We want to be careful not to plunge too deep when we place this in there to avoid damage to the axillary nerve. And then we need the correct instruments, and there's a lot of different instruments to pass suture, and those are all very important. You can see a number of those there, and you can see how this is utilized as you saw. So lastly, rehab is critical. Use a small neutral pill immobilized for 6 weeks. We go slow, PT to start in 1 to 3 weeks. Start with external rotation 0 degrees at the side, then forward flexion 90 degrees. Start with isometrics. 4 to 6 weeks, rotator cuff exercise, lower trap and serratus. And then we start active stretching in 6 to 8 weeks. 12 weeks starts in proprioception, neuromuscular facilitation, plyometrics 3 to 4 months, sport-specific training in 6 to 9 months, return to contact sports. Avoid too aggressive rehab, avoid lack of compliance, and avoid premature return to activity. So define what's being treated. Lateral cutis is preferred. Posterior inferior portal is terrific. Gravity fluid epinephrine helps with visualization. Need a good examination pre-op, examination under anesthesia, and arthroscopic exam. Don't miss the haggle. Mobilize the tissue to 6 o'clock position. Prep the glenoid. Retention and tighten the inferior glenohumeral ligament. Use a 6 o'clock anchor. The posterior inferior plication with the suture hook helps immensely. And then look and see what size, numbers, and anchor placement, and sling for 6 weeks with the correct rehabilitation. So with that, I thank you for the time to share that, and I will now introduce Dr. John Brotman, who's going to take up on the subject of bone loss. A great colleague of mine, a team physician with me at the University of Colorado, University of Denver, and the Colorado Avalanche. John Brotman, thank you.
Thanks, Eric. Greatly appreciated. What a great session. I certainly miss seeing all of you guys in the Buff Club and the hugs and getting to catch up with everyone who we missed. What a great session of talks here, and I'm going to take this the next step, which you've already heard about in regards to bone loss, and there have been some hints here, both in Dr. Frank's and Dr. McCarty's and Dr. Shanley's talks about bone loss, and hopefully I can decode that a little bit. So my standard disclosures, none are relevant here, but what is instability with bone loss? And what this typically is this is very often recurrent shoulder instability, loss of bone on the anterior inferior glenoid. And what this does is this decreases the available articular arc. And so there's essentially a mismatch between the glenoid and the humeral head. And I hope for most of us that we don't figure this out when we're doing an arthroscopy like you see on the screen here. And this is a situation where some of us do an arthroscopy before we do, say, a Latarjet to confirm that there's no other pathology. But this is a diagnosis that hopefully we can make after you see this talk preoperatively, and we don't end up in this situation. So you hear this golf ball, golf tee analogy, and the anatomy of the native human shoulder is actually very similar to that. And what we're talking about is for anyone who's hit a great drive and you knock a small corner of the golf tee off, is that you know that the ball is not going to stay on that tee after you knock the corner of the tee off. So that's the exact concept here. And so the arc length is decreased, the ball is going to fall off, hence the problem that we typically have. Patient history, as Dr. Frank touched on, is really critical here. So this is often status post to high energy dislocation. Oftentimes there's been an initial bony Bankart, which Dr. Shanley pointed out. And the people that worry me, so the people that should cue those red flags, multiple dislocations with recurrent instability and increasing ease of dislocation. So the exact patient that you may think, this story sounds a little bit fishy, right? Like I sneeze and my shoulder dislocates, or I roll over in bed. That's the exact patient that should really perk your ears up. And things like instability in the mid-range of motion, when they start getting unstable, not needing to bring their arm all the way back and up, but that their arm's coming out in that 20 to 60 degree range. And then we'll talk about some imaging-based things. So the point here, though, is that this is ultimately a radiographic diagnosis. So we need good radiographs, we need good 3D imaging, and we need to know how and what exactly we're evaluating. So why is this important? All the way back to Carter Rowe in the late 70s, he recognized in his open Bankart series that if they had greater than 30% measured with a ruler at the time of open surgery, that they had an increased failure rate. Burkhart and De Beer took that a step further, and this is the classic article in 2000 of the inverted pair glenoid that has already been mentioned, but that there's failure of an arthroscopic Bankart, especially in the contact athletes, of 89% versus only 6% with or without bone loss, respectively. Pascal Boileau took this a step further in 2007 and tried to quantify who's going to benefit or who's going to, say, have a worse outcome with an arthroscopic procedure in the setting of known bone loss. And then the biomechanics are really what's shown to be really the critical problem here. And so I'll present here very quickly the instability severity index. And what this showed essentially is that looking at a set of patient factors that they have when they're seeing you immediately in the office, based on age, sports participation, contact or not, hyperlaxity, what their radiograph looks like, both on the Hill-Sachs humeral side and the glenoid side, that if patients had a score greater than 6, this predicted a 70% chance of failure with arthroscopic Bankart. So many have taken this since 2007, that a score perhaps greater than 4 should indicate someone for a Latarjet or a bony procedure. I will point out that almost every single one of our high school athletes with a primary dislocation in this setting has a score over 4 to begin with. So this, I see Dr. Shanley shaking her head, that this is that every single one of our contact athletes in high school with a primary dislocation is going to end up with a Latarjet, which I'm not sure is the right procedure, but we need to make sure we know exactly what we're evaluating here. So the biomechanics are that the effect of glenoid defect on instability is really significant, and you see the plane of this is important. They showed that a 21% defect will cause instability and range of motion problem with an isolated Bankart repair. The problem with that is that you see the bottom right red line was what had been modeled in the lab, but clinically we didn't see that. So this basically needed to be redone. And Yamamoto's group redid this with a different plane, showing now that that number went down to 19% to change the stability ratio biomechanically in the shoulder. So what you see is above 20%, now it's coming down to 19%. And we're getting a better sense of Christian Gerber showing us that if we have a ratio of the radius that's greater than the bony Bankart piece, this decreases the risk of recurrence or of instability by 70%. The force decreases to push the shoulder out. So we're getting a sense that we need to understand where exactly that bone piece is and how large it is. How do we measure this? So CT, and oftentimes CT arthrogram, is the study of choice. 3D CT has been shown to be the most accurate method, which you see on the right, the left-hand slide there. MRI is okay. So our colleagues at NYU showed that there's about a 3% error with MRI utilizing the circle method compared to CT scan, particularly 3D CT. I can still tell you that in my practice, 3% may actually change my management. So I think it's really critical if you're considering these options that you absolutely need to have the best study possible. This is the way that I think most of us measure bone loss, and the way that I use bone loss measurements, which is the circle method. A circle should portend the bottom 2/3 of the anatomic glenoid. The missing piece becomes a percentage of that circle, and that's how we measure our bone loss. What about the humeral side? So this is frequently neglected. The Hill-Sachs compression fracture is present in almost all episodes of instability. There's going to be some effect if the shoulder came out or even subluxated. Our buddy Dean Taylor showed that even if they don't require a formal reduction maneuver, they still can have all of the same pathology if they describe an instability episode. Traditionally, if that's less than 20%, we'd completely ignore it. If it's 20 to 40%, it may require intervention, and I'll get to that in a minute. 40% almost always require treatment, and that may be something big, like an OC allograft, an arthroplasty in certain cases. And then there's this concept of if they're engaging, which I personally think is kind of bogus, because if it was there at some point in life, it was engaging. It touched the front of the glenoid. It had to happen somewhere. So this may be that we can't reproduce their arm position. We can't reproduce their exact velocity or energy to produce that in the OR, but it doesn't mean that we can ignore it. This then I'll go to the concept of the glenoid track. And this is a newer concept that Yamamoto and Ije Itoi proposed that describes the Hill-Sachs in a more three-dimensional and interactive phase with the glenoid. And what this shows is that the arm in a 60-degree abducted, maximum externally rotated position, that the distance to the infraspinatus is within 83% of the glenoid width. So what that means is that, like you see above, if that defect is within 83% of the glenoid width, it will stay on the glenoid and will not fall off. The picture on the bottom, you see that that's further towards the articular surface, farther away from the infraspinatus footprint, and thus that defect falls over the edge of the glenoid, thus making this what we call an off-track lesion. So it's a three-dimensional representation of both sides, bipolar, on the glenoid and the humeral side, combined to know if that's going to engage dynamically for this patient and if that needs addressing. So what have we done with that? Well, Gene Wolfe really beautifully described a concept called remplissage, which is French to fill. These are arthroscopic pictures of a patient that I did a remplissage on. This is an arthroscopic image of me placing an anchor within the Hill-Sachs, passing suture through the infraspinatus and the capsule, and then tying that capsule up to essentially fill the remplissage, or fill the Hill-Sachs defect with this remplissage. We've shown that we can do this successfully without restriction of external rotation or low recurrence of instability. And this is an algorithm now back to the instability severity index, where we show with an isolated humeral bone defect, not on the glenoid side, that Bankart plus remplissage is the appropriate treatment. You can see farther on the right, combined humeral glenoid bone defect is not an indication or a solution here. So what I want to point out is that remplissage is not a solution for critical glenoid bone loss. That does not solve the problem. And there is some bet hedging going on with a lot of surgical treatment now, thinking about this, that we can solve glenoid bone loss with a remplissage, which is not factual. That's never been demonstrated. I would say here that what is critical glenoid bone loss? And this has changed. So this has gone from 25% with Burkhardt and De Beer, now all the way down to 13% from our buddy John Tokish, who showed that they may not have a redislocation difference, but they have a clinical outcome difference, meaning they don't trust their shoulder, all the way down to 13% of bone loss. So I think we're really defining that we may have a bigger problem than we think here. So what are we going to do about it? We got to restore the glenoid arc. We have Latarjet, we have iliac crest bone graft, and now distal tibia. We even have now the addition of autograft distal clavicle is being used, or spine of the scapula. The Latarjet is a coracoid transfer where we take the coracoid with the intact conjoint tendon. We get this triple blocking effect. And this is a highly successful operation, but there's a limit. And so with the 30% defect, Godadra showed us that we can only restore so much. So you have to know there may be a limit to this. And if we need free graft, the iliac crest is excellent. This is called the Eden Hibernate. And we've shown with two of my former mentors that patients can be successfully treated with a free graft. What about distal tibia allograft? So our own Dr. Frank has pioneered some of this work with her colleagues at both Rush and up in Vail, showing excellent results with distal tibia allograft, equivalent to the Latarjet with a low set of recurrence. And this has even been taken a step further with now their arthroscopic techniques. So their arthroscopic Latarjet can be performed. And a newer concept that I've been using that I think is probably going to be a more significant tool in my toolbox moving forward is for the bet headers, the ones like Dr. McCarty was saying, they have a little bit of bone loss. You don't want to do an open stabilization because of the potential morbidity. Maybe we can add arthroscopically a free bone block, but with a Bankart repair. And this is a case that I did recently, first time operation, but 16% bone loss. So what do you do with this kid? So these are pictures of his arthroscopic procedure, big capsular deficiency, flat anterior glenoid, anchors and a guide in the front. I pull an autographed bone. This is actually distal autographed distal clavicle in arthroscopically, and then a Bankart over the top of that. So this maybe adds 30 to 40 minutes to this operative procedure, a little bit of increased complexity, but I think this is going to be a great next step in regards to our treatment algorithm. Outcomes of this, Latarjet Bristow, I want to point out simply the low recurrence. And in this systematic review of 3,200 patients, arthroscopic Latarjet actually had the lowest of recurrence rates at 3%, no difference in osteoarthritis. 100 patients with 2-year follow-up, showing that maybe our higher level competitive athletes may do better overall than our recreational athletes, though both with very good return to play and very low recurrence rates of 2% and 3% respectively. A comment that was already brought up is that it's not all roses. And so what are the North Americans here afraid of? Well, this is a valid point. Out of 4,200 procedures, the bone block versus a soft tissue repair had a 10-fold increase in complications. So you have got to know what you're doing, and we've got to make the right decisions for the right reasons, because the open, particularly bone block procedures, absolutely expose our patients to higher risk. And the problem is those risks can potentially be catastrophic in these patients. So we know 30% predicts failure of open Bankart. Now 18 to 20% has a biomechanical change. Now maybe JT shows us it's 13%. Where is this going? And so perhaps the next phase here is that we need to demand match our patients. So maybe the throwers that need all their motion, they get an arthroscopic stabilization. Our somewhat higher level athletes with particularly humeral sided defects need remplissage, and then our contact and more higher level ballistic athletes, maybe they need a bony reconstruction or maybe a hybrid like I showed. This has been taken further now, the Glenoid Track Instability Management Score, and this is in addition to the Instability Severity Index. The bottom line here is that the better we get at evaluating what they have by imaging, we can more appropriately stage what they need. And in this study, they saved about half the patients a Latarjet and had equal outcomes. So in summary, bone loss is a significant risk of recurrent instability. Scoring systems are a guide. They're not a law. So we need to be really cognizant of what we're doing and why we're treating what. Beware of the warning signs. Make decisions by imaging in the office. understand most defects are combined and they interact in a three-dimensional way, and that there are multiple excellent options for glenoid reconstruction, all of which have good results. Thank you very much.
Excellent job, JB. Thank you, Dr. Brahman. That's a really important topic. So we're going to go next after that terrific shoulder instability forum and talks to Dr. John Hill. And I think Dr. Hill is up and running. Dr. Hill, thank you for getting back on and resolving the conflict of the issue that you had.
Well, thank you very much. Now I have a new reoccurring nightmare of the disappearing share screen button, but just like everything else, if you shut down the application, it comes back again. So we started off on this, and as you see the picture of the weed whacker and the hornet's nest, that's what happens when you use a cool tool, but in the wrong application, and that's the risk of ultrasound. If you have the machine, but you don't put in the time to practice, that's where you can cause problems, and it's not always beneficial. So reviewing the phases of tendinopathy, and with diagnostic ultrasound, you can see the acute tendinitis where you just see fluid around the tendon, and then the angiofibroblastic stage where you see neovascularity. And eventually what happens is you get the chronic changes with it where you have nothing except the dysfunctional tissue and necrotic tissue that's there. And you have to treat each one of these differently. Efficacy of diagnostic injections, there's a lot of things that can cause pain. And so it's finding out what exactly it is. Pre-surgical planning to make sure that you're planning the right procedure. And then accuracy, is the needle where you think it is? So just looking at the glenohumeral joint, this posterior approach coming in this thin bicycle racer, we can use a linear probe, but some people that are a little fluffier, the curvilinear is a much easier transducer to use. And then you can see the needle coming in right above the humeral head underneath the labrum. And that's where you can accurately get the injectate right where it's supposed to be. I don't have to debate the accuracy of glenohumeral joint use with ultrasound anymore. This has been around, and 14 years ago, 15 years ago, I was more of an evangelist trying to tell people they ought to use ultrasound. And that is pretty much settled now. And you can see the fluid going in the glenohumeral joint. This is an example of a large volume glenohumeral joint injection for a frozen shoulder. You can see it begins to distends even further. And right here, you can see then the steroid floating in the joint. What happens is this is a highly inflammatory state, and you use power Doppler, and you can see the joint capsule become very inflamed. And that's why if you use a small volume, a 1 cc of a steroid, it just doesn't treat this very effectively as much as this 20 cc's. Link this with manipulation with the local anesthetic immediately afterwards, and it's a far more effective procedure than just trying to do one or the other alone. Also, people will never break their humeral head off or tear a tendon if they're moving it themselves, so it's much safer than if you're trying to manipulate under general anesthesia. AC joint, if you're injecting a normal AC joint, it's not too hard, but we don't do that very often. It's usually the pathological arthritic, and dropping a needle in this joint isn't all that easy. One of the advantages with ultrasound is you can come in from the side, place a needle under the joint capsule, and then you can see the injectate go right into the joint itself. Much more effective than just trying to hit it plus or minus. Biceps tendon, this is a long axis view of the needle coming into the tendon sheath. This is the short axis view where you see the fluid around the tendon sheath. And right there, this is the approach to take doing that. The accuracy of a palpation guidance isn't all that terrific. Frequently what happens with palpation guidance, especially even with dry needling, you tend to dry needle the lesser tuberosity and not the biceps tendon. So that's where, if you know where to look, that's helping. And the more ultrasound you do, then the more you know where to palpate on that. Example of chronic tendinopathy versus an acute tendinitis. You see the tendon is normal, has a completely normal architecture, fluid around the tendon sheath. That's a tenosynovitis. And this has a dysfunctional neovascularity and the dysfunctional collagen that's beginning to necrose. Using motion, you can see if the biceps subluxes out of the groove, and this is where it's staying right where it's supposed to. Example here of subluxed biceps, where the biceps is sitting over the lesser tuberosity. And in this view right here of a long axis, there's lesser tuberosity, and there's the biceps both strung over the top of it. So acute rupture of the biceps, it leaves an empty groove filled with fluid. And that's where I always tell people they've done their own surgery and they've just gypped us out of our surgical fees. That the acute one, when you move it around, you see the fluid, you'll see the stump of the biceps tendon as it's in the groove. When the rupture has been there a long time, or a tenosynovitis or a tenodesis, then the groove fills with granulation tissue and begins to go away, and eventually it just disappears. Dynamic motion is also quite helpful with ultrasound. You can see this view over here where the person has normal humeral head depression and the supraspinatus, greater tuberosity, hide underneath the acromion. In this view, there's no depression. The greater tuberosity and supraspinatus ram into the acromion and causes trouble. Remember, proper position, scapula protraction, but this function is far more effective than a subacromial decompression. Then you think, well, maybe the tendon is abnormal, so you can look at the contralateral side. On the involved side, the tendon is intact, but this supraspinatus is thickened, has dysfunctional tissue, and the opposite side looks normal. So just because a tendon is there doesn't mean it's a normal tendon. With those abnormal tendons, we can do this procedure called Titanex, or the FAST procedure. And what happens with it is we can use a needle, the 16-gauge needle. Using high-energy ultrasound, you can liquefy or emulsify the diseased portions of the tendon. Then you can irrigate and aspirate to get that material out. The needle is relatively blunt, so you make a small incision with a number 11 blade to introduce the needle, and the bluntness of the needle is actually very protective because you cannot place this needle in normal tendon, so it keeps us from hurting people. And then the fluid comes in, you irrigate it, suction it out, and here's an example of what it's going like. With this, you can pull it out. The advantage this has is it's a tiny incision, and you can initiate rehab on day one. A lot of times we emphasize eccentric loading because when you're removing this tissue from the center of it, we want the normal tendon to glue back together again. And that's the advantage of starting rehab immediately with it. Post-procedure, here's the dysfunctional tissue, the collagen from a calcific tendinosis floating in the bag. So it's much better to have that tissue in the bag than in the shoulder. And then this is an example of a patient, 53-year-old, all the signs of impingement. We've looked at the x-rays, there's calcium in the supraspinatus, tried all the conservative treatments, NSAIDs, PT, a couple of bursa injections, and the patient still is in a lot of pain. So again, to remind you what a normal the shoulder looks like, this is normal supraspinatus tendon. And then here's an example of the archiform the calcific tendinosis, where you see acoustic shadowing behind it. And this is where the transducer is looking at that. So calcific tendinosis, it can look like this or it can look like this. This is the resting phase of it, which is much more painful than when it's in the formative stage. And you can do this procedure in any of those stages. That hydroxyapatite, that calcium, it's very soft like toothpaste and can be pulled out of there. Here's just a reminder of the three stages. The formative stage, where you see the dense calcium with acoustic shadowing. Then the resting phase where it looks like the tendon is thickened, dysfunctional, measured sometimes twice to 3 times the normal size of the tendon. And then eventually it begins to degenerate into this cystic form on that. And the 10X procedure or the percutaneous tenotomy can be done in any of those stages. So here's an example. Initially, the needle comes in, you begin just liquefying that dysfunctional tissue. Then you begin going in and out, pulling it out. As it suctions and irrigates it out, it begins to hollow out the tendon. And pretty soon you can remove this whole section out of there. And that's what the procedure's like. A lot of times the operative time is under 5 minutes in order to do this. So just in summary, diagnostic ultrasound is very helpful. It's not just placing a needle, it's knowing where the needle is and what's wrong with the tissues. Ultrasound guided injections are much more effective than palpation guided. And then you can also understand what is wrong. You don't treat chronic tendonitis the same way as you do acute tendonitis. One is a tendinosis, one is a tendinitis. And then ultrasound-guided percutaneous tenotomy is an option for surgical procedures, and a lot of times you can get the collagen out and have people rehab a little bit faster. Thank you very much.
Hey, John Hill, thank you. Thank you for giving us such a great talk and correcting all those woes of the computer. But again, I encourage you, get John Hill's book. It's called All In. And he will tell you some fantastic stories of his life and a lot about medicine and a lot of different things. So anyway, we got about 10 minutes. We're going to go on break. Ann McNamara, Director of PT from the CU Sports Medicine Performance Center in Boulder, is going to have a wellness video she's going to run in 10 minutes. We're going to come back, get on track with the rotator cuff, and thank you for a great first couple hours, and we look forward to the next sessions, and thank you to all the speakers.
Welcome back, everyone. So let's get moving again for another one of our breaks. Again, I'm Carol from the CU Sports Medicine and Performance Center. So we're already in our seats. Let's stay there for a little bit longer. Come to the edge of your seat here. Oh, it's really hot. All right, you're going to go ahead and take your right leg. Crank that leg so it's good and straight. Toes up to your nose. And we are going to stretch those hamstrings. Don't just go grabbing for those toes. We're just going to rotate through those hips. Keep your back nice and flat until you feel a good stretch in the back of your leg. If you're feeling crazy, we're going to add some hands now. Take your left arm, cross it around your body, right arm into a stretch. And you can even add some wrist circles as well. We're going to be here for a little longer. And let's switch it out. Extend that left leg nice and long, toes to nose. Keep that back nice and flat and start to go forward. Ooh, that's a stretch. Right arm across the body, wrist circles, your fingers. All right, let's take that right leg again. Cross it over your left. And let's just do a gentle press down on that knee. I like to add some ankle circles in here as well. You should start to feel this along that posterior chain and into your glutes.
Hi, busy. Busy.
position, but also we're going to get a stretch on the other leg. So let's think about this as kind of a twofer. You're getting two different things going. We're going to just flicker up and down, feeling the stretch in here. You can experiment with pointing your toe out, maybe a little more in if you're feeling wild. For 4, 3, 2, and 1. Woo! Come on up to the center. Arms up ahead. Bring them to your low back. You're going to clasp them together like this. And we're going to do a big forward bend. Hinge at those hips. Come on forward and down. What I'm trying to do is bring my chin down between my legs. Feels pretty good on the back here. You can either keep this position, you can try to keep your palms together to try to get a little more of a stretch, or we can move on. You're going to take your left arm, left hand really, and you're going to find your right toes, or at least just somewhere underneath your body here. Let's go ahead and open up towards the ceiling. I always like to make sure I'm looking towards my top hand, so you're getting that twist all the way up and into your neck. And let's slowly, with control, switch it out. Switch back. And the other side. Let's clasp those arms right at the base of your spine. Hinge at the hips, so flat back this time. Let's go ahead and lift on up. Squeeze those butt cheeks to come the whole way. All right, let's do that stretch and side lunge on the other side. All right, here we go. Toes forward, a lot of weight on the left. And let's go ahead and flicker here. I'm sitting down and back, squeezing my left glute as I go. I'm feeling a really good stretch through those adductor muscles on the inside of my leg. Good, we got 4 more. 1, 2, 3, and 4. Very similar to last time. Let's bring those feet together though. You're going to forward bend. You are going to plant your left leg. You're going to plant your left hand, bend this left leg, and twist on open to the ceiling. I want you to hold this for about 5 breaths. 1, 2, 3, 4, and 5. Let's switch it out. My right hand plants, my right leg bends, my left leg is straight. We're going to go to the other side. 1, 2,
All right, hey, Ann, thank you. And that was Carol Passarelli, one of our wonderful physical therapists at the CU Sports Medicine Performance Center in Boulder. Hey, thanks for the break. Thanks for allowing us to take a moment to get up and stretch and do everything we needed to do. So it's a pleasure again. We're going to get into the rotator cuff, and Dr. Meyer is going to come back and talk to us. He's one of the team physicians for the Denver Broncos. Get ready for the season. I know that's about all the football that we have this year. So glad you guys are playing, Braden. And thank you for giving us a talk on the anatomy, biomechanics, and healing of the rotator cuff.
All right, so get this started up. So obviously big topic. I'm very lucky. A lot of smart people are following me after my initial 10 minutes to kind of go in more detail. But I'm gonna give you just a quick run view, anatomy, some biomechanical thoughts, and obviously healing of the rotator cuff. We're looking at the anatomy. Let's jump right into it. 4 main muscles. Subscapularis is the largest of the muscles, has its own insertion site onto the lesser tuberosity, and has the main function of internal rotation, which we talked a little bit about earlier. The supraspinatus, which is most commonly torn and probably the biggest bugaboo for our rotator cuff pathology patients, has an insertion onto the anterior and lateral portion of the greater tuberosity. Main function is abduction. You can see here with the arrow pointing to the supraspinatus tendon. and a long head biceps tendon closely associated with this. The two posterior rotator cuff muscles, the infraspinatus and teres minor, they originate from the infraspinatus fossa and back of the scapula and insert onto the greater tuberosity. Their main function is external rotation. The anatomic footprint you're going to hear a lot about probably the next hour, because this aids in our diagnosis of our tears as well as repairing the tears, kind of looking at tear patterns. Subscapularis, it's on its own, has the largest footprint onto lesser tuberosity, and the infraspinatus has the second largest. And some of the newer morphology studies and anatomy studies show how this infraspinatus tendon posteriorly comes around, and you can see from this anatomy picture here, its fibers then insert and overlap on the top portion of the supraspinatus, so the ISP being infraspinatus. So it's a larger, has a larger emphasis during repair than initially thought. Anatomic footprint, this is getting into some of the deeper biology, but really 4 zones: the tendinous zone, the fibrocartilaginous zone, which is not calcified, then there's a calcified fibrocartilaginous zone, and then bone. And these are important when we're thinking about the healing properties. And so we're, again, adding things like biologics and augmentation, we're trying to reproduce this anatomic footprint. The biomechanics, you think about the rotator cuff, and we talked about this a little bit earlier. It actively compresses the humeral head into the glenoid cavity. There's short lever arms. It's a pulley system, a very functional high machine that we have for our shoulder. This establishes this stable and dynamic fulcrum, the golf ball and the golf tee. You can imagine if one of these lever arms was torn or weakened, the whole machine would be shaking and not doing very well. This is something I was interested in. I learned a lot about when I was in Europe, this critical shoulder angle, and this is just to show some of our morphology and sometimes things that we're actually born with, maybe introduce some of this pathology. So this is at a Gerber's group in Switzerland. There's 3 groups: a control group with normal rotator cuff and no arthritis. Group 2 was a full, MRI documented full thickness rotator cuff tear. And group 3 were patients with no rotator cuff disease, however, primary OA. They looked at this critical shoulder angle, which is this angle here with the purple lines that shows a vertical line matching the glenoid face out to the lateral edge of the acromion. And when they looked at kind of the averages of this angle, the control group was 33 degrees. The rotator cuff group that had full thickness tears was much higher, and the OA group was much lower. And you may think, okay, what does this mean? I think what it shows is there's definitely some biomechanics playing a part in some of our degenerative changes that we're seeing in some of our injuries. And so if you look at this in more detail, this picture on the left is the rotator cuff 38-degree group, and that was on average. The right shoulder is the DJD arthritis group with the lower angle of 28 degrees. And the main force vector of this is our deltoid. With the larger angle, the force vector is more superior. And so you're compressing the rotator cuff. The rotator cuff is getting worked a little bit harder with this angle. Whereas with the shorter angle, the smaller angle of 28 degrees, the force vector is more medialized, which is probably compressing our joint surfaces, adding to a little bit of arthritis. So things to think about, something I look at when I'm looking at x-rays of my patients may play a part when we're looking at healing of even partial rotator cuff tears. If they have a higher angle, may put them to a little bit higher risk of further progression of that tear. So rotator cuff healing, this is a huge issue. We'll touch briefly on it. Dr. Schlegel's going to go into more detail about techniques of the repair, but that's a widely variable thing with all surgeons. Patient factors need to come into play, including comorbidities and their compliance following surgery. There's implants and techniques, and then the biology, which is a huge topic, including stem cells, PRP, graft augmentation. But we'll touch a little bit on this. When we think about tendon healing, I think about 4 things. Think about the biology, how we're going to kind of reproduce that anatomic footprint and make it look like those 4 zones, make it look a little more like normal tendon. The technical side of it from a surgical factor. There's environmental and patient factors that play a part in this, and then rehab, which Ellen's going to talk about to us later, and I'll touch briefly on here. So these associated factors, even with COVID and N95 masks, you can still smoke, unfortunately, and that's a very bad problem when we're trying to get tendon to bone healing. The vascular supply is limited. You got to think about age, and you got to look at the size of the tear, diabetes, and quality of the tissue. A lot of associated factors. We're looking at healing of a rotator cuff that can be involved. Just a little shout out to the Inverness site, but we'll talk a little bit about rehab. Delayed versus early rehab has been looked at. We know that cuff failure occurs within the first 3 to 6 months, which is in the early phase of our healing process. Dr. Galotz looked at knowing that tendons like loading, so that it facilitates healing. So we want to load these tendons. So earlier rehab may help this. However, we're trying to protect our tendon repair. So what's the best thing to do? So a lot of studies, randomized controlled trials, systematic reviews, meta-analysis looking at this, still some conflicting evidence supporting both strategies. Cheng et al. In AJSM 2015 did a meta-analysis. It showed improved range of motion with the early rehab, which is what we want to see. However, it trended towards an increased re-tear rate with the earlier group for the larger tears. And so the conclusion was more maybe we should be individualizing this postoperative protocol to improve healing. So small to medium tears, maybe a little bit earlier range of motion. Large tears, we delay the rehab. These reported healing rates, you're going to hear a lot about probably these next several talks. It's extremely variable. Even some studies, including Dr. Galotz's study in 2004, which is an MRI and ultrasound study showing only 6% rate of full healing. So only partial healing and a lot of full tears. It really is variable anywhere from 6% to 90%. So we know we're still trying to figure out how to get this tendon to heal. Our ultimate goal is to obtain tendon to bone healing with this meticulous technique, really being patient specific and tear specific. We know that patients functionally do better if the rotator cuff heals. There's studies on that. Functionally, they have better range of motion and strength. I say functionally because overall, all patients do well, even if it doesn't fully heal. But functionally, we do know we want the tendon to heal to give them the best outcome. The tendon to bone healing, a little biology, this kind of, the healing begins with formation of this fibrovascular tissue between the tendon and bone and at the footprint site. Bone eventually grows into this interface tissue, and the collagen fibers then eventually laid down onto this. And so we're trying to, again, reproduce those 4 zones at the tendon-bone interface for an anatomic repair. There's 3 phases of the healing: an inflammatory phase, a fibroblastic phase, and a remodeling phase. And this is just a complex interaction of all types of growth factors in cells, way out of my league trying to discuss these things. But we do know that the tendon initially heals with a little more of what a scar tissue heals with, so primarily collagen 1 and 3, whereas normal tendon bone collagen is more collagen 2, 9, and 10. But so again, the biology and some of the augmentation we're doing is trying to make this tendon and bone interface look more like a normal tendon. Surgical techniques, again, I'm not going to discuss too much of this. Dr. Schlegel and the rest of the group is going to go through a lot of this with massive tears and repair techniques, but the ultimate goals are provide a high initial strength to reconstruct the anatomic footprint, and then obviously maintain this fixation throughout this entire healing period. We think this is at least 6 months out to 12 months and maybe longer. The technical considerations to include excursion of the rotator cuff tendon. I think Dr. Brobin's going to discuss some slides and tendon transfers, and our main goal is not to over-tension this repair. There's a lot of discussion and information about the technique of single versus double row, which is just how we repair the tendon at multiple rows of anchors versus 1 row, versus this kind of speed bridge, transosseous equivalent type techniques. And just a PubMed search, you can see, I mean, you literally can get information for days about that. And we know a lot. So a lot of evidence. We know that double row repair restores more of the anatomic footprint. We know that is mechanically superior to single row techniques. There's several meta-analysis, level 1 and level 2 studies that show higher healing rates, double row repair. However, we still have not been able to prove a significant difference in clinical outcomes. And these are over the last decade, so maybe longer term studies will continue to let us know if this is the right way to do it. Dr. Gennario in our group, Dr. Bobek and Dr. Schlegel looked at the cost effectiveness of double row repair. Unfortunately, it's not cost effective with rotator cuff, no matter what the size. However, you got to think about the re-tear rate and the long-term outcomes and possible need for future surgery, including a reverse shoulder replacement if they fail to heal or go on to rotator cuff arthropathy, or even a revision rotator cuff repair. It may make double row repair more cost effective if we look more at those factors. And so the technique, again, it is exhausting. There's a ton of things out there with technique, including the anchor fixation methods, type of sutures, knotless, anchors designs, including our all suture anchors that I like to use. We know just in general, the weak link is this suture tendon interface. It's the most common failure site biomechanically, excuse me, and then also what we see at the time of revision surgeries. A lot of factors can play into this: poor quality tissue, the vascularity, the patient factors, the surgeon factors. Do we do a good job? Were we meticulous with our repairs? And obviously mechanical over-tensioning and getting the excursion of the tendon. So that will lead us eventually down the road of we need to augment these repairs. What are we doing from a biology standpoint? What are we doing from soft tissue standpoint? Are we adding dermal allografts or synthetic grafts? What are we doing to make sure that we protect this wink leak? And so in conclusion, we know patients all do well clinically after rotator cuff surgery, even with this larger re-tear rate that we're still seeing on larger tears. Is double row repair better? Biomechanically, we think so. Cost effective, we're still yet to determine. And again, failures are again occurring at the suture tendon interface. And I think we need to learn a lot about our biology to make sure that we're getting this perfect. And references, thank you. Look forward to the rest of the talks.
Hey, great job, man. Thanks for the great overview, and good luck on Monday night with the Broncos. And next, it's my pleasure to introduce Sharab Podar. Dr. Podar is a non-operative sports medicine specialist. He's been a team physician at the University of Colorado for over 19 years. He is the medical director of the University of Colorado Athletics and a great friend and colleague. He's my roommate on the road. He doesn't snore too much. He's a great roommate, and he's also so thought of at the University of Colorado. He's been honored as a honorary letterman for the University of Colorado. Received his letter and letter jacket a year ago. So Dr. Podar is going to talk about how do we need to think about rotator cuffs and maybe the non-operative treatment of them. So it's not all about the surgery. So Dr. Podar, thank you for sharing with us.
Thanks, Eric. So, you know, as Dr. Meyer just kind of highlighted, a lot of our focus on rotator cuff treatment has really, and probably rightfully so, focused on the surgical techniques and approaches. And a very reasonable question, I think all of us realize, having treated patients, is does every cuff need to get fixed, and is there a role for non-operative treatment? And if so, what is that role? I don't have any disclosures. So if we think about injury and orthopedic disease in general, most of the time when we think about disease states, a patient will usually have increased symptoms with increased severity of disease. So you think about osteoarthritis, you think about instability, both glenohumeral and AC. Typically, the more severe the disease state, the more symptoms the patient will have. In the setting of rotator cuff tears, many are often asymptomatic. So one of the really important questions are, does pain really correlate with rotator cuff severity? So back in 2014, this was from the Moon Shoulder Group. You know, they looked to answer this question. Symptoms of pain do not correlate with rotator cuff tear severity. So they looked at about 400 patients. No measure of pain really correlated with any measure of rotator cuff severity. So that brings us out of our traditional thought processes when we think about disease states in this orthopedic realm. So it's very reasonable to subsequently think about, is non-operative treatment of rotator cuff tears effective? Now, one of the things I want to highlight here is we're not talking about acute tears. This is more in the chronic setting, which is the majority of oftentimes what we see in our clinic. So what is the success? So there's some seminal articles out there over the years, some older. This is a prospective cohort study with about 50 patients. Average age was about 60. Mean duration of symptoms was 2 years. So this is chronic rotator cuff syndrome. And these patients went through a home-based therapy program for 3 months. 38 of those 50, about 76%, declined surgery at 3 months because their quality of life and functional scores were adequate. And so that's interesting. So as we think about how do you treat shoulder non-operatively, how do you treat a cuff non-operatively? Obviously, physical therapy is the standard and hallmark of this. So what is the actual effectiveness of physical therapy in treating atraumatic full thickness rotator cuff tears? So this, again, was from the Moon Shoulder Group, and this won the 2011 Near Award, and this was seminal because as we looked at this, it really looked at is non-operative treatment effective. This was a multi-center prospective cohort. 452 patients were enrolled, and the average age of the patient was 63 years. All these patients, the inclusion criteria included atraumatic full thickness rotator cuff tears. They were treated with an evidence-based physical therapy program and followed in near term 6 and 12 weeks and longer term 1 and 2 years. So what was seen? So when one of the really key pieces in this study was the demographic and comorbidities were controlled for, and there were outcome scores that we traditionally look at for functional utility for patients. So the results, and I highlight this, if you look at 6, 12, 1 year, and 2 years, out of this patient cohort, ended up being about 20%. If you look at in total, went to surgery after a trial of PT. Most of who went to surgery, if you look back, did so within the first 6 to 12 weeks. And the results didn't seem to worsen with time. So I think that was kind of a seminal call for us to kind of consider this as this non-operative role in the treatment of chronic rotator cuff disease. So what are the patient outcome measures after non-operative treatment? If you look at what was presented in this and you look at the functional scores, the ASES, the work, and the SANE, from baseline at 6 and 12 weeks, there was a clinically significant improvement in a lot of these scores with non-operative treatment. So the conclusions from this were that a physical therapy program is effective non-operative treatment for atraumatic rotator cuff tears. I remember listening to a talk from Jed Kuhn several years back, right around this time when this was published, and he has this mantra that I still remember to this date, that MRI is the tool of the devil in chronic rotator cuff disease. So because what that goes back to is some of the original slides we were considering. Does what the picture looks like correlate with how the patient is doing? So as you look at this, the outcome scores improved over 12 weeks. Less than 20% of patients failed and ended up having surgery. So the other takeaway from this was that the effectiveness of physical therapy is really revealed early. The patients who chose to have surgery typically, again, do in the first month and a half to 3 months. And after 12 weeks, the effectiveness lasts at least a couple of years as this was followed out. So more recently, there was another surgical versus non-surgical management of rotator cuff tears. And this was really a matched pair analysis. And I really enjoyed reading this last year when it came out, because this is a prospective cohort. They looked at a little over 200 patients and really matched the groups. And again, these are full thickness chronic rotator cuff tears. And they really matched the groups, and there were no significant differences in demographics or tear characteristics between the groups. Both groups reported improvement in pain and functional outcome scores. But if you really look at the subset analysis and regression analysis, the patients who were offered and who chose rotator cuff repair reported greater improvement in their outcome scores and reduced pain versus those who chose non-operative treatment. And some of the mantra that we'll see also that will be highlighted and that we know is that the better outcomes are really associated with younger age, shorter symptom duration, and rotator cuff repair. So what about some of these biologic options? I know there's there's going to be, there's been mention of it, and Dr. Dragoo will have a nice talk later in the morning, early afternoon about this. But really, in the non-operative setting, in the non-perioperative or intraoperative setting, there's insufficient evidence to routinely recommend PRP for rotator cuff tendinopathy. And if you really look at injuries, PRP may reduce pain associated with rotator cuff injuries, but when you look at this meta-analysis and review, systematic review, there's a lot of heterogeneity in baseline, short and long-term follow-up. So we really don't know what the role of some of these biologic treatments in the outpatient realm would be. So what we need to do, and like in a lot of settings, especially with our biologics, is that we need to have more double-blinded, randomized control investigations with larger sample sizes and matched pair controls, and standardize our PRP preparations, which at CU we are in the process of doing that in a standardized manner across a lot of our sites, and we're looking at our biologic approaches. So with this information, how do we approach the atraumatic rotator cuff? So what do we need to consider? There are a lot of people who have asymptomatic rotator cuff tears. The results are good, even in the event if you have surgery and you have surgical failure, as Braden mentioned, oftentimes you do well. And there's no correlation between the severity of disease and pain. So we need to consider the variables, right? So, again, in a chronic setting, youth has its advantages. There's environmental factors, there's comorbidities, there's biology, right? Biology of tissue repair, and you want to think about the size of the tear as all really, really important variables to consider. So I think non-operative treatment has a role. It's definitely an option. If the patient fails this treatment, or obviously in an acute tear setting or tear in a younger patient, then surgery is obviously an option. I've got great colleagues that I refer to all the time and take great care of all our patients. So thank you.
Hey, thank you, Dr. Podar. Really appreciate that view. We've heard non-operative treatment of shoulder instability, non-operative treatment of rotator cuff, and now we're going to talk a little bit more about the essentials of repairing the rotator cuff. My colleague, Dr. Ted Schlegel, who has joined the University of Colorado several years ago, and he was the founding member of the CU Stebbins-Hawkins, at that time, the Stebbins-Hawkins Clinic in Denver, longtime NFL doc for the Denver Broncos. In 2012 was named the NFL Doc of the Year. He holds the Hawkins Sports Medicine Research Endowed Chair at the University of Colorado, named after his mentor, Rich Hawkins. And Ted has a lot of experience with rotator cuff. So Ted, we're happy to have you. Thank you.
Yeah, thanks so much, Eric. This is a great pleasure to be part of the symposium this year, invited back. Eric's always done an amazing job putting this together. And the only regret I have this morning is that we're not all together to be in a social environment, but hopefully next year we'll be able to do that. This is an area of great interest for me through my career. It's something that we started early, right after fellowship with Rich Hawkins, and really we're involved with a lot of what we call translational medicine, trying to understand the basic science around rotator cuff disease, how we could influence that with new technologies, show the effectiveness of that with some of the animal work, and then ultimately now look at the clinical effects of this. And it's a really exciting area. We have still a lot to learn. We're working now on a chronic rotator cuff model up at CSU with our team up there, and I'll kind of finish that up with what's the future hold for us. As it relates to my disclosures, let me, some reason not advancing here, sorry. Okay, here we go. Have no disclosures as it relates to this presentation itself. What do I want to accomplish in the next 10 minutes? There's a lot to cover, but really want you to understand a couple things. What is the natural history of an untreated rotator cuff repair? We've heard a little bit about that. in some of the earlier presentations, Dr. Meyer and Dr. Podar, but want to kind of hit that because I think that's really important as we're making decisions. What are the basic science principles that we need to think about when we're repairing rotator cuffs? What are the adverse factors? We've heard a little bit about that from the previous speakers. And then really, what are the future technologies that are promising to enhance rotator cuff healing? Always like to start with a case because I think that kind of frames the discussion. And in this case, we have a 28-year-old right-hand dominant professional football player who presents with complaints of primary shoulder pain at the end of training camp. So these we're always faced with, what are we going to do at this point? We're early in the season. Are we going to treat that patient non-operatively or operatively? And we always want to make these decisions based on the best available literature. So the physician really wants to know a couple of things. What happens if I don't do anything to this player? How's that going to turn out for him? If I wait, am I going to make the condition worse? And I think that's really always in the back of our mind when we're trying to make the decision. Is it reasonable for the player to get back on the field? And what is the timing of that? And what will enhance the best chance for a good outcome? And we want to base this always on the literature, the best available literature that we have. So we heard a little bit about this. Jed Kuhn is one of our great friends down at Vanderbilt and where Eric came from. The Moon group is fantastic, I think, as it relates to the research they've done. And Jed and I, along with Rich Hawkins and Neil Alatraj, were on these instructional courses over the years talking about the controversies of rotator cuff disease. And I have to say, the first time I heard Jed give this talk, I almost fell over. An orthopedic surgeon talking about non-operative treatment. But the work is good. Dr. Podar has pointed out why this is something to consider. And I think we have to think about this in the scheme of the patients that we're treating, particularly focusing on the word in this title, atraumatic full thickness rotator cuff repairs or tears. And Dr. Kuhn points out appropriately that we don't really know what is the cause of pain in patients. So maybe the cuff itself isn't the problem. Rotator cuff tears can be treated without surgery. That this data shows that. And really maybe the outcome is more about patient expectation. So that's one of the things I think that we really need to consider. Somebody that depends on where they are in a traumatic versus atraumatic, age and expectations are really ultimately going to decide whether a non-operative program is a good way to go. I have to point out this is the work that's been done is a case series level 4 evidence. So not the best evidence that we could have, particularly when we're looking at trying to make great decisions. So back to our player. So we got this player at the end of the season. As time's gone on, he's gone through the season, played. Now he has increased pain and weakness. And unfortunately, if you look at the MRI on the left side, it's a small tear. Now it's become a big tear. And at the time of surgery, we look in now arthroscopically and we see this large retracted tear. So this is a problem from the standpoint of how this patient's going to do with surgery, higher chance for this patient to fail. So the real question is, have we done this player a disservice by allowing him to continue to play? I like to go through this. I think this is really important as far as understanding the natural history of untreated rotator cuff tears. Full thickness tears do not heal spontaneously in humans. So we got to understand that once you have a tear, a full thickness tear, it's always going to be there. Second thing is full thickness tears do have a risk of increasing in size over time. Many good studies showing that, particularly some of the early ultrasound work done by Ken Yamaguchi and his group. And this is just what we saw on our player, that the tear does have a chance of increasing. We heard about this. Full thickness tears that do increase have decreased strength. So that's going to be more important depending on the type of patient that we're treating. And athletes in particular really want to think about giving them the best chance to compete. We do know that unrepaired tears have a chance to go on for fatty infiltration. So the MRI on the left shows a normal supraspinatus muscle, and the one on the right shows this atrophy that occurs. And at some point that the atrophy becomes so significant that we probably can't actually repair the rotator cuff. This study is actually interesting. I've seen this surgically, and Christian Gerber actually did a nice study looking at the fact that with time, not only do we get this fatty infiltration, but we also get a shortening of the tendon. And as we think about success with repairs, the more tension on the repair, the higher chance for failure. So once that tendon starts to decrease in size, then we have more problems. So where does that leave us? Well, we don't really know the rate by which the tear increases or the percentage of patients that have symptomatic tears. But I can tell you over the years of taking care of patients, we do see the number of patients requiring reverse total arthroplasty is on the rise. And we're really trying to limit that. So what are the factors that are most important in maximizing success with repair? This is some of the work that we did early in this kind of translational medicine. We're really trying to figure out what gives us the best chance. And Dr. Meyer showed that really there are these layers that occur where the tendon attaches to the bone. So any procedure that we're doing, we're really trying to recreate the normal zone of fibrocartilage, cartilage's interface. And that's going to be the success, ultimately restoring the normal tendon. The basic science were particularly early on, we were doing repairs open with transosseous tunnels. We were starting to make a transition to anchors, and we could do that now arthroscopically. So we did show that we could do successful repair by using anchors versus transosseous tunnels. And then we could start to put in stitch patterns that would allow us to get the same success that we did with open repair. So that allowed us for this transition to an all arthroscopic repair technique. It does take time for a tendon to heal, considerably longer than we thought. And some of the work that we've done, Christian Gerbers and others, really show that when we repair the tendon, it often retracts, and this is filled with this gap or a scar tissue, which is not as good as normal tendon. So whatever we do, we need to try to do the best chance that we can to get that tendon to heal the bone. I think this is really important as far as the rehab. We showed that the strength of the repair is very weak in the first 6 weeks, and strength improves. By 12 weeks, the strength of the repair is only 25% of the normal strength of the tendon. So whatever we do with the repair, we need to make it as strong as possible at time 0. And then we really have to be careful with our rehab afterwards. And I think that ultimately will allow for the best success. We've heard why do some tendons why do a lot of tendons not heal? Diseased tissue, poor blood supply, this fatty infiltration, increased force at the repair site, and some of the other factors that we really just can't alter as far as patient's age, chronic disease. So maybe that's where some of the work that we're going to do going forward with biologics will have a big impact. We do know that the size of the tear does affect success. So when we're looking at some of the early work with open repairs, 30 to 50% of the chronic tears failed, particularly the large ones. And Bruce Miller did a nice study with the best repair construct, double row repair, looking at ultrasound studies every 2 weeks, and showed that he still had up to a 40% failure rate. So it's pretty significant. And when they did fail, they usually failed in the first 12 weeks. What we really want to focus on is particularly an acute repair or acute tendon injury. You want to get to that earlier, and you don't want to really wait around a long time, knowing that the chance for success decreases. So what do I want to do? I want to fix small cuff tears in young patients because they have the best chance of healing, and I want to do everything I can to decrease the likelihood that they're going to go on and have significant problems. The future really for us is biologics, and we don't have enough time to really talk about that. I know Jason's going to talk a little bit about it, but this is where all our research is going now from the clinical, from the basic science side, and we're doing a lot of this work now with following patients clinically with mechanical stimulation, with pulsed ultrasound, PRP, scaffolds, and so we will report back to you as we have more information. So thanks again for allowing me to participate today, and I'll look forward to the discussion at the end.
Hey, thanks, Ted. Great talk. You've got great experience, and really appreciate what you're doing with all of that. Now we're going to have a nice session on looking at the massive rotator cuff, and we're going to look at everything from repairing it to partial repairing it to looking at tendon transfers to even doing a reverse arthroplasty. So the next talk is going to be given by Dr. John Brobman. And as soon as Ted Schlegel stops sharing his screen, we'll get Dr. Brobman on the screen. If you can look at your stop screen at the top or the bottom, there we go. And Dr. Brobman, we look forward to hearing how you might approach the massive rotator cuff.
Thank you. All right, I think we're good.
Looks great.
Eric, it's good. I had it on. It shared the wrong pane last time, so I think are we good? We're good now. We're good this time.
Excellent, man. We see the perfect PowerPoint.
You guys could have just interrupted me, you know. So formal. Anywho, thank you. What a great session again. I echo all the sentiments of just being able to come together and learn from everybody. Hopefully I can contribute a little bit here on massive cuff tears. And my task is to talk about fixing the massive tear or doing tendon transfers, and quite a Herculean task. I mean, I think we could have had a 3-day symposium just on this talk, but I'll attempt to get us through it.
Where's volume? Bottom right. Okay.
You guys okay? I don't know, someone's not muted there. Anyway, so what is a massive cuff tear? So in North America, Bob Cofield defined this as a 5-centimeter tear. The more traditional definition from Europe has been a 2 or more tendon involvement by Christian Gerber. And the clinical evaluation is critical, and you've heard a lot about this, and I'll touch briefly on it in that. You know, we want to really look at the patient. So what you see here, this is true pseudoparesis. So this is the patient trying to raise their arm. On the left side, we're looking at scapular winging. Bottom left here is infraspinatus atrophy, and we're looking at scalloping there. And then fatty infiltration, as Dr. Schlegel and others here have pointed out. And this is pseudoparesis with what we call escape. So I wanted to just point out that lag signs are a tool that I use frequently. This Ralph Hurdle has pioneered, and looking at a lag sign of 7 degrees in an isolated supraspinatus tear, and as that goes up, this involves more of the superior and superior posterior rotator cuff with a high degree of specificity. So I found this really critical. And what this is pulling the patient's arm out, particularly into external rotation and an abduction external rotation for the hornblower sign. And if they can't hold that arm there, that's a positive lag sign, and we can measure the degree measurement that's happening there. Superior migration is really critical, and this is associated with large and massive tears. And a acromial-humeral distance of less than 7 millimeters may indeed portend a completely irreparable tear and poor healing. Touching on what you'll hear many of us talk about, the Goutelier staging here. This was a CT-based study, and what we're looking at really is either the stage 3s and 4s, where the fat is at least equal to the muscle or more than muscle. And the issue here, why that's important, is that several studies have shown that there's no functional improvement with even attempted repair with 3 or 4 Goutelier fatty changes on preoperative MRI, and is a strong predictor of postoperative re-tear and poor outcomes. So how do we know if a cuff is repairable? So there's a concept of a functionally irreparable tear with muscle atrophy, positive lag signs, static superior migration, fatty replacement on MRI. And does a massive cuff tear equal an irreparable tear? Maybe, maybe not. What about the tissue quality? And what about the tools in our toolbox, right? So these are all things that are really important. And there are a dozen options for massive cuff repair. We can just debride it. We can partially repair. We can transfer tendons, a patch, the SCR. We now have the biodegradable spacer, and then finally the reverse arthroplasty. So I'm going to take a few minutes and digress into a little bit of a topic that I don't think is addressed elsewhere, but I think is really critical when we talk about this. So what about cost and cost effectiveness? And so the cost is variable. There's societal and systematic cost, there's hospital, but most importantly, what's the cost to our patient? And in the US, healthcare is 17% of our GDP, projected to be 20% by this year, $2.5 trillion in 2009. and expected to continue to go up. The direct cost of shoulder pain, $7 billion. The real issue here, though, is that we shouldn't be focused necessarily on cost, but taking a page out of my mentor's playbook here, JP Warner, is that what we need to talk about is value. And it's something that is not getting a lot of press, but really needs to. And I think our group here at CU and many others participating here are doing this. And I applaud the efforts, because this is the only way forward for us. And what value is the gain and benefit, be that survival, outcomes, patient satisfaction, divided by cost. And so this is based on 3 principles, and it shifts the importance away from the system and completely onto the patient. Care is organized around specific conditions, and that there has to be universal reporting of outcomes and results. And this is from Harvard Business School, Michael Porter and his colleagues. Rotator cuff over a 10-year period of time has shown a 141% increase in treatment, and shoulder arthroplasty a 250% increase. So shoulder care in regards to value basis is critical. Cordasco showed that outpatient cuff repair showed a 43% cost reduction and high satisfaction. Cuff repair versus observation in Vitale's surgery was highly cost effective, on par with many other standard medical treatments. What about arthroscopic versus mini open? The scope increased the cost. That's largely, we think, implant related, and similar to our own Jamie Gennaro's study showing single row versus double row, that their analysis showed that double row was not cost effective for any tear size. I would again emphasize that this is not a value-based study. This is a cost-based study. So I'm not actually sure that that is indeed a negative outcome. The economic value of shoulder pathologies has been studied, and the bottom line here is that we need higher quality studies. At least 50% are poor at best, and we need to do a better job. What about the economic value, again, for society? Cost effective in all populations. The lifetime societal benefit of fixing a rotator cuff for $3.4 billion in about 250,000 cuff repairs per year. However, as has been pointed out, is maybe highly age dependent, and that's probably a relation to most likely tissue quality. And you can see here that as you march down this table, as the 10-year brackets of age increase, the net societal savings decrease. So just as Dr. Schlegel pointed out, the ones that we want to be fixing are the young, active, small tears, such that they don't progress to fall into this group if possible, and if we believe in this. Cost effectiveness, I don't want to steal anyone else's thunder, but this was shown here in the setting of a massive tear and pseudoparesis without osteoarthritis. They tested 3 conditions: cuff repair followed by revision, cuff repair followed by reverse, or reverse, and showed that the most cost effective was attempted cuff repair followed potentially by reverse if they need it, though primary reverse did become cost effective when it exceeded arthroscopic cuff repair by only 0.04 quality adjusted life years. So now what? So there are so many new treatments, right? We have all these things, balloons and Regeniten patches and PRPs and SCRs and all this. So at what value and cost? So what if we have a massive irreparable cuff tear, but no DJD? So that's where I think we've really struggled. And this is where this concept of tendon transfers comes in. However, this is absolutely not a new concept. So latissimus dorsi for irreparable posterior superior cuff tears and the pectoralis have been worked on for decades now. And one of my mentors, JP Warner and Christian Gerber here, pictured in 88 when I was, I don't know, maybe I would have been in about 3rd grade. These guys were working out the biomechanics and the technique here, doing this with indications of mild to moderate weakness, an intact deltoid. They needed an intact subscap, no DJD or stiffness, and a motivated patient. This is what it looks like. And so it's kind of a big deal. This is a big operation. So lateral position, typically we do maybe not this big of an exposure anymore, but a reasonably large exposure, exposing posteriorly the latissimus dorsi, remove it from the humeral head. This has been modified, and more mini-invasive and arthroscopic assisted techniques are available, but still kind of a big deal. And this is brought open over the head to reconstruct the posterior superior cuff. And our ideal candidate is someone young with an irreparable tear. Primary complaint is weakness. Gerber and others have shown an excellent 40 to 60 degree improvement in forward flexion with satisfactory outcome greater than 80. The bottom line here, though, is that this is really difficult. It's a big operation. You need a really skilled system. in a really motivated patient to make this work. And I'd say most of us have honestly kind of removed this from our practice because of the difficulties surrounding that. So enter Bassem El-Hassan, our future Mass General Chief, back to where he and I both did fellowship. And he's done an amazing body of work at the Mayo, looking at different tendon transfers and improvement in line of pull biomechanically. And so this is a brief slide from some of that work with the latissimus dorsi and the lower trapezius, which we're going to talk about. And so showing that the line of pull can be biomechanically greatly improved to replicate the posterior superior rotator cuff. This is what it looks like. So a small mini incision over the back of the shoulder. We add an interposition graft, be it a hamstring autograft, or most of us use an Achilles allograft through the posterior open incision, and then hook that up arthroscopically to the rotator cuff. And this has shown excellent results, though the literature is somewhat limited. Bassem published on 33 patients. He showed 97% improvement overall and 50-degree improvement in forward flexion. So really nice results. What about the subscapularis? So this was traditionally the pectoralis major, and I think we've all done this through our career. However, the outcomes have been variable and unfortunately generally poor in some situations. That can be improved if it's transferred subcoracoid, if they have an intact posterior superior cuff, and if the head is, of course, centered. This is what that looks like that Herbert Resch described, an open technique. This has been somewhat modified to split this based on the heads of the the pectoralis. Though again, Dr. El-Hassan and his group have worked out a latissimus-based transfer, which improves the biomechanical pull, can be performed through a mini open harvest and then an arthroscopic assisted approach. However, unfortunately, limited literature so far regarding the outcomes. So what do we use when? And so my current personal algorithm is that if I have repairable tissue, they're indeed a first-time surgery, no DJD, and they're not pseudoparetic, so they can achieve at least 90 degrees of forward flexion, that patient in my hands gets a cuff repair. If this is the revision setting and they have functionally irreparable tissue, so that high-grade Goutallier-based tissue or tissue that we know we tried to repair in our own hands and didn't work with lag sign, particularly horn blowers without DJD, that's the patient that I think is indicated for tendon transfers. What about irreparable without lag signs? That's maybe going to be touched on in a later talk, but that's a patient that I would consider superior capsule or balloon based on patient demand. And then if they have those problems with DJD, that's a reverse arthroplasty. So remember, evidence, not eminence, should sway our decision-making. We need to get involved, follow our patients, honestly report our outcomes, and make changes based on those results. And I thank you very much for your time.
All right. Hey, thanks, John Brodman. Appreciate it. Now it's really a great pleasure to have one of our invited speakers, a nationally known orthopedic surgeon, sports medicine, and shoulder surgeon from University of Pennsylvania. Dr. John Kelly was a football player at Columbia in the 70s, was a lineman. He's gone on now and has been just a fantastic mentor to many orthopedic surgeons across the country. He is the director of shoulder surgery at the University of Pennsylvania, also the co-director of the Sports Medicine Fellowship. He's a great friend. He has been seen on Zoom quite a bit during the pandemic. He leads a weekly prayer session that he and I take part in. And we've both given many instructional courses on how to avoid stress. Although I think there's nobody better doing it than Dr. John Kelly, my good friend. John, thank you for joining us today. I wish you were here in Colorado, but next year.
Oh, I'm just honored, and let me sure I can share my screen here. Eric, I never. Can you guys see that? Or am I?
Not yet. Not yet.
Okay, I'm a technophile. How about here? Any luck there?
No, Dr. Kelly, go ahead and hit that green share screen button.
Okay.
And
yes.
then you'll select that file and then hit share.
Well, where's the, okay, hold on. The green button, I hit share screen. Okay, or say application window.
You're going to click the PowerPoint that you want to share.
Yeah,
Should
it
pop
says,
up.
it just says application window, entire
I
screen.
also have your presentation as well if you'd like me to share it on my screen.
Okay, I'm sorry. I worked on this before. It worked all right. I'm sorry. But let me try one last trick. And
Sure.
so I have it up here now. Not yet. Hold on. Let me get some. Okay, why don't you just put up my, hold on. I just had it before. Okay. Anyway, why don't you go ahead and share? I'll figure it out the next time. What do you say?
All right, Bob. we'll get it up. All right, Ellen.
So Ellen, thanks a million. And I just can I advance, Ellen? Or you?
Nope, you'll just have to say next slide, and I can advance
Next
them.
slide.
Sure.
Yeah. I'm working under a handicap, so I'm sober. Just bear with me, everybody. These are my disclosures. And next. So let's audio. You got a gift, Eric. You got a gift. You're a special guy. And when Eric calls, I listen. So anyway, next. So the PowerPoints here that, Dr. Braven is a lot smarter than me and better looking. Scope repair burns no bridges. We're talking about the myth of the crescent tear, oblique reduction, how the subscap holds a key and how grafts work. Next. And partial repair can reverse pseudoparalysis. We're going to talk about force couples, the subscap and the comma tissue, and how margin convergence is a lost art. Next. And so who can we help with a scope repair? If someone has, you can just keep clicking there, Ellen, you'll see the absence of escape, no significant arthritis, erosion of the acromion, clicking, and click. This is when I dial 303 Seidel, click, right? So next. And we're talking about force couples. So, the good Lord made it so they only need a business end of your cuff for it to work. And the upper subscap, the lower infraspinatus, or the business end of your cuff, they provide a stable fulcrum. Okay, next. And in our lab here, where I work, we found that if you cut the supra and infra in a rat, repair just the infra, the gait is restored just as well as repair both supra and infra. Next. So the supraspinatus is humeral head compressor, not a depressor. The depressors are the upper subscap and the lower infraspinatus. As Eric would say, that's where the ball game's played. Next. So the supraspinatus does very little to depress. So we're going to work by the depressors, which are the upper subscap and the infraspinatus. So next slide. So this is the cable. This is really the business end again of our rotator cuff. That's the upper subscap and lower infraspinatus. This is where we're going to confine our attention. Next. If you can get, just like Dr. Burkhart's picture here, in the suspension bridge, there's two key points fixation. That's how God made our shoulder. So there's a very, very important part of our cuff where the biomechanical stresses are principally concentrated. Next. And this is what the cable looks like in vivo. This is usually as the older patient gets, the more one defined it gets. Next. You're doing a great job, Ellen. I'm going to send you a little bonus check. So one of the themes tonight is I'm an arthroscopist. I'm minimally invasive. I don't do lat transfers, but I do other things. So the lost art, I think, is tear reduction. We're talking about how we can mobilize these large cuff tears, release the inferior capsule sometimes, and we're going to excavate the cuff from the acromion. I think margin convergence is a lost art because we have so many people selling anchors, double row, triple row. I think we've lost the art of tear reduction. Next. So I'm a lateral to Q person. I respect beach shear, especially for cuffs, but this is the way I was trained, the way I learned. And I use these three portals. You can keep clicking there, Ellen. And I promise I'll fix the next talk because the next talk's a lot longer. It has some funnier videos too. Next. And what I do is I release, a couple releases I always do. I release the coracohumeral ligament, but I'm careful not to injure what I call the comma tissue. We'll talk about that in a minute. Next. And then I go up top and I release all the scar to the acromion, to the spine of the scapula. And I don't do what we call interval slides because I take this vascular tissue and I think I make it worse. So I don't, and there's Korean literature to support this contention. Next. And then I look for what limb is mobile. And I think that U shapes are very rare, but most of the time you'll see a mobile limb and you have to reduce it to where it belongs, usually no oblique reduction. Next slide, please. So we were taught for years that a supraspinatus footprint is very wide. And we learned, you can click, Ellen, that that's not so true, that the lateral supraspinatus footprint, next slide, is only about 1.3 millimeters wide, which means that every time you see this more than 1.3 millimeters of lateral footprint exposed, there has to be a posterior element, usually sometimes anterior, but there has to be a additional component in the supraspinatus. So next slide. And you click the videos too. So when you see what we call a crescent tear, it's not really crescent because one limb is usually mobile. You click the below one too, Ellen, thanks. So I'm a big believer in oblique reduction. Next slide. I think we've lost the art of oblique reduction. This is how tears belong restored. They don't always deserve a double row because you have to get that side-to-side component. I think we've lost the art of that. So when I see dog ears are done, that usually means they're not reduced. When you know your tear is reduced, you won't have a dog ear. Next slide. So this is what we do, most of us, double row, but I don't do that. Only in acute tears will I do double row. Next slide. And it's a whole can of worms, and I'm sure we'll have time maybe later on for questions. Next. So you have to play a little sleuth work and say, where does this tear belong? So hit this clicker. So most of the time, there's no a mobile limb. We got to figure out where it belongs. Next, please. So this is what happens. There's usually a mobile limb. Next slide. And we got to figure out where that belongs reduction-wise. Dr. Burkhardt, who's been the pioneer in this, even in his writings in 1999 or so, says that tendon to tendon healing is important and margin convergence only versus tendon in the bone. Next slide, click. There's no difference. And this is Steve Burkhardt's writings. I have a good friend, Craig Morgan, doesn't use any anchors now. I think that's a little too far, but I do think that there's some wisdom in we've lost side-to-side repair. Next. So that's not what I do. Next slide. So what I do is find the oblique rim, click, and then I'll obliquely reduce it. And next slide, Ellen. And this is what we work hard to do, is to get that reduction, right? It's like reducing a fracture. That's what you want to see. Next slide. Now the subscap, you haven't seen it, but it's seen you. In our series, we have over 90% of our massive tears that subscap tears. Next. And this is the edge of the subscap. There's something that God gave us called the comma tissue. And you can click it, Ellen. We did a study in our lab, Eric, that the comma is actually 50% SGHL and roughly 50% CHL. And that's going to tell you where the subscap belongs. But we save this comma tissue because, next slide, it gives us something to sew to. Click. So the comma tissue is really not only part of the superior cable, the inferior cable, but it also, if you look at the arrow, gives me tissue to sew the infraspinatus to. So next slide. I am always careful to save the comma tissue. Okay, click. And it restores our cable. Next slide. And if those of you don't use a 7-degree scope, please, for your subscap, it makes it much easier. Next slide, please. To give you an idea, what it can do in terms of reduction of the tear, after I mobilize the comma tissue, there it is. It's a lot closer to the infraspinatus. Next. So I can go up top and sew. Now look at this big hole here where the subscap is torn. You'll see a huge gaping hole. Next slide. Once I fix the subscap, Eric and Jonathan and Rachel, whoever's on the phone, look how much smaller the hole is just by fixing the subscap and advancing the comma tissue. Next slide. So then I go up top and I sew whatever is left. Now, there's some studies that this works about as good as anything. Next slide, please. And the SCR has maybe realized tissue doesn't have to always be the greatest quality. And then I'll sew my comma tissue to the infraspinatus and get usually most of the time, most coverage. Next slide, please. So I finish my repairs, Eric, with tape, and I keep the footprint usually unscathed. Next slide, please. And I will tension the tear with tape and get, you're not looking for 100% coverage, you're looking for mostly covered. So you can look something like this. Next, please. And you won't always get full coverage, but if you get the infraspinatus and the subscap fixed, I'm no God-given, I'm no Buddy Salvo, but I got a lot of happy patients out there. Next slide, please. I keep the footprint. This is a double row that failed. I came to my office. The footprint is, this is a anchor graveyard. There's a very little tissue for the cuff to grow to. So I think the footprint is sacred ground. Next slide, please. So you don't need full coverage. Steven Snyder, who I trust, just like Eric, an honest guy, you can get a mostly covered cuff. Next. And Dr. Snyder has given us the whole concept of the crimson duvet, or microfracture of the tuberosity, and you'll get fill-in. And I've seen it myself from his work, actually. Next slide, please. I will sometimes use the biceps tendon, and many people are now using the biceps as an SCR equivalent. That's a good option. But I'll use it, whatever tissue is available. Next. And I will use microfracture of the tuberosity. I'll use tape. I'll use ripstop sutures, whatever it takes. And I'll leave my margin conversion sutures long. Next. And what I'll do, Eric, is I'll incorporate that into my lateral anchor. So you see a cuff tear like this, you say, okay, call the priest. Well, let's take our steps. If you do margin conversions, next slide, and know where the tear belongs, start reducing the tear, and all of a sudden it starts being covered. And I'll leave these sutures long, and I'll incorporate that into my lateral row. Next slide. And I'll tension it. So this is what it looks like after a microfracture tuberosity, leaving the tuberosity unscathed. Next slide. And this is what it looks like at the end. So mostly covered, not fully always, but mostly under minimal tension, nature abhors tension. Next slide. And this is what we look like. And again, I'm not hitting them out of the park, all these cases, but I have a lot of happy patients. Thank be to God. Next slide. If you know where it belongs. And sometimes you get it fully covered like this. Margin conversions, tape, and you get full coverage under minimal tension. Next slide, please. The issue I got with double row is that most of the studies, all the studies I come up with, are on acute cadavers. Now, I will use double row in acute tear in a young person. Next slide. But every study I came up with, John and Eric, are on acute tears. That's not what happens. They retract along the line of pull. So next slide, please. What happens in nature is retraction along the line of fibers like this. Next slide, click. So I think that a lot of this is industry driven, and I'm sorry I get my Irish up, but it's all about the Benjamins, right? Next slide. And every anchor we use is about $375. Plus, if you tension it too much, you'll get what we call type 2 failure, which is very difficult to fix sometimes. That's due to medial tension. Next slide, please. So when do I use grafts? I use grafts, A, when I don't run out of gas, and B, when the tissue quality is really poor. If I don't get about 70-80% coverage. And Alan Barber is an honest guy, just like Eric is, and he showed that if you use a graft augmentation, you get about double the success rate. Now, at our hospital, we have tough insurers in Philadelphia. They don't pay for these new products that are out there. So I do the old spun. Next slide. I use my own graft, and I put some sutures medially and laterally, and I end up augmenting. And I think it is a good thing in the right patient. Not everybody. And again, depends on my age. If I run out of gas, then I'm like, I think I have most of it covered. It'll probably be fine. Next slide. Now, the SCR has been the explosion, and everyone's doing this. It's a biologic solution. It's a biologic reverse. Next slide, please. And this is one of the first ones I did. This is a marine, and this has a, as Jonathan showed, the horn blower. He's going to have a lag sign. Next slide. This is 9 weeks post-op. This is like 7 years ago, Eric. I'm like, there's something to this. There's something to this. Next slide, please. So I use Bill Pennington technique, and this is his technique that he uses push-in anchors, and it's made the technique a lot easier for me, and it keeps the suture salad much more manageable. So I use it. Those of you, we just wrote a book, and his chapters in this, he does a wonderful technique. He's done more SCRs than anyone in the world, I think, Bill Pennington, Wisconsin. And I use this technique. Next slide, and it's worked well on my hands. And this is a patient I had a failed SCR. She didn't want a reverse. She's only in her late 40s, 50s. So I did a revision SCR on her. And thank God, this is, look, as most studies show, the lateral footprint's intact. Next slide. She went on and did very well with this Pennington technique, push lock anchors, double row laterally. Next. So if you look at the results of SCR, depends who did it. Mihata, incredible, ASCS score is 93. I have not done that well. I've done like 22 of these patients. My results are mixed, but Bill Pennington has an honest guy, Green Bay, Wisconsin, 82 SCS scores, but he noted a 2.6% increase in the humeral acroma interval, which is encouraging. Next slide. So you got to know when to hold them, when to fold them. If I see a Hamada 4, which means arthritis, then next clicker, you got to, pick your battles. That's when I call Dr. Seidel and get a reverse. Next. For the therapist in the office, we have some lab studies here where I work showing that immobilization helps rats not only healing, but also diminishes inflammation. So I go real slow. I don't start PT till 3 months after SCRs and my large cuff repair. So next slide, let's just talk about the results. Buddy Salvo's group, partial is as good as full. Next slide. And in our own massive repairs, we had Penn scores of 70, not quite as good as 85, but this was a survey I did a few years ago, but the patients were happy. Next slide. I only use 1.3 anchors. So in summary, partial repair can help a lot of patients. Look for the subscap, question a crescent tear. I use double row for acute tears. I use grafts. I use SCR unless there's arthritis, and more invasive options should be the last resort. So for the audience, what would you like? Next slide. For your loved one, do you want this or would you like this? Next slide. This is my Glenosphere prep. All right. Anyway, thank you. Next slide. Thank you, Brother Eric. And I'll get this video stuff worked out next time. Thanks for your patience.
Hey, thanks, JK. I appreciate it. And we look forward to your Energized for a Lifetime talk. And you mastered the stress very well of not having that come up. So good job. So thank you.
It's called prayer, brother.
So, all right, Dr. Seidel, he was on a flight, so I think we're having a video of his talk. Karen Belmore, if you could put on the video of Dr. Seidel. He's trained at Thomas Jefferson for his shoulder elbow fellowship. Great colleague, has done a terrific job in the shoulder elbow with us, and we look forward to hearing the talk. Thank you, Karen, for starting that.
Good morning. My name is Adam Seidel. I'm a shoulder elbow surgeon at the University of Colorado. I want to start by thanking Eric McCarty for the opportunity to present. So I'm going to be talking about massive rotator cuff tear, and I'll try to convince you that reverse shoulder replacement is the best option and the way to go. So I'm going to spend a little bit of time talking about the function of the rotator cuff, as well as natural history of rotator cuff tears and the natural history of rotator cuff repair. I will talk about risk factors for failure of repair, which is why reverse shoulder replacement is an option for some patients, and then just go into a little bit of detail as far as who gets a reverse from me when I'm evaluating the massive rotator cuff tear. Looking at patient characteristics is one thing and tear characteristics as another. So just a brief overview of the anatomy. I'm sure this has been hammered in this morning, but rotator cuff is 4 muscles, 1 up front, the subscapularis, 1 on top, the supraspinatus, and 2 in the back, the infraspinatus and the teres. The function of the rotator cuff is quite simple. It is to keep the humeral head centered and to allow the big muscles around the shoulder to do their thing. So the deltoid, the pec, and the lat. And then obviously in the horizontal plane, the infraspinatus and teres are responsible for external rotation, and the subscapularis is responsible for internal rotation. Rotator cuff disease is a very wide spectrum, ranging from tendonitis to rotator cuff tear arthropathy. So I think it's very important to remember what we're talking about here when I'm talking about reverse as an option. We're not talking about partial thickness, low-grade rotator cuff tears. Obviously, I would not consider reverse in those patients. We're also not talking about end-stage rotator cuff tear arthropathy, where reverse is a no-brainer. What we're talking about is these kind of tears, which are massive rotator cuff tears without arthritis. It's important to understand that rotator cuff tears are very common in general. 30% of the population has a rotator cuff tear, correlates with age. So the frequency of full thickness tears in patients aged 60 to 70 years old is 20%, and it goes up to 80% in patients over the age of 80. Partial thickness tear over the age of 60 is about 25%. So what I tell patients is that if I go on the street and gather 100 patients that are over the age of 60, about half of those patients would have either a partial or a full thickness tear of the rotator cuff. So it's quite common. So we know that it's common, so why not just fix it? Why don't we just repair all these tendon tears? Well, we know that the re-tear rate following rotator cuff repair is quite high. It's consistently reported anywhere between 20 and 50%, up to 70% in a revision setting. We know there are certain patient and tear characteristics associated with healing, and we know that mechanical repair techniques don't seem to alter the re-tear rates. So I think it's important when I'm talking about this and I'm talking about re-tear rate, what I'm likely talking about is a lack of healing of the rotator cuff repair. So here's a study that was done, published a while back in JBJS. So looking at 18 patients with large tears following rotator cuff repair, and 17 out of these 18 patients had a re-tear of the rotator cuff or lack of healing of their rotator cuff, and their functional scores, their patient-reported outcome scores, decreased as time went on. So initially they did okay, but as time went on, those scores decreased significantly. Predictors of repair failure. So again, a lot of times these tears do not heal. The biggest predictor of repair failure is age, also tear size, the level of or the degree of fatty infiltration, best visualized on the MRI. Other factors: smoking, the chronicity of the tear, obesity, and comorbidities such as diabetes. So age and size are the biggest predictors of if a rotator cuff repair will work. So if you look here, as you focus on the massive tears, which we're talking about today, patients 50 years and older have a 43% chance of healing, whereas patients 80 years old and older have 17% chance of healing. So really poor healing rates overall once you get into that massive tear category, and very poor once you're in that 70 to 80 year old age range. So options other than repair, which a lot of these have already been discussed. So simple debridement, which is something to consider, biceps tenotomy or tenodesis, tendon transfer. Again, I'm going to focus on reverse shoulder replacement, and then superior capsule reconstructions. So why reverse? Why do I recommend a reverse in some of these patients? There are predictable results with reverse shoulder replacement, in particular pain relief. So most of these patients get quite good pain relief, restoration of forward elevation. So most people after a reverse shoulder replacement are able to get their arm up over shoulder height over their head, and the patient satisfaction is quite good after reverse shoulder replacement. The other thing to consider, and this is not the reason to do the surgery, but it is something patients are interested in is the length of recovery. So my general rule is that for rotator cuff repair, patients are going to take a full 6 months, if not longer, to recover. This is the same for superior capsular reconstruction. For a tendon transfer, it's typically greater than 9 months. For reverse shoulder replacements, most patients are quite happy around the 3-month time point. They have really good pain relief. They have restoration of function, maybe not full function or their maximum function, but they're in a pretty good spot at 3 months, much quicker than the other surgeries described. So how it works, so quite simple. I told you before that the rotator cuff functions to keep the humeral head centered on the glenoid so that the deltoid can do its job. When the rotator cuff is deficient, a reverse shoulder replacement can serve that function. So it stabilizes the joint. It allows for a fixed fulcrum for the deltoid, and it allows for the deltoid to work and lift the arm up over shoulder height overhead. So who gets a reverse? In my practice, this is older patients with a massive tear, patients with a true pseudoparalysis with a massive tear, any massive tear with underlying or concomitant glenohumeral arthritis, and then patients with multiple other risk factors for failure of alternative treatments such as SCR. So this includes a irreparable subscapularis and multiple comorbidities such as diabetes. So this is a symposium to discuss athletes. So why am I talking about reverse shoulder replacement? There have been several studies actually recently looking at return to sport after reverse shoulder replacement. So in general, the return to sport is very high, greater than 80%. Now, these are different sports than we may be talking about otherwise. I'm primarily talking about golf, tennis, and generalized fitness, as well as swimming. So if you look at the numbers, about 84% of patients were able to return to swimming, 77 return to golf and fitness, and almost 70% return to tennis. So those rates are quite high after reverse shoulder replacement. So in conclusion, massive rotator cuff tears often can't be repaired, and they have a very high rate of not healing. Age is the biggest risk factor for failure. Reverse shoulder replacement should be an option for these patients, but patient selection is very important. The surgery is not for everyone. It's typically not for young patients, just given the longevity of the implants. It does produce predictable outcomes in the right patient, and most of these patients are able to return to sport. But again, those sports are typically golf, swimming, or tennis, as opposed to any higher level or contact sport. I apologize that I won't be able to be live to answer questions today, but do not hesitate at all to reach out to me via email if you have any questions about this talk about reverse shoulder replacement. Here's my email. And once again, thank you very much for the opportunity.
Hey, that was great talk, Adam, and maybe you'll see this later, but appreciate it. And now we're going to wrap up this session on the rotator cuff with Dr. Shanley. He's going to come back on and talk about the principles of rehabilitation after rotator cuff repair, and then what about guidelines for return to play. All right, Ellen, thank you for coming on one more time.
Thanks, Dr. McCarty, a pleasure. So we've just looked at 6 talks about rotator cuff tears, and I think this goes to speak to how difficult the treatment of rotator cuff tears are, and how many different opinions we have. And with that, there's probably as many different and varied opinions about rehab after rotator cuff tear. So my disclosures remain the same. The biggest challenge with rotator cuff post-op rehab is balancing healing with time to function. So we know that we don't want people to get tight or lose their functional ability, but there's nothing worse than having a patient who can't function appropriately because they didn't have their rotator cuff repair heal, and maybe we went too fast. So we have to balance those things, and that starts with making sure we understand the considerations and the time frame to the development of the problem. So is it really a mechanical or chemical problem, or more likely both types of problem with
things like poor vascularity, altered biology, smoking has been talked about. If the problem is long-standing, then we have other impairments to deal with, such as decreased acromial-humeral distance, maybe some additional joint problems like osteoarthritis, scapular dyskinesis, and altered muscle activation. This time frame leads to increased stiffness of the tissue, which gives us concerns about long-term extensibility and functional flexibility for patients. But in addition to that, it also gives us problems with tissue quality. So Dr. Meyer talked so eloquently about the cuff insertion, and I think he hinted to and even said that when we have a cuff repair, it doesn't necessarily recreate the tendon in its original format. So we have different types of collagen, and with that, we have different types of concern about the healing, and so we have to respect that. So there's some primary factors that we use to choose the post-operative course we have following rotator cuff repair. We talked about age-related changes. We know that Boileau in 2005 told us that in 55-year-olds, 95% of them typically heal with a small rotator cuff tear. But 10 years later, only approximately 60% of those same people will have healing tissue. Fatty infiltration, tendon healing timeframes, the tendon's response to immobility and remobilization are all important characteristics to consider. And we know that failure really has some indicators to it. For functional outcomes, the increased time from tear to fixation, this acute with chronic or chronic with acute tearing or chronic tearing, increased age as it's been talked about several times, and then decreased preoperative forward elevation, range of motion, and strength are strong indicators that our functional outcomes are in question. We know there are anatomic outcomes that of increased tear that have been associated with things like tear size, retraction, tissue quality, fatty degeneration, and then also other biceps pathology. But functional outcomes don't have to equal anatomic outcomes, especially if we're careful with the rehab process. There are other factors included in these things that we need to consider, not only the duration of the problem, but does the person have any mobility issues that we should pre-op or prehabilitate before they go on to surgery? So if they have mobility problems where they would need a walker or a sliding board to transfer, it often helps to clear up those problems before they had surgery. Why they came to surgery, was it pain? Was it function? Was it a combination of both? Are there goals to become or go back to CrossFit activities, be a laborer, be a golfer? Or are there some more limited goals that the patient is willing to be happy with? So what is known is that clinical outcomes are widely reported to be good, and that's irrespective of some of the anatomic failure or anatomic issues that occur. 98% of the failures occur in the first 6 months, and as Dr. Schlegel said, we only have 25% tensile strength by 12 weeks. So size and recovery time do matter in planning the postoperative rehab. This is a table from the American Society of Shoulder and Elbow Therapists publication in 2013 that was provided in a JSES, looking at the pathway for rotator cuff rehab. And you'll notice that the pathway is really built on not only what we know about rotator cuff repair and all the things around rotator cuff repair, but also what we know about EMG activity of exercise. So you see phase 1, 1 to 6 weeks, and phase 2, 6 to 12 weeks, really isolate exercises that put decreased EMG activity through the repair site, so less than or equal to 15%. Also emphasized is decreased ultimate loading and decreased cyclic loading. If we look to the next two phases, 8 to 16 and 12 to 20 weeks, we really escalate the EMG activity from 16 to approximately 30%, and then 30 to 49%. You see in that 8 to 16 week time frame is the first time frame that any activity in part of the rotator cuff is active or resistive. And then in the 12 to 20 week period, we start with some elastic resistance so that we can progress people that are appropriate into phase 4, which is greater than or equal to 50% strengthening. This appropriateness is based on tissue repair, tissue quality, the report from the surgeon, patient preference, and patient goals. If they're not returning to high level function, then we minimize the stress that we put through that tissue. So the summary of that is for the first 4 to 6 weeks, we're careful to load slowly across the tendon, and we control load by loading or limiting the range of motion, limiting the speed of motion, and making sure we're respecting the inflammatory and healing response. We gradually introduce stress during the maturation period to help the tissue mature. And we don't use pain as our guide because we know that isn't always the best predictor of injury. Often patients show increased inflammatory response and injury prior to experiencing pain. So if you look at the pathway for the smaller to larger repairs, you'll see that in phase 1, the larger repairs are delayed by 3 weeks, but essentially go through the same process. In phase 2, they're delayed by 2 weeks, but essentially, again, go through the same process. In phase 3, it's a 3-week delay again. So the implications or the important tenets are education, so the patient understands expectations and what they should do, protecting range of motion, and slowly, progressively loading to increase function. So the rehab plan should match the surgery and the patient's available range of motion. Risk factors for stiffness, calcific tendonitis, adhesive capsulitis, and partial repair. Additional range of motion exercise is effective at the end parts of rehab in order to restore the range of motion. We know that delaying stress to the tissue is important. If we do manual therapy, to make sure that we do it in areas where there's less stress on the tissue and we don't create gap formation. So in summary, controlled loading and return to activity are preceded by no heavy lifting for 4 to 6 months, and our progressions are listed here. The central question is, how do we load the repaired tissue and make sure we get the physiologic adaptations of the surrounding tissue without stressing the repair? Thank you.
Thank you, Ellen. Thank you for your time today and for sharing us so much. You know, I've always enjoyed you at the national meetings and really appreciate you being with us, and look forward to seeing you in person. We get you on the field, and hopefully that's next year. If not then, maybe the year after. But thank you, and thank you for today.
Appreciate it. Thank you.
All right, we're going to take a 5-minute break here right now before we come back. So slight alteration in the schedule. We're going to take a break, and then we'll come back at 10:55 with Dr. Kelly for the keynote address. And why don't you start the stretch break number 3? Thank you.
Hi, I'm Heather Thomas, as well as physical audit instructor. I'm here to get your heart rate going. So here we go. And warning, if something doesn't feel good, do not do it. First thing is just going up on your toes 10 times. You can take your arms up, do a stretch at the same time. We're doing 10. There's 5. And 6, reach for the stars. If you're arms, 8,
All right. That was Patty. She did a great job. Thank you, Ann and Patty, for keeping us stretched. The weather's not quite like that today. You know, we got still got snow on the Flatirons. Now we're going to see if we'll go for round 2 of Dr. John Kelly and see if he's going to be ready to take us and tell us how to stay energized for a lifetime. Again, Dr. Kelly is well known for what he does in stress management, and I think he's got. Is that your fellow there? Who you got helping you out there?
That's my revered office manager here. So, can you see the screen now?
No.
Okay, hold on. Let's see what we got. Let's see, Eric.
Sorry for the delay, everybody.
That's all right.
If Will can't fix it, it can't be done. It says share screen. Application window. Here we go. We got it. We got it.
You got it?
Yes, you do. Hey.
Hail Mary, full of grace. Oh boy. Will, you the man. I'm just going to give my office manager another raise. So, we ready?
Bring it on.
Okay, buddy. Well, these are my disclosures. They're all literary. And I tell you, I can't tell you guys enough about the Reverend McCarty. He's a friend to die for. And, you know, I was a decent football player. He was a great football player and an even better person. This is Mary Elizabeth, who lives in Denver, and her future husband, Chris. I want to make as many visits as I can out there to the Reverend and Miriam. But if you can hear this, Eric, you got a gift, my friend. Yeah. That's right. That's why he is. So we live in a stressful world. This is a typical day in healthcare, sports medicine. It starts out pretty good. And then say hi to the camera, Mom. Goes downhill. And before you know it, your whole day is a disaster. So this is serious stuff. Burnout is on the rise. You know, up to 56% of PGY2s are burned out, and 40% of surgeons in general surgery field, particularly in medical students, any of them in the audience, 47% of you are burned out at one time, 50% of residents, physicians, 46% by Shanafelt. I married an ICU nurse. The second highest rate of PTSD is SICU nurses and behind combat veterans. So we're here to talk about what I learned the hard way, how to stay energized the entire life. We're talking about managing your ego, how to live in the moment, how to prioritize relationships, protect boundaries, the hard no, the slow yes, and how to nourish your soul and live a meaningful, honorable, service-filled life. You know, we have a choice. We have decisions we can make every day. God gave us free will. We can decide to minimize energy drains. We can maximize energy sustenance. So the big question would be, how happy am I? Because happiness matters. It's a great book. There's several books I want to mention in the course of this talk. Maybe you can write these down and give Ellen the handout. But there's a book by Sean Aker called The Happiness Advantage. And he says that, you know, success doesn't lead to happiness. Happiness leads to success. People that are happy are more creative, they're more motivated, they're more resilient, they have more energy. And you know, those of us that provide care, they have more compliant patients. We provide better care, we have more to give. And in Philadelphia, where I get sued BID, happy providers get sued less. So tell me, folks, would you rather listen to this person for instructions or this person? You tell me. So this is a great book that those of you who haven't read, anyone over age 20, I give this to my kids. This was a classic when I was a resident. Stephen Covey back in the late 80s. Your life is a product of your decisions, not your conditions. Which means this is Viktor Frankl, who Covey expanded on his work. Between stimulus and response, there's a space. In that space is our power to choose our response. In our response lies our growth and our freedom. So we have the ability in every event to choose a response, right? We have free will. And Franco goes on to say, everything can be taken from man, but one thing, the last of human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. This guy is a hero. He's a Holocaust survivor, Auschwitz, and he wrote about his experience. He said, everything but one's attitude can be taken away. So the Navy SEALs take this concept of ownership. Own your stuff, own your happiness, own your marriage, own your practice. Things aren't going well in your life, own it. So people that own their lives recognize that our ego is always working to sort of sabotage our success, sabotage our happiness. You know, our ego, and the real word ego stands for, in my belief, edging God out, right? It's a pseudo self. Our mind creates it. It's selfish. It's never satisfied. It separates us. It enables accomplishment, but at the expense of happiness. I know a lot of big egos in medicine. They accomplish a lot, not very creative stuff, by the way, but they accomplish much, but they're never happy. How do you handle your ego? First of all, you have to be aware when it's activated. You know, whenever we're really angry, defensive, fearful, when we're judgmentally, particularly, when we're perfectionistic, that is our ego at work. How do you know to get away from it? Recognize that this is not going to bring you peace. I create space. I just watch it. I watch it, and then I act upon my values anyway until I get to my present moment, until I connect to my source. So we're not our feelings. We all get negative feelings. We get bombarded with negative thoughts. Negative thoughts happen, just like your heartbeat happens. You know, you can believe these thoughts, or you can just create a little space. You can just watch them and realize that they're not us. They're just feelings, right? And then we can choose, because our God-given free will, what we give attention to. Perfectionism is something I struggled with for years. I still do. Perfection is an illusion. It's associated with anxiety, depression, eating disorders. And those feelings of perfectionism, they're not from your source. You're always feeling like you're falling short. And I'll be the first to say, I've been in practice for 30 wonderful years. When I first started practice, Eric, I would do this 60-minute meniscectomy. It had to be perfect, right? Boy, was I tired after 2 cases. That didn't last long. So how do we get rid of some of this baggage? We have to learn to be resilient, to live in the moment. Living in the moment has been called the end of suffering by many spiritual writers. Anxiety, worry, guilt, obsessions, grudges, judgment, perfectionism, all that stuff goes away when you become present. And also, when you can live in the moment, you get clarity. You can connect to your source as you see your universe, your God. You know, over 2,000 years ago, the Chinese wrote Lai Tzu. If you're depressed, you're in the past. If you're anxious, you're in the future. If you're at peace, you're living in the present. Amen. You know, when in the moment, our relationships blossom. We're open to inspiration, passion, enthusiasm. The word enthusiasm is from the Greek, entheos, in God. We forgive. We forget. Every day's a new day. And then we can bring our A game to work and at home. When our twins were little, my wife and I were both stressed out. We had some battle royales. Like I bring that baggage to the OR. And now I realize, you know what? Yesterday was yesterday. Today's a new day. And my faith, you know, is a great expression. Don't let the sun set in your anger. Such wisdom. We're in the moment, we're more efficient. There's lots of literature now about multitasking. It doesn't really work. We think it does, and we all do it still, but it doesn't really work. Let's watch Kramer drink and smoke at the same time. Now, do you think he's enjoying either one, the cigarette or the beer? I don't think so. When you do many things at once, you lose the quality of what you do. How do you develop mindfulness? Well, you have to practice. This is a great book, another book, number 2, The Power of Now by Eckhart Tolle. This is a godsend book for me because when I learned to live in the moment, my surgery times went down. I was having more fun. I was more creative. I was closer to my wife. All that other stuff, that other static was gone. So I took a course in mindfulness too. And Michael Bain, who taught the course, said, whenever you get really stressed out, just stop, breathe, and just be. Just be. In my faith, I realize when I'm in the moment, I got nothing to prove. My God loves me, who I am. That's who I am. Here's an example. I struggle with this. I did a lot of trauma work over the years. You're in surgeon with that perfect reduction. And I can tell you the orthopods, I had many a 2-hour ankle fracture, like had to be perfect. Now I realize, stop, breathe, and be aware of when perfectionism takes over. Just watch it. Get back to the present moment you're anchored, and then real inspiration, real creativity kicks in. You realize, this is good enough. This is good. So let's talk about mindful relationships. Those of you think you get on the journey, and if your relationships aren't in good shape, forget about it. It's been determined that maybe 80% of our happiness is by your relationships. I could be the greatest doctor, greatest surgeon in the world, but if Marie and I aren't doing well, it means nothing. This is my twin brother, Mike, and my daughter, Anne Marie. Mike's fighting cancer now. You don't think a day goes by where I don't thank God that he's still with me, and I don't call him every day, and I don't take my life for granted? So your commitment is going to determine your growth and happiness. We don't just enter relationships willy-nilly. When Eric McCarty showed up the first day of football at CU, I think he said, I'll try this out when it gets hard. No, he stayed at practice. He worked late. I read that Eric would carry cement bags on a backpack and run mountains. That's the commitment it takes to become excellent, as he was an excellent football player. So commitment in relationships is everything. It's transforming. And for me, I take the vow seriously, for better, for worse. For better, for worse. I think it's important to recognize it takes a lifetime to grow up. That's why you have to stay in there. Now, if you're in an abusive relationship or someone's really a jerk, get out. But for most of the relationships that we encounter in our lives, commitment's everything. When we commit, we make the most of a situation, look for the good and for the growth. And I need that commitment for the security to grow, Here's the bullseye approach to hierarchy of priorities. For me, it's the higher power. But right outside that higher power is my union with my wife. And look at it, above children and career. If you get this hierarchy of needs right, you're going to have a happy and fulfilled life. A good friend of mine, Eric, says he works on his epitaph and on his funeral, homilies. And he wants to know what people are going to say about him when he dies. What a great way. Covey says, begin with the end in mind. What do you want people to say about you when you die? That you're rich, that you're successful? How about your family? How about your wife? How about your children? I've been to funerals of very successful orthopedic surgeons, and the children are angry. And I got that experience early in my life, and I said, that's not going to be me. That's not going to be me. You see, this is jet fuel for your career. When you get things right at home, it will propel your career, propel your happiness, so you can do the things that we all do to be successful. So I want you to meditate on proactive relationships. For 30 days, assume responsibility for a relationship in your life, particularly those of you who are in a spouse or partner. Become aware and say, what am I bringing? Do you know that your relationships in your life reflect your internal life? When things aren't going well, guess what? You're probably not going so well. There's an expression that's so powerful. We don't see things, people, as they are. We see them as we are. Why? We project onto others our own stuff. And we can change it. St. Francis said a single sunbeam is enough to drive away many shadows. We can change relationships. This is book number 3, Getting the Love You Want. We all want to be loved, right? Every single person ever lived. Harville Hendricks is a Christian author, and he says the only way you can ever really get the love you want is if you love that person you're with, committed relationship unconditionally, spouse, partner, because your subconscious brain can't tell the difference between loving someone very close or loving yourself. And don't forget this one. The hardest times to choose love become the very times you can grow the most, right? It's a choice. Well, people say, I fell away from my partner, my spouse, because I fell out of love. Feelings are feelings. They're from thinking. But love is a decision. Love is a verb. It's up to you to create the life you want. You can heal your union if you heal yourself. And if you love that person totally and unconditionally, guess what? You're going to be changing your life for the better. So here's how we learn from our unions. We learn from relationships. 2 questions to ask yourself. What pushes your buttons? There's an old childhood hurt. And what don't I like about him or her? There's projection. Those two things, when you commit and work on these two things, you're going to grow without measure. I am twice the man I was just 5 years ago, and I got a long way to go. Marie will tell you. Live the vows. Dedicate your life to your spouse or partner. You know, your relationship's your vocation. Vocation's a calling, right? And you have to get rid of the ego. It's more important to be in relationship than to be right. Remember that. And when you forgive your spouse, you forgive yourself. We don't forgive because we have a hard time forgiving ourselves. When we forgive other people, we become kinder to ourselves. It works both ways. Own it. So, success in marriage, it's not about finding the right person necessarily, but being the right person. Be the right person. Be proactive in your relationships. Turn it around. And a great rabbi, Abraham Heschel, said, life without commitment, it's not worth living. It's not worth living. So the next point I'm going to make is stay close to your source, whatever your higher power is. If you develop a transcendent belief system to overcome all this craziness we see in our world today, honor, love, service, they're energy efficient. Service replenishes, it's other-centered. Meaning prevents burnout. If you can mindfully surrender every day, I have my little holy half hour in the morning, I have quiet time. I read something uplifting, I read the Bible, I read devotionals, I quiet my mind, and I connect to that source, which is changeless in a changing world. I try to become a servant for good. It gives me meaning. It's not about me. Booker T. Washington, a wonderful author, said, I learned long ago that those who are the happiest are those who do the most for others. We can celebrate our vocation of sports medicine, therapists, trainers, doctors. We live for other people, right? That's how we get out of ourselves. That's how we get rid of the ego. This guy was one of my heroes, John Wooden, 11 championships. No one will ever do that again. You can't live a perfect day without doing something for someone who'll never repay you. Wow. Look at that. Says it all. Service is its own reward. And again, meaning. Viktor Frankl again said, those who have a why to live can bear with almost any how. How do we get this case done? We'll figure it out. We're here to help this person. Choose to focus on all the good we all do. Appreciate the profound privilege to heal and emphasize the vocation, not the business. Another thing I should add to this, if you haven't done a service trip, I've been to Nicaragua, to India. Man, what a game changer. I will never, ever, ever, God willing, complain again. My 2 air-conditioned ORs with inventory, beyond measure. My old hero, Dr. Lockman of the Lockman test. He always focused on vocation. What a privilege we had to take care of people. And finally, those of us that are resilient believe in a friendly universe. You have to ask yourself, is everything rigged in your favor? Einstein said there's only 2 ways to live your life. One's as though nothing's a miracle. The other is as though everything's a miracle. I choose the latter. I look at all the bad stuff. I got involved with stress management because I was down 15 years ago. I got sued, $1 million suit for running a prescription for someone who didn't fill it. My dad had Parkinson's. My grandmother passed away. Boy, I went back to the basics. And I realized that happened for a higher purpose. Maybe rethink my life. Back to the fundamentals, faith, family, and self-care. So, can you hear this? Are you the kind that sees everything's a miracle from science? He's saying, is it possible with no coincidences? I believe in that. So say we are burned out. We can still reverse that. I'm going to give you a couple pearls and we'll finish up here. Again, we have a choice. We have free will. We're going to live the law of the echo. We're going to generate uplifts. We're going to make others feel better. Those are the 3 ways we can reverse burnout. The law of the echo. What you put out to the universe will come back to you. You reap what you sow. What goes around comes around. When I go to work in the morning, I could have the JV staff and I say, boy, we got a good day. We had a great staff today. We're going to have a wonderful day. I set the tone. You're the captain of the ship in the oar. People look to you. If you say, oh boy, you again, I don't think so. God gave us mirror neurons to reflect back what they receive. When you're light, you reflect light back. Be a light, not a critic. Smile. Here's mirror neurons at work. Wayne Sotil has written more about this than anyone I know, burnout. He says that if you look at those that are burned out and those that are resilient, we each have the same number of hassles. But what separates the burned out from the resilient is presence of uplifts in their day. Absence or presence of hassles means nothing. It's the presence of uplifts in our day that determines resiliency. So I'd ask the audience, how do you get uplifts? You give them. You give them. It's your choice. Maya Angelou said, I've learned that people forget what you said, they'll forget what you did, but they'll never forget how you made them feel. Make someone smile. Now, I can look at this video, and when this baby's smiling, how are you going to feel? So we have a choice to be a love finder or critic finder. We have a choice to give uplifts or to stress the people out. We can dedicate our life to making others feel good and heal, or we can just look for fault, be judgmental. We can smile and make someone else smile. Gandhi said, this is proactivity 101. That's what I'm talking about here. Be the change you wish to see in the world. Own your happiness. And when you're conscious, when you get all this stuff right, when you live in the moment, self-care becomes a natural. You start to realize, I love other people, I love myself. Sleep whenever you can. You can't afford not to work out. Whole foods, hobbies, very important. And learn to say no. We can't be all things to all people. Say yes to something bigger. No, I have plans with my wife that night. Let me get back to you. And Eric talks about in his talks, margin, creating margin time. Get to the office a little early. You can't be all things to all people. I repeat that. So let's talk about some action steps. Do you know if you take a vacation, you live longer, period. You lessen your heart attack risk, and long-term, you increase productivity. Henry Ford was the progenitor of the 40-hour work week because he realized, this is a study after Henry Ford by Daniel Cook, showing that if you work 60 hours a week, your productivity rises for 3 weeks, and then it dips. So those of us that work 40 hours and just can maintain that sweet spot, we're more productive long-term. Action step 2, excellence is important, but not perfection. Commit to being imperfect. Dare to have an inspired day. Breathe and just let it flow. Let that paper, let that case, let that talk just flow. And choose what you're going to feed your brain. You're going to look at terror reports and bad news, or you're going to read novels, spend time with kids, grandkids, animals, nature. It's your choice. You can watch this, or you can watch this. Your choice. So putting it all together, how do we stay energized? A peaceful and present mind, a life that's absolutely dedicated to others' relationships, a life of honor and compassion. Be a love finder, not a critic. You got to have boundaries. You can't be all things to all people. And focus on the healing that we do every day. If you can quiet your mind, live in the moment, connect to a higher purpose, you're going to have peace, you're going to have clarity, you're going to have enriched relationships, you're going to have a loving and compassionate disposition. Remember, it's not about you. There's no limit what a man can do or woman can do, so long as he or she doesn't care a straw who gets the credit. There you go. You have to follow your bliss.
Everything is the devil to you, mama. Well, I like school. And I like football. And I'm going to keep doing them both because they make me feel good. And by the way, mama, alligators are ordering because they're medulla oblongata.
Bobby Boucher followed his bliss. And my daughter and I were happy enough and blessed enough to write this. I'd be happy to send you the PDFs to Ellen. She can distribute to people who want as needed. And this is just hard-earned wisdom. I want to thank you for your attention. And I got to tell you again, Eric McCarty is a special friend and a special man. And I just an honor to do anything in the world for him or for him. Thanks for your attention, everybody.
Hey, John Kelly, thank you, sir. Much needed in this time of everything that we got going on with the COVID and so much disruption in our lives. And thank you for being such a great light for what we do, John. And that's a great message for us all. And I appreciate what you do, my man. I thank you for taking the time from Philly to be with us. I know you'll be out here, and when's that wedding of your daughters? I know you had to postpone it, right?
Labor Day weekend next year. So we'll try to, Maria and I'll drag it out. Whatever the date is, I'll stay and I'll bother you. How about that?
All right. I know many people appreciate that. They'll look forward to it. And those of you that don't know, so John Kelly also is a stand-up comedian. He's a man of many talents.
But I only do charities now because, Aaron is a man of faith. The nightclub scene got to be a little dark. So we'll do a little benefit tomorrow night, in fact.
Hey, is that online?
Maybe I can make it. Not really, but.
Okay. All right. Hey, well, John, thanks again. And I really appreciate you, brother.
I love you, buddy. God bless you all. Have a great day.
Thank you. All right. So we have a few minutes. We're going to take another short break. This will be our last break of the morning and of the day. Then we'll come back with an hour and a half of elbow, and then our last session of shoulder. And as you can see behind me, it's starting to warm up a little bit. The snow is fading, and it's going to get warm again after that several inches of snow we had in the past few days. So thank you. And I want to just, before we get the wellness break video on, I just want to again thank our sponsors, Arthrex with Gemini Mountain Medical as the distributor, Bragg, thank you very much. DJO, thank you. Horizon Prosthetics, we thank you. And Oser, a big thank you to you too, as well as Smith Nephew, Stryker, Wright Medical, and Zimmer Biomet. Thank you all, and most of all, thank you, Ellen Bagwell, for all the work that you've done on this, coordinating this, getting everybody in, and we appreciate everybody attending today. We have over 300 that have been registered. So, Ann McNamara, thank you again for the last wellness break of the day. We will start again at 11. We will start again at 11:30.
Snowy day for one of your breaks. We're going to go over a few stretches here to help you get levered up between these presenters. So we're going to start with just a nice simple reach down towards the floor. You can unlock the knees if you need to. I know some people have tighter hamstrings than others. We're going to come up top. We're going to reach back. Go into a little bit of a backward bend. You can kind of bias it to the left. And then you can bias it to the right as well. Come back down one more time.
Hey, Ann, go ahead and share your screen, please, so we can see the stretches.
Sideways lunge, a little bit of warrior type pose. We're going to come out to the side, lunge over that leg and reach over top, follow the middle finger there, and hold for about 5, maybe 10 seconds. We're going to come back, and then we're going to go the other direction, and reach out and lunge. Very nice. We're going to come back up. We're going to repeat that forward bend. We're going to go down. We're going to come back up, hands overhead. Very good. We're going to reach out to the side again. A nice forward lunge. Sink into it. Good. And then the other direction. Very nice. We're going to get those neck muscles stretched out a little bit. So we're going to go here towards your shoulder there. Give a little bit of open pressure there if you'd like. If you're seated while doing this, you can grab onto a chair. Then we're going to come back up the other way. This is where you can use your breath to kind of help relax into those stretches. Then we're going to come down, we're going to pull the nose down towards your armpit. We're going to tension that levator scapulae. And then the other direction. Very good. We'll repeat each of those one more time. Hold for about 10 to 15 seconds. Very good. And then down again. from there. If you're on a hardwood floor, you might want to grab a pillow or something like that. So I'll give you a few seconds to do that. All right, then we're going to come into a kneeling type stance here. So we're going to first think about kind of tucking your pelvis underneath you. What I mean by that is kind of act like you're tucking your tail underneath. You're going to rotate back a little bit. That's going to help to tension that iliopsoas muscle and that rectus femoris. Then we're going to lunge forward to whatever you feel comfortable. So some people feel a stretch right away. Other people need to lunge a little bit more than others. You can also add a reach over towards the other side, or the opposite side, excuse me. That's going to help to get a little bit of that lateral trunk as well as that hip flexor. Very nice. We're going to switch. Bring that right leg forward again, tuck that tail underneath, lunge forward. And we're going to reach up and across. Very good. All right. And then the last one, we go ahead and ditch the pad at this point. And then what we're going to do is what's called, been nicknamed the world's greatest stretch. What you're going to do is you're going to go into a lunge. You're going to take the right hand, or whatever hand is the same side as the leg lunging forward. You're going to reach down towards the inside of that foot. You're going to rotate up, look towards the ceiling. And then we're going to come back up. We're going to alternate. Again, reach down towards the floor, rotate up. And come up from there. All right, so that's going to take us to the end of our stretch break. Hope you guys have a great rest of the presentation. Looking forward to learning a lot more. Bye.
All right. Well, I hope everybody had a chance to really enjoy that talk. Remember, all of these talks or the presentation will be available for you to review on video. There'll be a link that'll be sent out soon, hopefully by late afternoon or possibly early next week. And appreciate the IT people and Ellen coordinating that. So next up, it's a real pleasure to go into elbow. And to start that off is my new colleague and fellow chief. He's the chief of the section of the hand and wrist and elbow. And it's Dr. Fraser Leversedge. Fraser comes from Duke to us. He's got a lot of experience with complex upper extremity injuries and nerve injuries, hand, wrist. He's been an Olympic physician in 2 Olympics, has a real interest in sports. And we're very happy to have Fraser. So Fraser, thank you for being with us today and talking about the evaluation of the painful elbow.
Great, thanks, Eric. It is certainly a pleasure to be here, and hopefully I will be able to get on to share my screen. I hope everyone can see this. So it's a pleasure to be here, and certainly back in Denver after 11 years at Duke. I've got a 10-minute short task here of going through the evaluation of the painful elbow, which is my charge this morning. I don't have any pertinent disclosures except for the photographs some of you see part of a book project that we were part of. But I do have the disclosure of having been here in Denver and seeing the excitement of sports and getting back to sports. And this is a 24-year-old running back following a complex left elbow fracture repair. And the question is, did he make it across the goal line with enough elbow extension? And we all recognize the elbow as being a tremendously complex joint. It doesn't like stiffness, and so injuries are really critical for being able to identify and to evaluate effectively. I'm going to start here though, because I do have an interest in nerve. And for anyone that you can raise your hand or select A, B, C, or D, this is a rugby player with a first rib pseudarthrosis. And the dysesthesias are to which distribution? And you say, well, why is this a part of our elbow discussion? Well, I think it's really critical to recognize pertinent anatomy, not just at the elbow, but what may cause symptoms around the elbow when we're doing our thorough evaluation. And that includes nerve distributions as well. But most of our elbow patients come from these types of activities, sports, complex injuries come with complex interactions with our environment. And so it's important that we get a good history, we understand the sport or the activity, and the injury mechanism is a part of it, because sometimes things are so complex that it's actually hard to figure out the injury mechanism, so I think we appreciate. Anatomy is really the key to the clinical assessment of the elbow, and really critically understanding not just the outside, but with our sort of x-ray vision, where we put our index finger for palpation, what we appreciate in terms of joint effusion, the location of our primary complaints are really critical to our assessment, and it helps us to guide effectively our diagnostic workup. That includes imaging and testing and so forth. And effectively, as we look at sort of the general principles, we really sort of break down the elbow pathology in terms of intra-articular versus extra-articular pathology, and then obviously whether the problem is local or regional, and or whether it's a referred symptom, something coming from afar. Our symptoms is really a part of our patient workup, and I think we all recognize that our patients really tell us their diagnosis if we listen carefully and if we ask the right questions. So if we're talking about the lateral elbow, the onset of symptoms, are they abrupt? Are they gradual? Are there certain things that aggravate the condition? The classic elbow, extending the elbow, palm down, lifting something from the floor is perhaps much more clinically applicable to the lateral epicondyle. If we're thinking about the quality of symptoms, getting a sense as to whether this is sharp and localized, whether this is an aching sensation or burning, which may be nerve related, or catching. For example, somebody with an osteochondral loose body, which may be causing a locking or a catching sensation in the mid-arc of motion, as opposed to somebody with terminal extension or terminal flexion stiffness. The location is really critical, and really having the patients describe where their symptoms are, I think as all of us recognize, the more vague, probably the more less reliable our ability to localize a symptom to a tendon or ligament origin, and perhaps we have to think of a musculotendinous unit, a joint, or perhaps even a nerve-related symptoms. Chronicity is also important, not just for the timing of onset, but also what's happened in the past in terms of the response to treatment. Did they get better for a period of time after an injection or a certain modality of treatment? And then critically, the associated findings. Is there neck pain associated with their worsening of their symptoms? Do their symptoms radiate into the forearm, et cetera? And I think this is really critical to ask these key questions. We're all familiar with walking through the basics of a clinical examination, But so I won't spend a lot of time going through the basics, but there are nuances to each of these on the list here, and we'll sort of attach these. Clinical examination, oftentimes with the elbow, it may be limited in terms of the range of motion, really getting a sense as to pronosupination, flexion extension, which can certainly be affected by the joints above and below. The DRUJ is just as important as the PRUJ in forearm pronosupination, and the shoulder oftentimes can give us a sense of limited elbow motion as well. Differential diagnoses is a part of our clinical exam, and a good vascular exam, for example, may pick up somebody who's got a cervical rib or an abnormality in their cervical spine that lends itself to a vascular compression that actually creates symptoms downstream in terms of fatigue or a relative sense of activity and tolerance. And no different than the patient with a cervical spine, C5, C6 related cervical radiculopathy, that may be a source of elbow symptoms in terms of lateral elbow pain. And these are those patients that have a really exquisite tenderness along the radial nerve distribution, usually asymmetric from the contralateral side, but not always. So having this as a part of our question and answer, but also in terms of our hands-on assessment. Functional assessments are often important for our sporting athletes, whether this is by a trainer, whether this is by our occupational therapist, but to really critically assess the patient's activity. Are they actually following through appropriately? Are they making contact with the ball at appropriate level for tennis players, for example? This can come sometimes from a coach that's letting us know their examination just as importantly as their functional assessment. And these are tools that are in our toolbox to really engage in sort of a multimodality assessment. So the clinical examination really goes back to our pertinent anatomy. Remember, the lateral ulnar collateral ligament is the primary stabilizer of the lateral elbow, resisting varus stress, but the actual lateral collateral ligament complex is really this sort of sheet, if you would. And these are the structures that we have to rely on in terms of both repair, but also appreciating instability, such as with posterolateral rotational instability of the elbow. And even a patient who's undergone multiple steroid injections for lateral epicondylitis can put these structures at risk. So being aware of putting your fingers on this structure and being aware of their location will help us in terms of our clinical examination, including for the more superficial structures. And you can see here at the lateral elbow that the lateral extensor and supinator origin, along with our mobile wad, is a part of our diagnostic workup. But when you actually take it apart, so to speak, we can appreciate the lateral epicondylitis patient with the more tendinous origin of the lateral epicondylar region is the ECRB, as opposed to number 2 there, which is the more muscular origin of our ECRL. Close by to the lateral elbow, just a few finger breadths distally, is our radial nerve and the PIN as it heads into the radial tunnel region. This is obviously important surgical anatomy, but it's critical in terms of our ability to pick up on our diagnostic workup. And this is the PIN heading along the dorsal forearm, where our clinical findings are also going to be suggestive of pain that radiates in the same region as our PIN. So inspection of the lateral elbow, you might see a patient with instability, and obviously this sort of skin puckering may be associated with these same X-ray findings, where you actually have the inspection itself will give us a key or an indicator as to our diagnosis. Palpation is critical, and again, being specific, this is the lateral epicondyle, and yet there are patients with lateral epicondylitis that also have pain further down the radial tunnel, and we have to recognize this may imply some difference or some combination of onset of symptoms in terms of etiology of elbow pain. So differentiating between these relative locations of the lateral epicondyle versus the radial tunnel can be important for our testing. And similarly, identifying the location of pain with provocative maneuvers, such as a resisted 2-finger extension test, and really focused on the lateral epicondyle. I also find very commonly patients treated for lateral epicondylitis that actually come in with this vague sense of symptoms, really between, if you took the mobile wad in your own hand, 4 or 5 centimeters distal to the lateral epicondyle, and they complain of more vague pain than localized symptoms to the lateral epicondyle. And this, remember, is down deep to your mobile wad is actually the location of your biceps insertion. And so patients with distal biceps tendinopathy or even a strain of their biceps can complain of pain along the lateral margin of their elbow. But a careful examination will also reveal pain at the insertion of the biceps. Obviously, a hook test allows us to look more critically at the integrity of the biceps tendon. And obviously, if we are concerned about the integrity, we can go on to further image their biceps. Injection history can also be a part of your clinical examination. How did a patient do after a previous injection, and where was the injection placed? Was it an intra-articular injection? Was it a soft tissue injection around the elbow? And then don't forget that patients with a history of injections may also suffer from the consequences of previous injection, and multiple corticosteroid injections, as we all know, can lead to degradation of our collateral ligament origin and elbow instability, as well as integrity loss of our capsular tissues and even fistula formation from our synovium of our elbow joint. A diagnostic injection, however, can be a very strong diagnostic tool, and I use this very frequently when we're trying to figure out if is this an intra versus an extra-articular condition, and the diagnostic injection can be very helpful from that perspective. When we look at the elbow imaging, our elbow imaging in terms of radiographs can help us with intra-articular pathology. Advanced imaging can obviously differentiate between collateral ligament versus extensor origin conditions. And imaging itself can point out acute versus chronic. And don't even forget the patient with a congenital radial head dislocation that once in a while can manifest itself with elbow pain. We also can see pertinent history in terms of previous injury, although it's not so good at pointing out chondral injuries, which may be the sequelae of previous injuries. And obviously, as we are investigating further, use of stress views or fluoroscopy can be very helpful in terms of dynamic imaging for subtle instabilities or perhaps not so subtle instabilities. For advanced imaging for collateral ligament injuries, MR arthrograms are usually very, very helpful. They are the most sensitive and specific testing for our elbow collateral ligament injuries, both on the lateral and ulnar collateral ligament sides. The distal biceps, as I mentioned, can be a source of pathology, whether a complete rupture, or don't forget the partial rupture leading to chronic pain associated with tendinosis or partial ruptures. And these are subtle findings sometimes in terms of even diagnostic forearm pronation and supination, which the patient describes as sometimes catching or associated with chronic tendinopathies and essential bicipital tuberosity bulk from the tendinopathy itself. And these you might find on radiographs or on MRI findings. And then distal triceps pathology, obviously a palpable defect at the triceps insertion and limited findings oftentimes radiographically, but you may see a subtle avulsion injury like you see here, or obviously MRI can be helpful for tendinosis related changes or degenerative processes associated with triceps pathology. And then finally on the medial elbow, patients undergoing sports where they put themselves at their own risk, and perhaps this ball came out, but sometimes it may lead a patient with a not so happy outcome with medial elbow flexor pronator strain or even an MCL injury that you can see here. The key is understanding that the relative contributions to stabilization at the elbow. Don't forget also the medial elbow, we see the median nerve here, and the median nerve pathology in terms of local soft tissue compression from our lacertus, our pronator, and even the pronator being two heads, the superficial and deep heads can lead to pronation or to the pronator syndrome, or even more distally, the FDS origin can sometimes be a source of median nerve pain. Again, these are all parts of our clinical history, sometimes with median nerve disturbance distally, but also in part it can be picked up on clinical examination when you can differentiate provocative maneuvers for each of these three locations. And then finally, the medial elbow is also a source of ulnar nerve symptoms at the elbow. This is the medial epicondyle, or two heads of the FCU, and our ulnar nerve. And this is sometimes a source of symptoms if we have a patient who has very subtle ulnar nerve instability at the elbow. You can see here coming up in just a moment, the very subtle ulnar nerve instability right there. And this is what happens in this patient with the ulnar nerve instability. You can see the irritation of the ulnar nerve creates this not so happy FCU tendon. Don't be fooled at the ulnar nerve with this snapping triceps. And this is a diagnosis of careful examination for ulnar nerve irritability. And you can see the triceps tendon here subluxing. This is well picked up on ultrasound, as pointed out by Rob Spinner, the Mayo Clinic, and one of my previous partners, Richard Goldner. And this is treated effectively with recession of the triceps and repositioning. And then finally, this is a great case just for careful exploration or careful examination of a patient and history taking. This is a patient who saw some top sports folks around the region who came in for a fourth opinion after multiple tests, multiple diagnoses. The key here was listening to the patient's history of where his pain was. He had both elbow pain with the cocking phase, but also following follow through, he also had significant forearm pain and cramping, particularly after repetitious throwing. And Gary Lurie pointed out this interesting diagnosis of the Ankylosing epitrochlearis, which I think everyone recognizes here at the medial elbow. This is the Ankylosing epitrochlearis. It can be a source of ulnar nerve compression and has been highlighted in young throwing athletes in particular. And this is his case. This is actually releasing. You can see the Ankylosing epitrochlearis being quite a substantial structure here. And once we've released the Ankylosing epitrochlearis, this is intraoperative. Look at his forearm and the fasciculations of the forearm musculature, sort of the ulnar nerve breathing a sigh of relief. And then finally, elbow instability, pivot shift tests. This is really finding the subtle instabilities is really critical. And sometimes we even have to take these patients and have them under a block or under general anesthesia to relax their resistance in terms of their muscle. They usually tell us a story where they don't like to push off, such as a chair raise test, and they really don't like to undergo some of these stress tests with the forearm, applying a valgus force while flexing the elbow, and the joint actually reduces at 70 to 110 degrees for this subtle posterolateral rotational instability. And so this is often a test that's done sometimes under a block or under a regional or general anesthesia. And then finally, the MCL, we recognize the valgus stress test, milking maneuver, and a valgus extension overload in a repetitive throwing athlete with sometimes posteromedial joint line pain at the ulnohumeral joint, sometimes even with some degenerative changes or early osteophyte formation can be seen aggravated with resisted elbow extension. So I know I've gone a little bit over time, sorry, Eric, but in summary, a comprehensive history is critical. Be aware of key anatomic diagnostic. Your finger is really the important point of your being precise with where the patient's symptoms are located. Diagnostic injections and provocative maneuvers can be extremely helpful. And then don't forget to select your imaging correctly. Adding an arthrogram to an MRI can increase your sensitivity and your specificity for critical injuries. And then don't forget about distant etiology for your elbow symptoms. If your exam, it doesn't show any signs of local elbow pathology. So thank you for your attention, and I look forward to the rest of the talks. Thank you.
Hey, thanks, Frazier. We're glad to have you. Great anatomy. Love the slides of anatomy, and we look forward to the many years ahead. So Adam Seidel, if we could get his talk up again, he's going to now talk about specifically the triceps and the biceps, the tendon injuries around the elbow.
I want to thank Eric McCarty again for asking me to give this talk. Again, Adam Seidel, shoulder elbow surgeon at the University of Colorado. I'm here to talk about elbow tendon injuries, focusing on distal biceps and triceps injuries. Just a brief outline, again, talking about ruptures primarily of the distal biceps and triceps. I'll go briefly into the anatomy, how to diagnose these injuries, and then spend a little bit of time on the treatment of both distal biceps and triceps ruptures. Distal biceps anatomy. So as most of you know, there are two heads to the biceps, the long head and the short head. These come together distally and insert onto the radial tuberosity. The distal biceps rotates as it's inserting onto the radial tuberosity. rotates clockwise in the left elbow and counterclockwise in the right elbow. This is important to understand when repairing this. It attaches medially to the lacertus fibrosus, which is an important structure because when this is intact, it can actually fool you with a hook test or with a diagnosis of a distal biceps rupture, which I'll go into a little bit more detail in just a bit. Numerous cadaveric studies have looked at the role of the long and the short head of the biceps. Essentially, the short head of the biceps inserts more distally into the radial tuberosity. It acts more efficiently at elbow flexion, and it's more efficient at supination with elbow and pronation or neutral. The long head of the biceps inserts more proximally, and it's more efficient at supination with the elbow supinated, so resisted supination. The tendon inserts along the ulnar aspect of the radial tuberosity, as you can see here. It fans out as it inserts. So epidemiology, incidence of rupture, it's actually pretty rare, although most of us in the sports division see these injuries on a regular basis. So 2.6 per 100,000 patient years. The mean age is 46 years. 95% of these are male. I can say that I've never seen a female with a distal biceps rupture. Smoking, patients that smoke have an increased likelihood of injury, and then patients with an elevated BMI have an increased likelihood of a distal biceps rupture. Mechanism is typically a traumatic event of elbow flexion against resistance. Most patients come in and describe the injury with an audible pop, feeling like a gunshot to the elbow. Causes of this, so obviously there's the traumatic event, but this is also an area of hypovascularity, and you can have impingement, which is secondary to decreased radial ulnar space with pronation, as can be seen here. Physical exam, this is typically a pretty easy clinical diagnosis, so patients will present with tenderness and bruising in the antecubital fossa and along the medial forearm. They have pain with resisted biceps flexion and forearm supination, and then a hook test. Hook test should be performed from laterally, and the reason for that is if you have an intact lacertus and you perform a hook test from medially, you can be fooled into thinking that the distal biceps is actually intact. So the key here is coming lateral when you perform that hook test. Imaging, clinical exam typically confirms this diagnosis. I always get an MRI before I take these patients to surgery, although some surgeons do not. I think it helps, obviously, to evaluate for a full thickness versus a partial tear. And then it also helps you evaluate for the level of the tear and the retraction. I think the biggest thing for me is evaluating the level of the tear, as these can be musculotendinous tears. That's quite rare, but it's something you need to be prepared for when going to the operating room. So I tend to get an MRI beforehand. Management, distal biceps ruptures are typically treated with surgery. Recovery is about 4 to 6 months. Re-tear rate is pretty low, less than 2%. Non-operative management, you get patients that will ask about treating these without surgery, and the studies have shown that patients experience 30% loss of flexion strength, 40% loss of supination power, and a loss of endurance. Actually, the thing that bothers the patients most is their loss of supination and their loss of endurance. Most patients can actually tolerate the loss of flexion. So surgical indications, again, almost everyone gets repaired. When I see them with a distal biceps rupture, really it's patients that are medically unfit for surgery that don't have this surgery. So who doesn't need a surgery? There's been several studies that look at this. This is a study looking at 18 patients that were managed non-operatively. And what they found is that patients overall were satisfied with their outcomes. But when looking at strength, especially again in supination, they had a 63% supination strength compared to 93% in patients that were treated with surgery. So quite a significant difference. There's a number of surgical techniques for repairing the distal biceps, and normally when you're talking about problems with multiple surgical techniques, that typically means there's not a great option, but in this case, these are all really good options, and this is a surgery that tends to do pretty well functionally once fixed. General conversation is 1 incision versus 2 incision. I know a lot of the guys in the sports division will do a single incision surgery. I prefer a 2 incision, but again, both of these approaches work quite well. They do have different risks. So single incision technique has a higher risk of a nerve injury, whereas a 2 incision technique typically has a higher risk of heterotopic ossification. For me, when I do a 2 incision technique, I always treat these patients with indomethacin afterwards. So just to touch briefly on the outcomes, overall the outcomes are quite good. This is a large study that was done, no significant difference in range of motion or strength between a single incision or 2 incision approach. This study shows that there was significantly lower complication rate after a 2 incision approach, but there's other studies that have found the opposite of that. So again, generally speaking, similar results and similar complication profile. The rate of re-rupture is actually quite low. As I said before, it's less than 2%. This is a large study here done out of the Mayo Clinic that showed the rate of re-rupture was about 1.5%. And of course, all of these were blamed on patient compliance as opposed to any surgical error or technique issue. Moving on to the triceps. So just briefly, the triceps anatomy, there's 3 heads of the triceps, the long head, the lateral head, and the medial head. This inserts onto the olecranon. It has a wide footprint distally with a width of between 2 and 4 centimeters. This is a rare injury. It accounts for less than 1% of all tendon ruptures. Typical age is 30 to 50. Males, much more common than females. Again, I have not come across a female with a triceps rupture in the past. Typically related to sports, I see a lot of triceps ruptures with patients that were weightlifting, but also football players. Risk factors, obviously, anabolic steroid use. Mechanism for this injury is traumatic event of overloading the extended elbow. This can typically be diagnosed clinically. Patients will come in with large ecchymosis over their elbow. You can get an x-ray on these patients, and I often do. Sometimes you'll see a little fleck of bone off the tip of the olecranon. And then just like distal biceps ruptures, I typically get an MRI. Again, it helps evaluate partial tears, the extent of partial tearing, but it can, again, evaluate the level of the tear and the degree of retraction for surgical planning. Management, really surgical management is the best option for most patients. Low demand patients in poor health can be candidates for non-surgical intervention. All others are operated on. Outcomes are quite good. The re-rupture rate is rare, high patient satisfaction, and then up to 80% return to sport after distal triceps repair. At this point, unfortunately, I will not be able to answer questions live, but here's my email, so feel free. Don't hesitate to reach out to me, shoot me an email if you have any questions about this talk. I appreciate the opportunity.
Hey, thanks again, Adam, and I hope you're having a nice time, a little break. First time you and your wife have gotten away without the kids, so thank you much. Well, next up, we have Dr. Tom Noonan. Tom Noonan, I've known for a long time. He has joined us just a few years ago with the rest of the Stephen Hawkins Denver crew that just does a fantastic job. He's the head team physician for the Colorado Rockies. He has been my go-to guy for ulnar collateral ligament surgery whenever we have had an athlete that needs that. He's just a terrific surgeon, terrific guy, and a great partner, and glad to have him as part of our sports medicine. Tom, thank you for talking today.
Eric, thanks so much. Yeah, I appreciate you inviting me to talk, and great meeting, and I'm sorry we can't be live today, but Zoom is pretty good too. So Eric asked me to speak about UCL injuries and who needs surgery. So you want to first ask some basic questions when you see somebody, and honestly, the first one I usually ask is, do you want to continue playing baseball? Because especially some of these, high school kids and younger kids have decided they don't want to play in college. And honestly, if somebody doesn't want to play baseball, they really don't need their UCL reconstructed. Another question to ask is what position do you play? Pitching obviously is the highest demand position and more likely to require surgical intervention. Position players, especially like first baseman, can often get by without surgery. One more question to ask is, have you had elbow problems in the past? And this is significant, especially if you've got a partial tear, because if the patient's had 4 episodes before where they've been shut down in rehab and it keeps coming back, that's obviously something that would tip you more towards surgical intervention as opposed to a first-time event. And then what type of tear is it? Obviously, full thickness tears, generally we treat those with surgical reconstruction. The exception might be an arthritic elbow in a late career athlete. A lot of times those elbows that get so stiff they can actually throw fine with no UCL. For partial tears, non-surgical treatment can certainly be considered. It's something I talk a lot about because we actually did a study several years ago looking at this topic, and we went through the Rockies organization over 6 seasons. We found 45 UCL injuries, and 30 of those we treated non-surgical. Now I will point out those were all incomplete injuries. All the complete tears did get treated with surgery, but we followed these 30 players. And the results were surprisingly good. So for return to same level of play, we had over 90% success rate for both pitchers and position players. So really the conclusion of our studies was that incomplete UCL injuries in pro baseball players oftentimes can be successfully treated without surgery. We just, hasn't been presented or published yet, but interestingly, we just followed 27 of these players long-term. So a lot of these guys had 8 to 10 years of follow-up, and none of the ones that we successfully treated without surgery went on to require UCL reconstruction. So that was some interesting long-term follow-up. So a lot of people ask me, how do we do it? Well, I think if you're gonna treat these non-surgically, you really got to be committed to it. You can't shortcut it because then things aren't going to work. So first of all, no throwing for 4 to 8 weeks. Some of that depends on severity of injury. Usually we're talking about at least 6 weeks of no throwing. If it's a bad sprain, sometimes 8 weeks. I usually will get them in physical therapy to work on elbow range of motion, shoulder strengthening, keep them busy. And I'll see them back at the end of that no-throw period, see how they're feeling. If they still have pain then, especially if they have pain with a moving valgus stress test, I think that is a negative prognostic sign. But if they feel good, no pain with valgus stress, then we'll start them on a throwing program. But to get them back to full competition, that usually takes about another 6 to 8 weeks. So when you're embarking on a non-surgical treatment program, I usually do tell the athletes this is going to take about 3 months. It's not a quick process. So what are we not saying with that study? We're certainly not trying to say that all UCL tears can and should be treated non-surgically. Obviously, the picture you're looking at right there, that ligament's pretty much blasted, and I would definitely recommend surgery for that. In our presentation, we also said, successful non-surgical treatment is maybe not a long-term solution, but again, some of our newest data may suggest otherwise. But I always remind people too that surgery isn't necessarily a long-term solution either, because some of these guys get reconstructed and do well for 6 or 8 years and then get re-injured. So even though the reconstruction is a great operation, doesn't necessarily last forever. Other points to consider, location. In our study, we did not see a difference in success rate based on location of injury. My colleagues with the Indians looked at some of their athletes, and they showed a pretty high failure rate with non-operative treatment of distal tears. However, if you do dig into their data a little more, if you look at high-grade distal tears, their success rate was poor. They had an 88% failure rate. But if you look at distal non-high-grade tears, their success rate wasn't bad. It was 60%. So I would offer to you, not all distal tears are the same. I think if there's stripping of the ligament distally with preservation of ligament thickness, those can be treated non-surgically. However, if the ligament's kind of disrupted at the sublime tubercle, I think surgery is probably the best way to go. So for this one, for example, you can see, the ligaments peeled up at the sublime tubercle. I don't know if you guys can see this arrow on my screen. I don't know if you can or not, but
yes, we can see it.
What's that? Can you see it?
Yeah, we can see it very nicely.
Oh, fantastic. Okay. Yeah, so you can see, the ligament's stripped up right here, but it's still pretty thick, and you can see it attaching all the way down here. So I think that one actually has a pretty good chance with non-surgical treatment. Same thing with this one. Again, the ligament's stripped, but you can still see pretty good tissue distal to that. This one, maybe not so much. You can see it interrupted here. It doesn't look kind of great beyond there. The fascinating thing about this one, though, this is actually an entry MRI on a guy we drafted with no history of elbow problems. So it does go to show you that sometimes even these injuries that you don't think will work out may work out. This one I would probably say no. You can see, the ligament disrupted at the beginning of the sublime tubercle, and there's really just nothing beyond there. So even though this, maybe you could say is kind of a partial tear, it's not retraction or anything like that. I don't like the look of that, and I would recommend surgery for that. Similarly for this one, again, disruption right where it attaches on the sublime tubercle, and you don't see a whole lot distally, so it's really more of a focal tear as opposed to like a stripping. Another thing to talk about is biologics. We, in our study, did not do any sorts of injections. There are a few studies out there. They're not great methodologically. This was a study out of Los Angeles, and they had 34 athletes with a single injection of leukocyte-rich PRP, and actually did have pretty good return to play rate of 88%. This is a study out of New York. Now, they use ACP injections, which is leukocyte poor. Results weren't as good, so perhaps the PRP formulation, made a difference. In terms of our treatment, we, certainly will currently consider PRP injections for partial tears, but unsure, if it does significantly improve success rate. Some folks did look at the MLB data recently. Pretty big numbers. The data, however, isn't, it's not a great data set. They found 544 pro players treated without surgery, 133 with PRP, 411 without. Overall return to play was not as good as ours. And then really the only finding that was significant was that the no PRP group had a faster return to throwing. The data was a little skewed though. The PRP group was older and more commonly major league as opposed to minor league. And what that's kind of saying to me is these are probably more beat up ligaments, kind of later in career guys that were hoping to avoid surgery. And so they probably didn't have as good a chance to do well anyway. And then the finding that the no PRP group returned to throwing quicker kind of makes perfect sense, because if you inject PRP, you're usually going to shut them down longer than if you didn't. So I'm not sure that's all that significant. So in summary, non-surgical treatment can be considered for partial tears, especially proximal ones. We will sometimes consider PRP or other biologics. However, if you have, a complete tear or a player with a history of previous non-surgical treatment of a partial tear, those probably best treated with surgery. And then like the cases we showed before, high-grade distal partial tears also probably best treated with surgery. I want to leave you with one more case. This is really interesting. So this is a 16-year-old kid. He's down in the Dominican Republic, pretty high prospect guy. I think he got signed for like $750,000. He's an outfielder in the Rockies organization. So I get a call in February and they say, yeah, a kid threw from the outfield, felt a pop in his elbow. We get the MRI and, again, this ligament is blasted here, completely disrupted. So I said, yeah, we should probably reconstruct that. COVID hits, and so he can't come. And now we're into like July, August, and restrictions are lifted. We're trying to figure out how to get him here and quarantine and all that. And one of our athletic trainers says, hey, you want to, maybe just repeat the MRI before we fly him up here? I said, sure, yeah, no problem. So we get the MRI, and look at this. I mean, it looks like this kid never had an injury. Now the story's not over because he's rehabbing right now. He has no pain, and I don't know. Maybe this is all like bridging scar, and he won't do well. But it is fascinating, and I do think, unfortunately, a lot of our younger players, just with the pressures of sport in our society, get pushed into surgery quickly. Because again, that's a very significant injury and a pretty interesting finding that he did so well. So maybe next year I can update you and tell you how he did. So that'll do it for this talk. Thanks very much.
Okay, thanks, Tom. That is fascinating. There's always a lesson to be learned, right? And we're still learning. So
yeah, absolutely.
Thank you much. We'll look forward to your talk a little bit later. So next, it's a very nice pleasure to introduce Frank Scott. Frank is a partner of mine and colleague for, gosh, over 17 years. He was passed on the torch as chief of the hand and wrist section to Frazier, and he's been a great asset for us in dealing with a lot of our athletes through the years and taking care of these high-profile athletes and fixing their hands and wrists. And Frank, I'm looking forward to your talk about lateral and medial epicondylitis, operative or non-operative. Let us hear it, okay?
Thanks, Eric, and thanks for the invitation to participate. So epicondylitis actually is a misnomer. It's not a disorder of the epicondyle, and it's not an inflammatory condition. So the more appropriate terminology for that would be tendinosis or tendinopathy, and then there's these other terminologies listed here as well that you see in the literature every once in a while. So as we all know, whether we're therapists, trainers, or physicians, know that this is one of the most frustrating conditions to treat, and a treatment program for one person doesn't necessarily apply to another patient. Everybody responds differently. So it's frustrating for the patient, and it's frustrating for the providers. But lateral elbow tendinosis is tennis elbow, as you know, and it is the most common overuse disorder of the elbow. And the primary structure affected is ECRB. And in 50% of cases, the anterior edge of EDC is also involved, but ECRL and rarely ECU involvement in tennis elbow. And Fraser kind of alluded to this in some of his anatomy diagrams, but this article out of Japan, published in the Journal of Hand Surgery 2014, illustrates, here's ECRL, and this is ECRL reflected, showing ECRB deep. And then with EDC reflected, you see the tendinous portion of ECRB nicely here. And that is the only muscle tendon group at the elbow on the lateral side that is distinctly tendon at this level. The other muscles are blended with muscle fibers and tendon. And so that might be one of the reasons that ECRB is the primary structure affected in lateral epicondylitis. And the other point out of this article is that the anterior part of the capsule that's directly underneath ECRB is very thin and distinct, and a distinct structure, whereas you get posterior and distal, the capsule blends with the annular ligament and the supinator muscle, and so it's more supported. And then on the medial side, you have your golfer's elbow or medial elbow tendinosis, and the primary structures involved there are flexor carpi radialis and pronator teres. So there's very rare involvement of FCU, and cubital tunnel syndrome is seen in approximately 30% of cases associated with the medial epicondylitis. And then every once in a while, someone presents with both medial and lateral epicondylitis, and that's called country club elbow. Now, the epidemiology of lateral elbow tendinosis is often associated with repetitive motion, whether it's athletics or occupational. And again, the treatment can be very frustrating for all of us. And certainly therapy is an extremely important aspect of treatment for lateral epicondylitis. And all of these various therapy modalities have been used in various treatment protocols. I like to send my patients for ionophoresis as well as strength and conditioning. But all of these modalities can be considered, including Tenex, which is ultrasonic debridement of the ECRB. And the non-surgical management of lateral epicondylitis includes a program of relative rest, not absence of all activities, but absence of abuse, and alteration of techniques or alteration of equipment. Counterforce bracing is used commonly. I like to use counterforce bracing during the day and wrist extension splints at night. And again, non-surgical management includes a rigorous rehab exercise program, including not only the elbow and forearm, but consider the back and the shoulder as part of the treatment program. Eccentric contraction is helpful as part of the conditioning program, and ankynia strengthening and ulnohumeral tracking can be used. And then non-surgical management includes careful consideration of injection, steroid, steroids can be helpful in the short term, but there's a lot of studies out there that show that they may not help in the long term, and the recurrence rate is quite high. This study here compared corticosteroid injections with ionophoresis with corticosteroid for lateral epicondylitis, and they randomized 82 patients and split the group into dexamethasone via ionophoresis, dexamethasone injection, and triamcinolone injection. And the ionophoresis group statistically showed more improvement in grip strength and more likely to return to work without restrictions. This study here randomized patients into steroid injection and placebo injection, and then steroid injection and placebo injection with physical therapy. And they assessed outcomes at 1 year with a global rating of change scores from the spectrum of complete recovery to much worse, and also analyzed the 1 year recurrence rate. And the interesting part of this study is the steroids had lower complete recovery or substantial improvement percentages than placebo, 83% recurrence with, or not recurrence, complete recovery with steroid. And the placebo was 96%, and then also a higher recurrence rate with the steroid, 54% compared to 12%. And the physical therapy, this is doesn't mean that physical therapy is not helpful, but in this particular study, that did not alter the percentages that we just quoted. And then this is a study that we did here at the University of Colorado, randomizing injection of saline, autologous blood, and corticosteroid. And outcome measurements included DASH scores, and VAS scores were taken pre-injection at 2 weeks, 2 months, and 6 months. And the interesting part of this study is that there was no significant difference at 2 and 6 months for all three groups. And this is another study that one of our fellows did, and it was published last year, analyzing the depression and anxiety among patients with atraumatic lateral epicondylitis and ulnar sided wrist pain. And we looked at both diagnoses, but I've only included the stats on lateral epicondylitis for this talk. But patients with a history of depression reported pain scores 1.2 average higher than patients without a history. And the reported rate of any mood disorder in the US general population is 9.5%. In this study, 34% of patients with lateral epicondylitis had medical record documentation of depression or anxiety or both. So that's almost 4 times higher in this diagnosis. And this correlates with a paper that David Ring out of Boston published a few years ago about coexisting mood disorder negatively impacts surgical outcomes and perceptions of pain and disability with a variety of upper extremity conditions. Surgery is very rarely indicated, in my opinion, for lateral epicondylitis, but it can be done open or arthroscopic or percutaneous release. And the indications for surgery is obviously failure of conservative treatment, including all the things we just mentioned, and monitoring over an extended period of time. Calcific tendonitis can be a contributing factor to take someone to surgery, or bony exostosis. But most people get better with conservative management. And I tell my patients that they're going to be dealing with symptoms for an extended period of time, but at some point, this is a self-limited problem, and most people get rid of their symptoms, although it may take a while, several months, or even a couple of years. And most people that do end up having surgery get a decent result. And this is just an interesting addition, a different way to consider treating lateral epicondylitis surgically. And Lee Dellon, who has a national reputation for nerve work and research, published this paper in the journal Hand Surgery about taking the posterior branch of the humeral, lateral humeral condyle is innervated by this posterior branch of the posterior cutaneous nerve, and this vessel loop is around that branch, and just snipping it and denervating the lateral humeral condyle. So just an interesting way to look at treatment of this condition. And there are the stats out of that study: 30 elbows and 26 patients, and you can see the VAS scores improved, and 80% got good to excellent results, and grip strengths improved. There were 5 failures in there, and 4 out of 5 had radial tunnel syndrome. And then just very quickly on the medial side, it's not nearly as common as lateral epicondylitis, but it is the most common cause of medial elbow pain. Peak incidence in the 3rd to 5th decade, 2-to-1 male to female ratio, and more common on the dominant side, and associated with ulnar neuropathy in 50% of cases. Fraser alluded to this too, but certainly in the evaluation of both lateral and medial epicondylitis, you need to consider more proximal pathology, including cervical radiculopathy and TOS, shoulder level problems, and then snapping medial head of triceps, and subluxation of the ulnar nerve, and the triceps tendinosis, and MCL insufficiency can all be on the differential diagnosis. The treatment basically is the same. I find medial epicondylitis easier to treat. It seems to be more predictable, and patients respond to conservative treatment for the most part. And again, ones that go to surgery are usually successful, but in my hands, it's rare to take a medial or a lateral epicondylitis to surgery. Thanks.
Hey, thank you, Frank. Thank you for all your work and your research into epicondylitis, and great topic. I think many surgeons have had it, including myself, and really appreciate it. So now we're going to head into our last section. That's going to be the shoulder section, which we got some great topics. We've got a nice controversy on the biceps, whether to tenadese it, to release it. We're going to talk about peak sports, and then also biologics. And so once Dr. Scott, if you could quit sharing your screen, we're going to have Dr. Aaron Provence on. And Dr. Provence has been a great colleague since 2008. He did his fellowship here. He is the director of pediatric sports medicine at Children's Sports Medicine Center, works up in Boulder, and also works down in Denver and throughout the metro Denver area, and also works in a lot of capacities, including he's on the CHASA, which is the Colorado High School Sports Association Medical Advisory Board. So Aaron, thank you for telling us about the painful use shoulder.
Thank you, Dr. McCarty. I appreciate the invitation to speak today, and thank you everyone for attending. I'm going to go straight into my talk here on painful use shoulder, what needs rehab and what needs surgery. So I have no financial disclosures. And as you guys know, I'll be talking about pediatric and adolescent sports or shoulder injuries. Now, if we just talk about youth injuries in general, that's split between 50-50 with overuse and traumatic injuries. We see a lot of similarities with shoulder injuries in the youth as well. With those numbers. And many of these shoulder injuries sit in this kind of gray area between operative and non-operative management. So I'm going to give you a couple examples here. So if you look at the picture here, this is a grade 3 AC separation. Now, you may see different treatments versus op versus non-op. If you have a young pitcher versus like a young football linebacker, this is a 16-year-old with a midshaft clavicle fracture. You can see it's 100% overlapping and some shortening going on there. Of course, that may see different treatments based on who they go see. So that could go operative versus non-operative as well. Of course, slap lesions in the young athlete, if they're a pitcher, that may be more likely to see operative management initially versus first-line non-surgical management. Then, of course, as talked about earlier today, shoulder dislocations in the youth, depending on if they're contact sport athlete versus non-contact sport athlete, that may see operative versus non-operative. Of course, that kind of injury would also depend on their position and parental and patient decisions as well. So I like to go through some cases here. I have 3 cases I want to talk about. Some of these are just youth sports, bread and butter. A couple other cases are kind of pitfalls that we need to watch out for when we're seeing these young athletes with shoulder pain. So this is case 1, 14-year-old baseball pitcher, right-hand dominant. Comes in with the typical right shoulder pain with throwing. There's been no trauma in his history. He's asymptomatic at rest, and it really just hurts when he's throwing. He denies any instability ever in his past. On examination, he has some weakness around the rotator cuff that's pretty generalized. He has some mild MDI. No impingement signs, no apprehension test is positive. And he has a little bit of mild scapular dyskinesia. But really his key on his examination is palpation. And he's really tender right over the proximal humerus. And then, of course, you get an x-ray of that shoulder. And of course, you're an astute clinician, so then you get an x-ray of the other shoulder because you want to compare side to side in this young thrower. And as you can see here, of course, looking at the left side versus the right side, you can see obvious widening of that proximal humeral physis. There's some irregularity and maybe some sclerosis there as well. So this is a classic case of your little league shoulder, or what we call proximal humeral epiphysitis. So this is a type of a stress fracture, if you will, through the proximal humeral physis. It does occur in those high-level pictures. You can see the age range there. It may look like a Salter 1 or a Salter 2 on initial films, but the exam is really a key. For those who are getting ready to recert their their sports exam or getting ready to take their board exam, one of the questions they ask is, why does this injury occur, or where does it occur in the throwing mechanics? It is due to rotational forces placed on the physis during the late cocking and early acceleration phases. So that's when they're getting all the way back and they're starting to come forward with their early acceleration. So that change in direction puts the most force on that proximal physis. So, of course, treatment for this in a more severe case may be 3 to 6 months out from throwing. Some of the mild cases, you may be able to get them back within 2 months or so, but it always involves rehab, not surgery, of course, and then a slow return back to throwing. We usually use interval throwing programs for these young athletes. We talk about pitch counts. We talk about the risk factors for recurrence of injury. Of course, those would be pain with pitching, any kind of decreased accuracy, and also fatigue. And the other thing is the interval throwing programs have some research backing them and has been shown to help decrease recurrence rates. So we really encourage you to use those. I do have these athletes switch into like a first base position if they can, and then just lob the throw back to the pitcher underhand, but no overhead throwing for them. And then you see this kid back 3 months later, repeated an x-ray, he's pain-free, x-ray looks great, PT's going well. You start talking about interval throwing programs. So that's more of your bread and butter case. I think this is probably the most important case I'll talk about today. This is a 13-year-old I saw about 5-6 years ago at Children's, and I've seen 2 of these cases now over the last 14 years. But I think it's really important to go through this. He was in dodgeball, he was in PE class. He's a right-hand dominant young man, so he's going back to throw the ball as hard as he could. And right as he's getting back into that late cocking place in his throwing phase, he has another young man come across from behind and grab the ball, the front of the ball, pulls the ball back right as he's going into his acceleration phase. And of course, he's trying to throw it as hard as he can, and he feels this pop. He hears the big pop, and he has really significant pain in the shoulder at rest and with attempting any type of internal or external rotation of the shoulder. His examination, there is some swelling. He has limited range of motion. I will say that he was seen by his primary care physician. He was sent to PT initially. About 2.5 weeks into the physical therapy, his therapist noticed that he had decreased internal rotation, or really couldn't do any internal rotation at all. So they sent him in to see us. And then on exam, he could not perform a liftoff test. His press belly test was really poor. Speeds test had significant pain, and he's really tender over that anterior shoulder bicipital groove. And so, of course, we ended up getting an MRI as soon as possible. X-rays were negative. I didn't include them all here, but they were all negative. And this is not his actual MRI. This was taken from the reference down here that you can see. But this is what his MRI looked like. And you can see that he has a complete avulsion of that subscapularis tendon off of that lesser tuberosity of the proximal humerus. And also you can see that his biceps tendon is completely dislocated medially out of that bicipital groove. And this would explain, of course, the pain that he's in, his exam, and also makes sense with the history. Now, of course, rotator cuff injuries are common as far as overuse in our young athletes, but full tears or avulsions are not that common. But this is a case where we see a full avulsion of that rotator cuff tendon. So early management is really important surgically for this kid. The diagnosis was a little delayed, but thankfully the PT caught on to the fact that he didn't have internal rotation, and then send him to see us. So I think the story here is make sure you're performing your special testing. If they're too painful initially in the clinic to get it, have them come back in a week and repeat it again. And if they're so painful they can't do the testing, then probably it's time to do an MRI. In the last case I'll go through here today, 15-year-old baseball catcher, right-hand dominant young man, reports some vague, deep shoulder pain. And he says it's been there for several months, probably 3-4 months. But he remembers this one episode about a month ago where he's trying to throw out a base runner that's going to second, and he feels this painful pop sensation in his shoulder. And then he reports weakness, easily fatigued in practices, his accuracy is all over the place. And he also reports at the end of the history, he has some continued clicking and popping, especially in the superior aspect of the shoulder. His examination is significant for some GERD. So as compared to the contralateral side, he has 15-degree difference in rotational arc. He's got a lot of pain over the bicipital groove. And your labral testing here, your speeds, crank, and O'Brien's test are all positive. And the other thing I was interesting to see is his apprehension test was also positive as well. X-rays were negative, and then MRI shows the classic slap tear. For these, if you look at some of the literature and online resources, non-operative management can be the first sign of treatment. And really you want to go after the GERD and address that. You want to make sure you're working on scapular dyskinesia and improving scapular stabilizers, and then eventually working out to the rotator cuff. And of course, core and hip strength is always important with any of these throwers. And then if that fails, or if it's a really high level pitcher with a type 2 tear, then that kid may end up going to surgery or may have surgery initially too. Some of this is obviously controversial, as you probably heard earlier today. I'm not going to go through all the types here. But key points with the slap tears for our young athletes, they're not very common. It's much more common to have a kid come in with proximal humeral epiphysitis if they're an adolescent. But if you do have a slap tear, risk factors for that include GERD, and also apprehension test is positive in 85% of these patients. So I think that was an interesting point that we should share with everybody. So try to keep it under 10 minutes. Dr. McCarty, thanks again for the invitation to speak today, and I'll move it forward to the next speaker.
Hey, Aaron, thank you much. I trust Aaron so much. When my kids, when they were younger, I had Aaron see them when they got hurt, and he did such a great job. Thanks, Aaron. Appreciate everything you do.
Thank you.
Great cases too. So, hey, next we're going to have Dr. Jason Dragoo. When Dr. Badal left a couple years ago, we had to search the country for a replacement, and we got the best guy that we could get, in a wonderful guy. Jason Dragoo came to us from Stanford. He is internationally known for his expertise in biologics. He currently is the Vice Chair of Academic Affairs for the Department of Orthopedics and the head team physician for the Denver Nuggets, and then he directs the Inverness Sports Medicine Center, which includes the CU Stephen Hawkins Clinic, and that's where he practices with many of our providers, and as well as the surgery center and the wonderful PT we have with there. So, Jason, man, I'm so glad to have you, and please tell us about the biologics and upper extremity.
Well, great. Thanks, Eric, for the introduction, and good afternoon, everyone. I know we're getting towards the end, and so what better time to chat about biologics in the upper extremity. And as we go through this, let's start maybe at the top, such as the rotator cuff, and work our way down to the elbow. As far as the rotator cuff is concerned, there's been a lot of attention and a lot of literature that really has been studying implant design and suture configuration, and that's getting to the optimization side of the fence. But quite contrast to that is biologic augmentation. There just hasn't been a lot of studies, and it may represent a good future area for improvement of our rotator cuff results. As far as biologics, you can divide them into groups if you would like. One are the growth factors, otherwise known as more of the PRP type of treatments. Tissue scaffolding is another one with regard to rotator cuff tear, and of course the cellular agents previously known as the stem cell therapy types of regimens. So let's go through it with the rotator cuff. And believe it or not, over 21 randomized controlled trials that have really looked at platelet-rich plasma as an adjunct to rotator cuff repair. Long story short, PRP just did not consistently hit the bar with regards to improvements in clinical outcomes or significantly lower the re-tear rate. For those of you who just love PRP and insist on using it in the rotator cuff, there are a couple of little things we can glean from the literature with regards to outcomes. First, PRP was more successful in the rotator cuff tears that were smaller or medium-sized. Also, the use of double row fixation tended to improve the PRP results. And then finally, really activating the PRP clots. That's either with calcium or thrombin, and injecting it right at the bone tendon interface tended to be the best application of PRP in the rotator cuff. This certainly begs the question, if growth factors aren't enough, are cells necessary to include in our rotator cuff repair? And I think biologically, this sounds plausible because the rotator cuff is often atrophic. I'll give you some evidence of that the local mesenchymal cells are somewhat displaced from the area of the rotator cuff tear. So there's very little cells that are available to direct the repair process. So one of the best steps forward as far as optimizing biology is just insertion site preparation. This has been termed many things in the literature, including bed abrasion, the crimson veil technique, or even local microfracture or microdrilling. Nonetheless, it creates bleeding bone, and with that, some cells, and it's the first step towards thinking biologically. If you want to see the data shows that if you break the studies up into groups that use marrow stimulation or microfracture-like preparation with rotator cuff repair versus rotator cuff alone, the site preparation side does better than rotator cuff alone. So plenty of literature to support your decision. But be careful of patients like this. The arrow is pointing to a patient here with an obvious full thickness rotator cuff tear, but look at the subchondral plate. You see that the line is broken, the subchondral area has edema, which has been shown to displace these mesenchymal cells that are necessary. So therefore, in a patient like this, bed abrasion may not be adequate to get adequate cellularity to the area. Instead, consider doing techniques such as microdrilling, going at least 7 millimeters down into the subchondral bone to really get the source of these cells, which are often displaced in situations like this. Well, here is the article on stem cell augmentation in rotator cuff repair. This has had its own little infamy here because of the results. So this is out of France. Philippe Hernigot, 45 patients in each group. This is matched with rotator cuff repair only and rotator cuff repair with augmentation using bone marrow cells. The great part of this article is that it's a 10-year follow-up, single surgeon doing both arms, and it shows really double the healing rate if you add cells to your rotator cuff repair. The downside to this article, it's the only thing that's out there. And so certainly we need more evidence before we widespread use the technique of adding cells to our rotator cuff repair. Nonetheless, it's a good start. I want to show you his technique because I think we can learn things from it.
Here's the technique again, out of France, showing him pumping in the bone marrow cells below the area of the rotator cuff tear. But look what happened when he took the needle out. All of the bone marrow aspirate just dispersed from that area underneath the rotator cuff tear. Instead, what can be done is, again, activating the bone marrow. So doing the same thing and adding calcium or thrombin to the mixture can create a gel-like formation of the bone marrow, therefore keeping it intact in between the interface of the rotator cuff and underlying bone. Nikhil Verma and Brian Cole are doing a follow-up study to Hernigau's. So they're about midway through this study, and just to tell you some interim results, they have not found double the healing rate, but they have found with the Sagaya score some more, let's just say, improvements in the rotator cuff repair thickness. So some small level of evidence to suggest that there's improvements, but stay tuned for their final results. In summary, there is some clinical evidence to support the augmentation of rotator cuff repair with cells, but additional randomized controlled trials will be required. And if the cells prove beneficial, they will likely need to be contained at the site of the repair. And I'll show you some techniques to possibly do this. Speaking of that, rotator cuff scaffold has reappeared on the radar. And these can be really used in two different types of conditions. First, augmentation of rotator cuff repair, in a sense, an overlying patch to improve the biomechanics. And I guess you can make some arguments that there can be some improvements in biology. Or interposition grafts, where there is a tensioned repair, so therefore you can lengthen the tendon with a graft, and that is more of an interpositional graft. Or you can use this graft in between two bony surfaces, such as a superior capsular reconstruction. In the future, we may have to redefine these interpositional grafts. You see, the lengthening of a tendon is likely to be an interpositional, let's just say, 1 graft, but we suggest that there can be an interpositional 2 graft, which is more of a sandwich in between the bone interface and the repaired tendon. If you use a sandwich graft, it would likely be solely to improve the local biology. So let's look at the literature. As far as the patch over the top of a tough repair, there's pretty good evidence to suggest that human allografts do pretty well in comparison to rotator cuff tears alone. And these are especially in tough rotator cuff repair situations. There's also a lot of literature to suggest that the xenografts don't do very well. And I bring that up today because there's been a resurgence in the xenograft and some recent data to suggest that they do well, which may be true with the new products. But I also wanted to point out that the literature suggests otherwise. And there has been many cases of erythema and drainage with the use of xenografts. So buyer beware, or I should say surgeon beware of xenografts in humans. Interpositional grafts, or detensioning the repairs, has shown also some level 3 success. So almost 60% rotator cuff repair and stability of the repair versus roughly half that with a tensioned repair. And also the according decreased re-tear rate with detensioning the repair. So there is some evidence of interpositional grafts also improving the local situation. But I think in summary, most rotator cuff surgeons feel that these scaffolds are appropriately in only clinically tough scenarios. And their routine use may be questioned. They're costly, inconsistently reimbursed from the insurance companies. There's lack of consistent literature and really unclear biologic benefit. What about the future? Is it possible that these interposition 2 grafts may be useful? Well, maybe, and here's how something could be designed, such as taking bone marrow cells, as Hernico did, soak them in a gel foam or collagen sponge, as you see on the screen, maybe even still doing a local repair site preparation in a bleeding bed of bone, and then place these interpositional grafts with the cells in between the interface of the bone and the scaffold, and then doing your standard repair. What about a few words on biology and muscle tears? Upper extremity, this would be pectoralis tears, especially at the musculotendinous junction, as well as bicep muscle tears. So this is not talking about tendon, which is largely surgical repairs on both. Well, pretty clear evidence to suggest that PRP just doesn't work very well in muscle tears. Matter of fact, more and more results throughout the United States show that injecting PRP into the muscle is not a good idea, with many reports of increasing pain as well as bony deposition within the muscle. We did some basic research on this to really show from a cellular perspective that this appears to be true. PRP did not activate any of the local muscle stem cells that are there naturally at the wound site, but platelet-poor plasma did. And you can see that circled all the way to the left, and you can see the muscle spindle cells that were recreated even in the laboratory with the addition of platelet-poor plasma. In an animal model, you see the bridging muscle that is across an injury, and that is in comparison to the PRP where you see the disordered scar tissue, which is likely to occur because it upregulates the proliferative side of muscle repair, which is not what we want in this situation. Here's some anecdotal results, and we're using this a lot, including with our NBA and professional players, the use of platelet-poor plasma approximately 2 weeks after their injury, then going through a standard rehab and pretty consistent results. Not necessarily a result of earlier return to play, but the consistent results are much improved look of their MRIs and the muscle planes. So instead of having the interposed scar tissue plane, instead you see that the muscle is just coursing through all the way to the tendon without the scar tissue zone. What about lateral epicondylitis? Well, believe it or not, more than 18 studies have been looked at with the use of PRP versus various other treatments in lateral epicondylitis. And in short summary, the leukocyte-rich type of PRP shows to be one of the best alternatives. If we look at the 3 largest randomized controlled trial, the largest is Alan Mishra's trial here, gives very representative results of the rest of the literature. First, we see that PRP does tend to have better results compared to corticosteroid injection or dry needling. However, if you also look at the literature, there's very little difference in between PRP and the injection of autologous blood. I say that because many of us have Medicaid clinics or patients that just can't afford PRP. So using dry needling and a little bit of autologous blood, at least per the literature, is not such a bad option. This is just a reminder slide of that PRP can be formulated in very different ways and that there's no such thing as just giving a PRP injection. Taking note that leukocyte-poor PRP is quite anti-inflammatory versus including the white cells is quite often inflammatory. And here's an up-to-date level 1 evidence chart of PRP. And you can see that the white blood cell poor PRP is beneficial in scenarios with inflammation versus the leukocyte-rich or inflammation-producing PRP is much better throughout the list of the tendinopathies. And you see lateral epicondylitis at the top of the list. What about the other common biologic therapies in the upper extremity, whether it be human adipose or bone marrow cells other than what we talked about in the rotator cuff area, or birth products such as amniotic fluid, no known significant applications as of yet in the upper extremity. So in summary, give biology that same attention that you've been given to your rotator cuff repairs and implants and surgical technique, and think about that local environment and attempt to optimize it when possible, as this may lead to improved healing rates and clinical outcomes in the future. So thank you very much, everyone. Have a great rest of the day, and thanks for having me, Eric.
Hey, Jason, great talk. I appreciate it, my man. You sure know a lot, and you actually do surgery too. So we can't forget that. And you're an excellent surgeon. So let us not fool ourselves. But thank you. All right, hey, we're getting on to our last two talks. Great topics coming up, and we'll have some questions at the end if you want, because we don't have any other talks after that, and we've caught up at least since we don't have anything after that. But Tom Noonan, all right, tell me why, if somebody has biceps tendonitis or some type of biceps pathology, that you can just cut it and let it fly.
All right, thanks, Eric. Yeah, so I'm going to talk about bicep release and why it's a very reasonable option for bicep problems in the shoulder. So, if you're looking at release versus tenodesis, what are the differences? What are the things we want to think about? So, in my mind, it would be deformity, 1, strength and function, 2, cramping, 3, and then complications. So let's take a look at each one of those. Deformity is kind of an easier one. It is more common with release. There have been numerous studies pointing that out. I've highlighted a couple studies, one in JSES and one in arthroscopy. And I would say, my personal opinion, I think probably that second study is what I tend to see, is that most of the time with a release, you will see some difference in the shape of the muscle. Couple caveats though, I would say, if you do a tenodesis and it fails, it looks really bad. Whereas usually with a bicep release, the deformity is much more subtle. Specifically, with rotator cuff repair, I think the deformity is often very subtle. Now, I will say that with my cuff repairs, I immobilize them 6 weeks. I don't start therapy. So I think it really gives that tendon some time to kind of scar down in the groove. So number 2, strength. And you might think, hey, release is going to be a lot weaker, but the data really doesn't show us that. No difference in elbow flexion strength. There's 3 different studies listed there. And maybe that's not so surprising, because I think, as Adam Seidel pointed out earlier, the brachialis is actually your prime elbow flexor. So we shouldn't maybe be so surprised about that. Supination, however, you might expect to see more of a problem with the bicep release. But again, you look at the data, and I think, Eric, you even had a study in here that I forgot to cite, but really no difference seen in forearm supination strength. There was one study, that last study on the slide, that showed kind of a mild loss of supination power, but I think that most of us probably wouldn't be able to perceive if we had 18% less supination power. Cramping, most people think that's higher with release. I kind of thought it would be higher with release because it's not attached to anything, but the data is interesting. The biggest studies have really shown no difference. This first study by Slenker, no difference between release and tenodesis. The second study here by Castrocini, interestingly, they had a higher incidence of cramping with tenodesis than with release. And so I think, in summary, you can at least say that the literature does not consistently report increased cramping with release. How about surgical complications? I would argue with a release, other than the complications that come along with a scope in and of itself, there effectively are no complications. The paper listed up top was in reference to subpectoral tenodesis. The numbers are small, I'll give you that, 0.3% wound infection, 0.3% musculocutaneous nerve injury. Humerus fracture would be if you use a tenodesis screw and a tunnel in the humerus. They're small, but they're real, and some of those are pretty bad complications, like the nerve injury. Now I want to point out one more study to you. This is a new one. This was in JSES this year. Good study. It was a systematic review and meta-analysis, and they basically looked at only randomized controlled trials that had minimum 12 months follow-up. So this is probably about the best we can do on this topic. Looking at the constant Murley score at 6 months and 12 months, had similar improvement, no differences between release and tenodesis. There was a difference at 2 years, but that difference was so small it was felt to be clinically insignificant. Second finding they saw was that tenotomy had a higher risk ratio of deformity, which again is no surprise based on similar studies presented. And then they saw no significant difference was detected in other functional outcomes, pain, elbow flexion, or forearm strength indices. So how do I do it? So pretty much any shoulder scope I do, I will tell somebody, look, we're going to look all over your shoulder. We may find a problem with your bicep, which could be a pain generator. If we do, we have two options. One, we can do a release. Most likely we'll have a deformity, although I tell most of the women, I think you would find it very subtle and hard to notice unless they're like super, super thin. You would have no difference in function or strength. If we're not doing something like a cuff repair, then you can come out of a sling right away, but I do have you hold off on bicep strengthening for 6 weeks. If we do a tenodesis, you'll have a more symmetric appearance. I think it is important to say more symmetric. I think you're setting yourself up for problems if you say it will look identical, because at least in my hands, you know, the tenodeses look good, but sometimes they do look subtly different. So I tell them you'll have a more symmetric appearance. Again, no difference in function, and I typically do keep them in a sling for a few weeks to let the tenodesis heal. So in my 20 years, I've done a lot of releases because, again, I explained to the patients, just like I showed you, here's the options. A lot of people pick releases. You know, I've had a very few people that have had cramping. I've had a couple that, you know, despite telling them it would look different, didn't like the way it appeared, but overall, patients have been very happy with that. I also do tenodesis as well. I probably am, I'd say 80-20, probably 80% release, 20% tenodesis. And I've done all different kinds of tenodeses, open, arthroscopic, groove, sub-pec. I currently do open sub-pec. I've had good results with that as well. I would tell you though, and I've seen this from other folks' patients as well as some of mine, pain following a tenodesis at the tenodesis site is rare. But very real, and the patients that get that, I've personally found very hard to treat. I don't think there's a good solution for that. So, you know, in summary, if cosmesis is important, I think a tenodesis is the way to go, although just like in this slide, I don't think if you do a release, it's like this before and after. Otherwise, I would recommend a release. I think it's an easier recovery, lower risk of complications, and again, no difference in strength. And if you need to tell a couple stories to your patients, you know, you always have the John Elway story, who did not have a surgical release. His traumatically released and all the shoulder pain went away. And then Brett Favre, in his right before that great season he had with the Vikings at the end of his career, had a bicep release performed by Jim Andrews and obviously did quite well. So that'll do it. Thanks very much.
Hey, thanks, Tom. Well, Rachel, your time for rebuttal. You know, why would we do a tenodesis instead of a release?
All right. 1 second. Just sharing my screen. All right, you guys can see that?
Yes, we can.
Okay. Well, again, thank you, Dr. McCarty, for the opportunity to talk. What a great symposium. Thanks to everyone for chatting and speaking, and Dr. Kelly, of course. And I'm going to spend the next 10 minutes telling you why Dr. Noonan is wrong about his opinion on tenotomy. Just kidding, just kidding. There's a good option for everyone. But really, tenodesis is the way to go. My disclosures are still listed online, and none are relevant to this talk. So, biceps tendon pathology is real. It can be inflammatory. It can be due to instability. It can be due to a slap tear or superior labral tear. This is an example of one of my patients who had a chronic biceps tendon rupture, and you can see a very bulbous end to his biceps tendon and then a ton of tenosynovitis and thickening just along the entire course of the biceps tendon, most of which cannot be viewed arthroscopically, which is when a lot of us tend to diagnose or not diagnose biceps problems. So a lot of potential problems with biceps tendon pathology. And on physical examination, we can see multiple things, including groove tenderness. Then there's a variety of special tests, and we've discussed those earlier today in the physical examination talks in terms of determining biceps-related pain. And it's often associated with other dysfunctional shoulder conditions, including cuff tears, slap tears, and arthritis. What is the function of the biceps tendon? Well, this is up for debate, not really in the scope of this talk, because we could go on for hours and days, and there's whole symposiums dedicated to the biceps tendon. EMG suggests a minimal role, and biomechanics suggest a role as a secondary stabilizer to the shoulder itself. And I think none of us really truly know what function the biceps has. as noted by Dr. Noonan, you can have no biceps tendon and still throw for a Super Bowl. And so we don't really know how much function this tendon provides for us. But what we do know is that it's a pain generator when it's pathologic. And so that's exactly what we see here. If you look at that, you wouldn't want that in your shoulder. That's a nasty looking biceps tendon. That's a biceps tendon that's causing a lot of pain and needs to be treated surgically in order to relieve that pain and for the vast majority of patients. We know that biceps pathology is common, and what's critical to understand is it's not always visualized arthroscopically. In this study published out of JSCS almost 2 decades ago, 200 patients were undergoing a simple subacromial decompression arthroscopically. 80% were known to have biceps pathology, but only half were seen arthroscopically. The rest was noted based on preoperative physical examination and imaging, and then noted once the biceps was taken out of the groove through an open approach. And so over half of the time, biceps pathology may not be visualized arthroscopically, and we can't really rely on that. So what is the treatment option for this? Either a tenotomy or a tenodesis. This is a tenotomy. This is how many of us do it, where we take an arthroscopic biter and we'll take the biceps off of the superior labrum attachment. You can use a radiofrequency device or a shaver or scissors or a variety of other options to do this, and you could just leave it. And the question is anything else indicated, like a tenodesis? And certainly, as Tom just mentioned, tenotomy is easy, it's fast, it's effective, it's safe and cheap, no implants, and really minimal problems with this, but not so fast, because, you know, that all sounds great, but really there are some potential downsides. And this is how some of my patients look at me when I tell them, yeah, I might cut your biceps and just leave it. And they look at me, even if I tell them the Brett Favre story or the John Elway story, and they look at me very skeptical like this. And so factors that impact decision-making include patient's age, their activity level. Are they a work-related injury patient? Do they have chronic symptoms? How extensive are those symptoms? And what other concomitant pathology, like a rotator cuff tear, do we have? And then certainly arm size and anatomy is relevant here. This patient's bicep is different than this patient's bicep. And so we have to be cognizant of our patient's anatomy and really tailor the treatment to the patient. Tenotomy would suggest, or the literature would suggest, that tenotomy is safe and effective, but there is a relatively high complication rate. When you look at this paper shows a 13.3% complication rate in 30 shoulders. That is not insignificant for a procedure that should be, quote unquote, very simple and easy. So while not all these complications are major, they're still there. And so that's something we do have to disclose to the patients. And that's higher, I think, than many of us think. What about cosmesis and patient acceptance of how it looks? Well, when you look at these two studies, some patients care, some patients don't care, but really no difference if they get a tenodesis versus a tenotomy. But there are patients who have deformity and cramping, up to 20% of cramping after a tenotomy. And so it's important to counsel your patients that that is a risk that we don't really see with tenodesis. And then when we look at functional outcomes, we can see in this paper published out of HSS, and we can see that 70% of patients in the 54 patients that had a tenotomy had a Popeye sign. Now, this doesn't bother everyone, so there's a difference between having the problem, having the cosmetic deformity, and really having symptoms from it. But still, this is a pretty significant number and something we need to be counseling our patients. And I think if patients knew these numbers, they may choose to have tenotomy less and less simply due to the cosmetic effect. And certainly there is some fatigue discomfort or cramping in this tenotomy patient population. What about when we compare tenotomy to tenodesis? Well, this is a tough comparison because not every tenodesis is created equal. And so when you look at the literature, it's hard to compare tenotomy to tenodesis because tenodesis can be performed arthroscopically. It can be performed through a mini open approach. There's a variety of different ways to do it. So we're not always comparing apples to oranges, or apples to apples here, I should say. But when you do look at the literature and you look at all comers, this was a systematic review of 19 studies, only one of which was a randomized controlled trial. The rest, or the vast majority of which were level 4 studies. The authors concluded there's a lack of strong evidence to advocate for one technique over another in terms of tenotomy versus tenodesis. This was a study published out of the Rothman Institute, another systematic review, again, mostly level 4 studies. And it showed that in patients who undergo tenotomy versus tenodesis, all of them really have good outcomes, but better outcomes in the tenodesis group and significantly more Popeye signs in the tenotomy group, as one might expect. And that's important because it's important to be able to counsel your patients on the potential downside. And I would note that the patients, when we compare outcomes that had superior outcomes with tenodesis, those were in patients undergoing concomitant rotator cuff treatment. When we were just looking at all comers, whether they had concomitant rotator cuff treatment or not, tenotomy versus tenodesis results were actually very similar. And they concluded that the only major difference between these two treatment outcomes was the cosmetic deformity that's associated with tenotomy alone, and patient-specific factors should guide the surgeon. So are there downsides to tenodesis? Well, certainly cost if you're using an implant, and potential complications of adding a procedure. And complications are rare. And again, the tenotomy had a 13.3% complication rate in that one study that I mentioned. Complications after subpectoral biceps tenodesis have been examined by the Rush group and by my mentor who taught me how to do this procedure, Tony Romeo. And while complication rates are low, 2%, they can be devastating, including in very rare but devastating cases, neurovascular compromise and proximal humerus fracture. And so that can be problematic. And certainly we would hate to get an infection in this part of the shoulder, which is right near the axilla, and could be impacted by P. acnes or now C. acnes. There's been a report of several cases of neurovascular injury, brachial plexus injury, and so we've got to be careful with that as well. I think using good technique and understanding your anatomy can hopefully avoid this, but even in expert hands, this can happen. The bottom line for me in my practice, and I think for many of us, we cannot recommend tenotomy for patients who have good athletic aspirations and pursuits, except in very rare instances. And we've discussed a couple of professional football players, including one who did have a surgical tenotomy. Absolutely anyone who's concerned about cosmetic appearance, we cannot safely predict how a patient's going to feel about a deformity that's quote unquote caused by their surgeon. So they come in with pain and they come out with a deformity, and you're the only one that intervened. Some patients will blame the surgeon, even if you document, even if you've had extensive conversations about the potential for cosmetic deformity. Once they see it, they may not feel as strongly as they did in the preoperative discussion, and they may blame you as the surgeon for causing their cosmetic defect, for causing that cosmetic Popeye sign. And then finally, in workers' compensation cases, we don't really want to give the patients any reason to have continued pain or keep their case open. We want to treat any potential cause of pain. And in some cases, the cosmetic deformity may lead the patient to continue to experience pain. So what I ask are I put up these 4 doctors as our group of surgeons and physicians here who spoke in this session. I would ask each of you, Dr. McCarty, Dr. Noonan, Dr. Drew, Dr. Provence, what would you prefer? And I think the answer is clear. We'd all like to have that biceps in the gentleman with the black shirt as opposed to the one with the white shirt. We'd all like to have a nice contour of our biceps tendon after a biceps tendon surgery. And so therefore, I would strongly encourage tenodesis over tenotomy in the vast majority of patients. Thank you all very much.
Hey,
This
Rachel.
looks like Dr. McCarty.
Great. Yeah, great. You like the Popeye on that? That was mine, I'm sure. Yeah, that was a great talk, Rachel. We got a couple minutes to talk. We got some of the physicians on still. We got John Brabin, Aaron Provence, Tom Noonan. We'll just take a couple minutes. If anybody has any questions, they want to put it up around biceps or any of those topics that we just heard about, we're free to talk about it. I think, Tom, it's a very interesting discussion regarding the biceps because, I think it's very important to have the discussion with the patient ahead of time. I think the most unhappiest patient I've ever had was the patient that the biceps was bad. We did not have a discussion beforehand. I released the biceps, and he was very upset that we released it. He felt better, but he didn't like how it looked. We didn't have that discussion. And I think regardless of whether it's a tenodesis or tenotomy, the discussion is very good to have ahead of time, and then give them that choice. And some people would be very upset if you did a tenodesis, or some people upset if you did a tenotomy without them their consent. But I know you talked about your discussion with them ahead of time, and I think that's really a key thing.
Yeah, and I don't disagree at all with anything Rachel said. I mean, if somebody gives me the look like that dog gave her in her talk, I go tenodesis. I mean, if they're very comfortable with release and understand it, I don't have a problem doing release. But if they start waffling and I don't know what's going to look like, I usually tell them, let's just do a tenodesis, because I totally agree with you. In fact, you want to hear a funny story? So I recently had a guy, he's in his 50s, works out a lot, had really bad looking bicep and MRI. We tried all kinds of non-op treatment. We go to surgery. So pre-op, we say, okay, we're going to do scope, check it out, bicep tenodesis. So literally, and I'm guilty because I think the last few times I saw him in clinic, I didn't have him take his shirt off. We just cut it a quick exam. And so I'm in pre-op, and he's going to sign a consent. I look, I'm like, Ed, your bicep is already torn. And he said, oh, I had no injury. I mean, clearly he must have ruptured his bicep like months before. And so I said, and he goes, gosh, he goes, I didn't even notice it. And I said, well, we can just do the scope if you want. I'll try and fish it out and reattach. He goes, no, it doesn't bother me at all. So we do a scope. He had an upper border subscap tear, fix that. And so he calls me the other night and he's like, hey, I was looking at my bicep. He's obsessing over this thing now, even though pre-op it was already torn. But it's hilarious because I knew he was like a tenodesis guy, and I offered to do it. But then, and he's fine, he's not mad. But it was kind of hilarious that we had this whole discussion pre-op, and he's like, no, doesn't bother me, leave it. And he goes, yeah, I think I can tell a difference how it looks. And I showed my wife, but she couldn't tell a difference. And it's just funny with this whole topic. So I think the bottom line is you want to have a happy patient, and you explain to them the options, to the best of your ability, the pros and cons, and then help guide them to the best decision.
So one point though, and I think is interesting maybe to get your guys' perspective on, but a failed tenodesis is different than a tenotomy.
Totally agree.
So, whenever we do a subpec tenodesis, like, I don't know about you guys, but I've got to pull pretty hard to like pull the vincula and, all the little synovial attachments, right? Because that's an intra-articular structure. And so there's like a seal that's holding that tendon. And I think that's why a lot of tenotomies do fine if it's a superior capsule or superior, labrum issue or a tendonitis issue or whatever, that may be relieving that tension, or if it's like a stenosing tenosynovitis, right? It's like a trigger finger release. But a failed tenodesis is not the same as a tenotomy, and that's never really been studied. It may be worth actually studying in a group of our patients because, you ask who would do what, and like Rachel, a good friend of both yours and mine, has a failed tenodesis, and he would tell you that he would never do that again. He rather would have just had a tenotomy. And it's interesting, but I don't think those are equivalent. I think that's an important point.
That's a good point, JB. Well, Rachel put it up there. We got our surgeons on, and we got Dr. Provence on. Why don't we? What would you do for your if it was your biceps, Rachel? What would you do?
I mean, this one right there. You can barely see it. So I would do a tenodesis subpec, and I would ask the surgeon to use a very small suture anchor, 1 or 2, to minimize fracture risk.
Okay. How about you, Tom Noonan?
I'm gonna do a release, Eric.
Okay. All right. How about you, Aaron Provence?
I was on the fence there for a while, but the last couple slides from Rachel, I think I'm going to go with tenodesis. Now, my biceps not as big as yours, DMAC, but I think I'd still go with cosmesis.
Hey, JB, what would you do?
I think I'd have a subpec tenodesis. I think function is important.
And I've told people this before, but I would have the release. So I would go ahead with it. I don't want to be in a sling. Let it go. I think I'll be fine. So Tom, I'm with you. Even though, Tom, it's interesting. I think it's the way that you talk to patients, not you, but us in general, how we talk to patients. Because my release are about 10% release and 90% tenodesis. So, I think it's how you talk to them, and I don't think it's that much of a different population. It's just, it probably is how it comes across. And I'm probably selling more of the tenodesis, and you're probably selling more of the release. And, we could probably flip it, and it'd be interesting to see if you turned how you talk to him and I turned it a little bit, how we could reverse that bit. I bet that's a lot of it. It's very interesting.
Yeah, for sure.
Hey, Aaron, I love your cases. I think the subscap is really interesting because that's an easy one to miss. And I've had several kids that have come through the same way. That involves around the biceps, but it's not the biceps. When you've seen those kids, how much of those kids end up having, biceps pathology, or even without the subscap? Because, you said it was tender around there. What's your take on maybe not that case, but the biceps in general in kids?
So in those cases, though, where I see the subscap avulsion, both of those cases, I've seen the long head of the biceps tendon dislocated medially. So I haven't seen an isolated subscap avulsion without biceps involvement. I don't know if you've seen that at all, EMAC, or not, but that's the two cases I've seen. As far as biceps injury and upper proximal biceps injuries, we see those quite often, and of course we're always looking for a slap tear, but we don't see as many slap tears in the kids. But we see a lot of proximal biceps tenosynovitis.
I've and Tom, you've been around, JB around, Rachel not around as much, but we've seen some of these younger athletes that have some true recalcitrant tenosynovitis, and I've tenodiced some younger athletes, 15, 16-year-olds, and they've done very well. But usually what I'll do, and we didn't talk about that much, but I'll have them do for sure try needling, try therapy, maybe an ultrasound guided injection. And sometimes they'll get relief, but then if it comes back and we just can't get on top of it, we'll do something. Tom, what's your take on that kind of scenario and that patient? What's your experience been
with a younger kid?
Yeah, younger kid.
Yeah, I mean, I would, I don't like slap repairs, but I mean, a young throwing athlete, I would still consider it if we've exhausted everything else. If it came down to doing something on a younger patient, I probably would steer them more tenodesis. Although I had an interesting, it was probably a 16-year-old girl that somebody done a slap repair and did horrible. I got stiff, and so we were going to go and do capsular release and do something with the bicep, and she insisted on a release. I even tried to steer her into a tenodesis. She did great. But like Rachel presented, I think probably the younger, more athletic ones, I mean, they tend to choose tenodesis anyway, which is fine.
Hey, Emek, we had a question from the audience here.
So I'm going to ask you because you're going to be asked. So, and we'll throw JB in there too. I saw this. So this is addressed to Dr. Frank Noonan, but also I'm going to ask Dr. Barabman. So what about age of the patient, concomitant surgery, like a massive cuff in greater than 70 years old? All right. So Rachel, would you tenodese or release that?
So I think a lot depends on the chronologic age, or less than the chronologic, more on the physiologic age of the patient. So I've had some 70-year-olds that really look like 50-year-olds, and in those cases, if I'm going in to fix the cuff, most often those patients want the tenodesis. I always offer. I say I can cut it and leave it, or I can cut it and fix it. And these are the pros and cons. And probably like you, Emak, I probably steer them more toward the tenodesis option as opposed to the tenotomy, but I always let them pick. But to me, the age of a patient doesn't impact most of what I do ever. If it's a true kind of physiologic 70-year-old, then I'm starting to question, am I even supposed to be doing the cuff, regardless of the biceps? And I start thinking about cuff quality and is this better for a reverse? And we start getting into that discussion in terms of the surgical indications in general. But I don't let the age of the patient necessarily deter me from doing a tenodesis. If they've got a fluffy arm, so to speak, so kind of the opposite of a muscular arm, but a more fluffy arm, and I'm doing, a rotator cuff repair, and that's often in kind of that older female patient, those I often recommend a tenotomy, because I don't think even if they have a cosmetic deformity, they're gonna notice it. But if they're one of those muscular males or females, even at 70, and I'm indicating them for a cuff, I'm okay doing the tenodesis and often do it. And I still use the same technique. I'll do a subpec. And lastly, the last thing I'll add to that is there's been some recent discussion, although it's not a recent technique, for using the biceps to help with massive cuff repairs, almost as like an SCR, or superior capsular reconstruction, or something like that. So that's an option too, in terms of using the biceps tendon to help you augment your cuff repair. I haven't done that, but that I think is in the toolbox.
I think I know what your answer is, Tom. What would be your answer to that, release or tenodesis?
Yeah, I mean, again, you have the discussion. I would probably steer more towards release. The other thing I would tell you, I mean, which I'm sure you have experienced, like over 70 with a large cuff tear, that bicep is usually really thickened, and sometimes you cut it and the tendon's like sticking up out of the groove like 2 centimeters. You literally have to go resect part of it because I'm worried it'll impinge in the joint. So I don't think that patient will get any deformity because unless you open subpec and yank the thing out of the groove, it's just kind of stuck in there anyway. So in that case, I think a release would be just fine.
Yeah, that's a good point. John Brobman, what's your take on that?
Yeah, like Rachel, I think I lean a little more towards Rachel's approach. You know, I agree with all sentiments, though. I mean, I've encountered both of those, and I have done the tenodesis without tenotomy technique. So if it's a cuff at risk, if it's someone that, you know, does not want or is not appropriate for reverse or tendon transfers, maybe tenuous cuff tissue or a bigger cuff tear that's not as mobile as we thought, regardless of the, I mean, if it's thrash, then I think it has to go and you got to take it out of the groove, especially if it's a source of preoperative pain. So I think, you know, something like we're working on with the buff score and how much the bicep is symptomatic in the groove preoperatively may be a predictor, and no research I know of has looked at that as far as a predictor of outcome. But if it looks okay and I need an augment, I have tenodesed it high in the groove and not cut it and used it as an in situ SCR, or essentially like an interval reconstruction. But if it's perfectly normal, they have great tissue, especially if it's like a traumatic cuff, I leave it perfectly alone if it were fine. I don't think it mandates being treated just because you're there. I think it's based on all these other things that you guys have already touched on.
These are great. Hey, Aaron, you got any last comments on words of wisdom with your kids? Doesn't have to be about the biceps. Anything you'd like to add?
No, I think the biggest point for me was make sure you get those special tests in, especially that lift off test and the press belly test, and be always looking for that subscap avulsion. Yeah,
that's exactly right. Hey, man, thanks for all the speakers and for everything today. Thank you, Ellen, for your wonderful coordination of all this. Everybody took time out of their day. We had at one point more than 300 people had signed up. There's going to be some people watching this. Everybody's welcome to get on at a later time to catch on some things. We did have Ellen Shanley email us back, and Ellen Bagwell has her presentations on PDF, and Ellen, and as well as all the speakers, are very happy to answer any questions that you might have. I think Ellen has all of our emails. There'll be some correspondence going out. Please fill out the evaluations. It's really important for us. This was an unusual year, so it's not our normal symposium, but we had some great topics, some great interaction with the docs and the physical therapists, and I wish we were together, but know we're together in heart. And thank you for joining us on this September 11th, 2020. Let's remember those Americans that died on September 11th, and you know, let's be very thankful for what we've got coming ahead as we get out of this COVID and look forward to what's ahead. And thank you. We look forward to next year, September 10th, 2021, and have a great day.